will also come, but we'll start the talks now. The first talk is by Dr. Sridhar Reddy. He will be talking on pediatric transplantation, the preparation, the nephrology aspect of it. Dr. Sridhar Reddy is a nephrologist here since last 10 years. Before this, he was in Care Hospital. He's an extremely dynamic nephrologist and very good in pediatric nephrology. His field of interest is pediatric nephrology. I think with his talk we will learn a lot. And the surgical aspect, we all know Dr. Kashinadam. He is a consultant urologist and renal transplant surgeon at Yashoda Melakpet, and recently has done a lot of pediatric transplant as well. To chair this session, I have with me Dr. Upendra. You also please join as chairperson. Dr. Upendra is a consultant urologist in this hospital for a very long time. First, I would like to welcome Dr. Sridhar Reddy to please start his talk. Sir, Jagdish sir, please welcoming you, and Dr. Ramraj sir, welcome you. Dr. Taif, Dr. Surya Prakash, thank you very much for coming.
Awesome.
Good afternoon, everybody. I thank Dr. Gopichand, my dear friend, who's a senior consultant urologist at this hospital. And I thank him for giving me an opportunity to share a little small overview of pediatric transplantation. Respected chairpersons, Dr. V.S. Reddy sir, Dr. Murthy sir, and Dr. Upendra. As we all know, pediatric urology and pediatric nephrology have made a big stride over the last 3 decades, and pediatric nephrology in delivering care over 3 decades have become a state of art over many centers, but biggest problem is availability of resources and the technical difficulties and exponential costs involved. So if we look at the common etiologies of the end-stage kidney disease in children and percentage of incident diseases on the right-hand side, the first 3 ones constitute more than 60% of all the causes that are causative of the end-stage kidney disease in children. Predominantly, it is either cystic or hereditary causes, especially the hypoplastic kidneys. They include nephronophthisis bilaterally, and a polycystic or a autosomal recessive diseases and severe forms of Alport syndrome. And inclusive within this group is PUJ obstruction or a UV junction obstruction, subsequently leading on to chronic interstitial subset of diseases and then causing progressive kidney dysfunction, causing CKD stage 4 and 5 ultimately. And second subset is parenchymal illnesses, which are cause of progressive kidney dysfunction, that is either glomerulonephritis, that is especially FSGS. The most malignant forms are the familial forms. The third one would be secondary glomerular involvement. That means It's a part of systemic involvement, like a part of either SLE or HUS. Of late, HUS has been becoming more and more common, with detection being the concern being more awareness amongst the medical fraternity. And lastly, few of very small things include neoplasms or tumors, or very rarely acute tubular necrosis with no particular cause, very rarely, especially acute cortical necrosis secondary to acute pancreatitis in children. So after seeing the common etiologies of chronic kidney disease, this is how we stage the CKDs from stage 1 to stage 5. Stage 1 with milder forms of illness progressing to 4 and 5, which are advanced stages of chronic kidney diseases. As we see, I have not included the anatomical disturbances here. It's only about the GFR concerns which I have shown. The more advanced it is, the higher number it has, that is 4 and 5. Any GFR less than 30 are labeled as very advanced stages of chronic kidney disease. Although our impetus as primary care nephrologists would be to identify someone at a very early stage and treat them early so that they don't progress to advanced stages rapidly. So this is when we think about CKD 4 or CKD 5, is when we think about the broad umbrella of what we call as renal replacement therapy. Under renal replacement therapy, we have transplantation, hemodialysis, or peritoneal dialysis. One of the three forms we have to start offering them at CKD stage 5, but the indications have started becoming more and more broader, more and more faster, and now we have started offering them even at later stages of CKD 4, simply because of improving their metabolic parameters and their growth. Specifically here we mention what is called as preemptive renal transplantation, especially in children who are deemed fit. Preemptive transplantation is something which we define as someone who undergoes a transplantation even without dialysis. And we offer them at GFR as much as 15 to 20. The advantage being the metabolic parameters and the growth is optimal compared to the delayed transplantation. So these are the options of renal replacement therapy. Either we can offer hemodialysis or peritoneal dialysis or transplantation. And in many situations, because of many reasons, we always use one of the modalities of dialysis, either hemodialysis or peritoneal dialysis, preferably peritoneal dialysis in kids, which we use them as a bridge for offering them kidney transplantation. The advantage of using peritoneal dialysis over hemodialysis is multifold. One is it is more easier and softer on the baby in terms of hemodynamic status. Nutrition is better because they don't lose too many nutrients during dialysis. Second thing is the PD fluid itself supplements nutrition. Third thing, they also create a space for further transplantation if space is a concern, if we have to engraft a organ. And it can be done at home. It is more friendly, less painful compared to hemodialysis. Therefore, peritoneal dialysis is offered in the first place for many of the kids who are motivated, who have a motivated family. And wherever we don't find it easy to do peritoneal dialysis, we always offer them hemodialysis with a tunneled catheter, then switching over to AV fistula, which is not very easy. But then as a desperate measure, we do offer it. And then offer them thrice a week maintenance hemodialysis at home. Once they are fit, once they are nutritionally stable, once we have their anatomical space, after assessment of their physical, psychological, biological aspects and financial aspects of the family, we always counsel them. Subsequently, at some time, we always prepare them for a transplant. The options of transplant are multiple. We have multiple choices, and in this we have either a living donor transplantation or a deceased kidney donor transplantation. And whenever we do a organ transplant from a brain death organ, and in Telangana, as we are all aware, Jeevandan is quite an active program. The brain being the government of Telangana, which is very supportive. We do have quite a lot of transplants being done under deceased donation, and especially if we have a age match criteria for children and who are listed for this program, they automatically get priority basis. So these are a few other options of living donor transplantation. One is ABO compatible transplant. We always consider only a living related kidney transplants, and parents, siblings and their children who are majors are the ones who are eligible. We don't do what is called as living emotionally related donors, that is altruistic donation. We don't do as much as we do living related donation. There is another option called as ABO incompatible transplant. Same thing we do, we categorize them as living related and altruistic donors. And there is what is called as paired exchange, that is swap exchange. That means a set of A and B will give the organ to set of C and D, and it is interchanged depending on their blood group compatibility. So brief word about renal transplant surgery. Dr. Kashinath will be dealing in greater detail. The donor nephrectomy can be done in open nephrectomy, laparoscopic and robotic assisted nephrectomy, although one of the first two options are commonly performed. And in transplant renal recipient surgeries, open surgery, especially in the retroperitoneal space, is something which is done most commonly, and we don't do in laparoscopic anastomosis in kids. So the finer details Dr. Kashinath will handle. And these are most of the benefits of kidney transplantation, like freedom from dialysis. There is more strength and ability to engage in more physically active lifestyle. They are more free to have what they want to eat, because kids would like to have all the things with not much restrictions. There is improvement in their anemia and metabolic parameters. There is lesser progression of neuropathy, and there is better physical and emotional well-being. So coming to a little bit of details about challenges of transplantation in kids, we divide them in few of multiple subheadings. That would be technical, that is surgical aspects. The other thing will be medical aspects, and then donor supply and the costs. So these are the factors that would affect the outcomes in children. One is recipient age. The little elderly they have, or if they are way too young, it becomes very difficult to transplant them, simply because it's very challenging for surgical techniques. The vessels are way too small. There is not much space to keep the graft in the kidney, and very difficult to manage their immunosuppression medically. But most importantly, the challenge is surgical. So these are the very important factors which dictate the outcome of the kidney transplant. One is immunologic factors, metabolic and technical factors. In the immunological factors, the kids are more reactive immunologically. That means they have very higher propensity for acute rejection, and whenever they have they have more chances for subclinical rejection consistently, because a bigger organ is always transplanted compared to the smaller organ, and therefore the rise in creatinine is does not dictate subclinical rejection. So we need to be very open, and any small rise in the baseline rise from the baseline creatinine is considered to be very significant, and there should be no delay in diagnosing a subclinical rejection. And therefore many centers nowadays perform what is called as protocol biopsies in children, so that they do these kidney biopsies at set period of time and detect any early rejections, so that the management is taken, the decision is taken early. These are the metabolic parameters because of which we may have certain rejections, because there is limited or impaired absorption because of the small surface area of the small intestine, and the metabolization of drugs, especially the calcineurin inhibitors, happen more rapidly compared to adults, and therefore it is very difficult to reach a trough level, and therefore many a times we might have to do a more frequent dosing compared to 12th hourly dosing. So that is one of the bigger challenges. And the technical challenges for a transplant include a small vessel size, that means they have more incidence for graft thrombosis, a longer operating time, that is the reason they may have higher incidences of acute tubular necrosis, and to accommodate a large kidney in a small child can be very challenging. So these are few studies which shows the long-term data, and the current overall half-life of transplant kidney in Western countries is about 2 decades now. That means half-life of a kidney means at the end of particular time period, 50% of the transplanted kidneys survive. That means at the end of 2 decades, we have 50%, which is a functioning graft. So these are one of the studies which was published in 2003, where 217 kids were studied, and it was concluded that there was a high retransplantation rate and there was a presence of significant morbidity, although kidney transplantation in children led to attainment of a productive and a satisfying life with a high degree of rehabilitation in the adulthood. There were certain kids who received 2 or 3 organs in their over a period of time. But because of the extreme difficulty in the availability of donor organs, it remains a big challenge to offer so many graft organs to a single person. So the growth and puberty was much better compared to being on dialysis, and the factors that affected their growth were the younger the transplant, they grew better, and corticosteroid all had a significant effect on blunting their growth because of the hormonal imbalance. So there was improvement in nutrition, especially in minimal or no steroid dosage, but we don't do any of these steroid minimization or steroid avoidance protocols because chance of rejection is very high, and the biologics used will be very high. And to improve their growth hormone can be used till their epiphyseal plates are fused, and it can be offered once in every week dosing subcutaneously, but unfortunately it turns out to be very, very expensive, to a tune of around 20,000 rupees every month. So that becomes a very expensive proposition. This was one of the studies which was published in India. Out of 39 kidney transplant recipients in age group between 10 and 17 years, there was a 1-year graft survival which was comparable to Western data, but it was suboptimal after few years down the line. And the most important thing was financial constraints, which was a major limiting factor in the use of medication. So in India, the majority of the challenges include a delayed referral, prohibitive cost of immunosuppressive therapy, and very limited number of transplantation centers providing pediatric transplantation. And before summary, there are a few pearls which I would want to express during evaluation for any of the pediatric transplants in kids. Medical evaluation always includes, first and foremost thing, the lower urinary tract, which needs to be evaluated thoroughly. Any history of recurrent urinary tracts or any disturbances in their urine, we always have to make sure that we have done a micturating cystourethrogram, followed by, if need be, MRI of the lumbosacral spine and urodynamic studies. After doing that, always make sure, depending on their history and physical examination, we always define what is the probable parenchymal cause if there is any clue. Always make sure we rule out systemic disorders, especially oxalosis, atypical HUS are red flags. Make sure we always rule it out, simply because an isolated kidney transplantation is contraindication in both of these. Only a small subset of atypical hemolytic uremic syndromes can be done, but generally any genetic causes needs full thorough evaluation prior to taking a decision of doing a isolated kidney transplantation. FSGS is one more illness which needs thorough evaluation. After a detailed evaluation is when we offer a living donation, because the recurrence of the primary illness is very high, and we would also lose the transplanted kidney. Once we are very sure about the native kidney disease is when we take the decision. And whenever we always involve the urology team, and we always have a multidisciplinary meetings prior to taking the decisions of transplanting a baby. So to summarize, renal replacement therapy in pediatric chronic kidney disease, in advanced pediatric chronic kidney disease, includes peritoneal dialysis, hemodialysis, and these are used as a bridge to kidney transplantation till they grow adequately. And transplant offers the best outcome compared to dialytic support. Both short-term and long-term outcomes are over a period of time improving with improvement in the nutrition and the availability of better immunosuppressive medication. And with a dedicated team, both forms of dialysis can be performed, but it's always used as a bridge. And one of the major limiting factor is the cost. So, and I always emphasize, all this is a team effort from nursing staff to dialysis technicians to care providers to psychosocial workers to urologists and nephrologists and post-transplant care. And first and foremost, the family should be very, very motivated. Thank you for patient listening. If you have any questions, we can take.
At what age, or do you estimate GFR, or based on kidney size, or based on age?
Yeah, first and foremost thing, I think it's with the size of the donor and the recipient. That mandates whether we use a single organ or we use a dual organ. Suppose if the donor is way too young and the recipient is hefty and a little elderly, then we take a decision that we do a dual organ transplant.
Is there a cutoff for donor age where you think you need to put two kidneys? Too small? Too small is, how small is too small?
Yeah, I think it's a very there's no objective evidence per se, but it all depends on the size of the vessel and then size of the organ. I think surgical decision is what would be more important. I think anything less than 10 years in a reasonably well-grown Indian child, we can do a split transplant, split organ. Lesser than 10 years, I think dual organ transplant would be.
Why I'm asking is recently we had a 12 years boy brain dead, and we were in dilemma. They were a little marginal then, whether put 2 kidneys or 1 kidney. Obviously the recipient was little obese, so then we ended up in putting both the kidneys in the recipient.
Yeah, I think it has to be taken both into consideration. And suppose if someone gets benefit of doubt with 2 kidneys, and that child would be more luckier, I would say. Yeah, a little heftier kid, although not very common in a child who's on dialysis. They're not so very nutritionally very well preserved, unless their primary illness is some kind of a syndrome where they have obesity along with a kidney disease.
Another thing is there a difference in the induction between pediatric and adult transplant?
There's, in terms of medications used, there's no change, although the dose used is slightly higher for a pediatric age group, not with at least thymoglobulin, but CNIs and mycophenolate, we tend to use a higher dose.
Steroids you continue same, because as you said, the steroids again not good for children.
Yes, sir. Yeah. But having said that, we keep as minimal as possible compared to the adults.
Okay, thank you.
Thank you, Sridhar. Nice presentation.
Yes.
Do we monitor microphenolate levels? So centers have monitoring.
We are not monitoring mycophenolate level as of now, sir, simply because mycophenolic acid does not really correlate with the amount of milligram per kg dosing whatever we give. And second thing is, it's mostly a clinical decision because intolerance is more commonly seen rather than under immunosuppression. So we don't do mycophenolate levels as of now.
So what is your experience with the FSGS operated patients, children? What is their maximum graft survival?
Yeah, it could be only very anecdotal, sir, especially with FSGS. In the primary illness, if they have very rapidly progressive illness in the primary patient, and if they have a strong family history of FSGS, then the only option left for us would be a deceased donor. We will not do a living donor there because the chances of recurrence is very high. So about if there is a strong family history and if this child has had a very rapid course, then maybe around 30% would have had a recurrence. At that time, then we might have to do plasmapheresis before and or immediately after transplant. But they are all very anecdotal.
Thank you.
Yeah.
Both aged below 20 years and they had recurrence within the first week. So after plasmapheresis, they are doing good.
Thank you, Sridhar.
Yes,
We will go to the
welcome.
next topic.
Yeah. Thanks,
Asu,
everyone. Thank
We
you.
will be talking on technical aspects of pediatric transplant.
Starting my presentation, I just want to talk about the relation between the urologist and nephrologist. The relation between the urologist and nephrologist is like husband and wife. If you have good relation, your results will be good. So you have to choose whether you want to be husband or wife. That's up to you. Always wife wins, nephrologist wins, so we can consider them as wife. Why urology has still crazy? Because we can deal with bowels, we can deal with gynecologists, we can deal with vascular surgeons. And at the same time, we are at risk. We are losing pediatrics and transplants. Now we are, as Gopi has started this initiative, We are very happy that we are going to grab again pediatrics and urology, and Mallikarjun sir is there. He is going to continue his pediatric work so that no one can take over these departments from urology. Thank you. Coming to presentation, there are two aspects in pediatric transplant. One is pediatric donor, one is pediatric recipient. I'm mostly talking about pediatric recipient. Children are not just miniature of an adult. We cannot just cut off dose or 1/4 dose or do just surgery like that an adult. So it is a different spectrum of disease. We should have more experience. I think after doing many transplants only, we can deal with pediatric transplant. Regarding coming to the, as nephrologist has decided and GFR, a surgeon will divide the pediatrics into according to his age. We can consider a child with less than 15 kg, 15 to 30 kg, and more than 30 kg. If this patient is more than 30 kg, is a bit easy to do surgery. If it is less than 15 kg, we are going to have more problems, technical issues. What are the problems in pediatrics? They have poor liver maturation, especially in children. Liver is not well matured to deal with the drugs what we give. And compared with anesthetists also have very much problems during intubation and all the things. They should have an idea of the anatomy of the respiratory system, the narrow trachea, narrow cricoid area, and when the intubation is there, we should have utmost precautions during intubation in a child. And compared with this heart also, pediatrics have very high heart rate because the heart is poor compliant. The output, cardiac output depends upon the heart rate, not on the compliance and the volume that will eject. So the heart rate is an important factor, should be monitored. Then regarding coming to the hemoglobin, initially the hemoglobin will be high in pediatrics, but with increasing age, they may develop anemia because of loss of fetal hemoglobin. And at the same time, because of immaturity of the liver, they may have deficiency in the factors vitamin A, D, E, K, which are important for a surgeon when a problem like bleeding or these complications are there. As you know, renal function is immature, but we are dealing now with transplant, which already we have lost the kidney. And children will have large head and big surface area, and they are more prone for hypothermia. Surgery time will be 15 minutes, and pre or post-op preparation will be 3 to 4 hours. So that is at most important. So surgery is only the part of total story. So taking proper history, proper examination, and not missing anything, especially cardiac system, respiratory system, and at most important is counseling the parents, because child is not going to do anything with you. You have to counsel and you have to take confidence of the parents for taking a child for any surgery, especially transplant, which is a big surgery, and this surgery is going to give him a next life. So regarding preoperative preparation, the NBM status as in adults, we can consider 6 hours solid should not be taken before surgery. As child cannot tolerate long duration of NBM status, we can consider them, we can give him breast milk till 4 hours before surgery, and clear liquids up to 2 hours before surgery. And one most important for anesthetists, they should keep all the instruments ready before. You cannot just search for the instruments like intubation, tube, laryngoscope, everything should be keep ready before the child arrives into OT. It is at most important. Time is very much important when intubating a child. You cannot afford to lose time and instrumentation because just lack of instruments. Warming equipment must be ready. As we take precautions for DVT in an adult, hypothermia utmost care should be taken in child. Because even though you are technically very good, if an hypothermia comes, the results will be very poor. As a surgeon, at least we should know the basic fluid management, like we can remember 4:2:1 rule, where we can give the first 10 kg, we can give fluids of 4 cc per kg per hour, next 10 kg, 2 cc per hour, more than 20 kg, 1 cc per kg per hour. If it is a minor surgery, you can give extra 2 ml per kg per hour. If it is a major surgery like transplant, adequate hydration is very much important. Even though you do good anastomosis, if patient is in hypotension, if there is no preload volume of blood, the flow won't be as good as you expect. Renal transplant in child. The first transplant was done in 1902 by Dr. Ullman. After 30 years only, we could do human transplant. After 30 years only, we could do child. What are the challenges? As we come across routine transplant, having good artery, thin person, it is well and good. But the challenges, more than having two arteries, short artery, delicate arteries like in children, and congenital abnormalities, and previous transplantation, and not availability of iliac vessels, and even not availability of the aorta. So these are the different, and especially bladder. In children, the bladder should be at most taken care, and we should evaluate properly preoperatively whether he is voiding well or not, whether he has a congenital abnormalities in the bladder, or whether he has a neurogenic bladder, whether he has a posturethral valve, whether he is able to pass urine after transplant, whether he can deal this volume of output comes after transplant. And if you want to teach CIC them, prepare him before itself. And if you want to do augmentation, you can do before itself, or sometimes even after transplantation, after proper counseling. As Sridhar sir tell the different causes of renal failure in children, most of the times congenital abnormalities like dysplasias and congenital cystic diseases and bladder abnormalities. Most of the time surgical causes are more common causes, unlike an adult where medical renal diseases are more common. Routine evaluation with lab and radiological should be done. Cardiac and respiratory system should be properly evaluated, and bladder assessment is very much important, and vessels assessment before taking him for surgery. You should do self ultrasound examination for a child to see whether the vessels are which much size, whether we can put kidney into him, and what about his right iliac fossa, how his area will be prepared, whether we can put the big size of kidney into that one. If you have an idea before itself, it is well and good. And immunization should be properly taken care. If it is completed, well and good. If not done, we can do after transplantation also. And preoperatively, hemodialysis status we should assess. Hydration status of the child should be assessed. As we discussed earlier, NVM status should be properly assessed. Pre-education and proper counseling of parents. Utmost important, take them the confidence of the parents, then take the child. Regarding donors, who will be the donors for a child? It can be live related, as sir mentioned, and it can be cadaver. Cadaver usually up to 35 years age group can take the rule of 35 we can follow. We can take up to 35, whether it is live or cadaver, for a kidney recipient for a child. Because for a child to give child, it is very difficult. Having a RTA, having a pediatric trauma case, having a small kidney to small child, it is very rare incidents we can see come across. There are many factors which can affect the outcome of the renal transplant. What is the age of the donor? Whether you are taking very young child as a donor or whether he is aged person. So we can follow rule of 35. So it is equal. 35 age group can help a child with renal transplantation with good outcome. What is the functional status of your donor kidney? Whether it is a good functional status also should be assessed before. Size of the kidney is very much matters for a surgeon. If it is a big kidney, it is very difficult to implant in a child, especially if it is less than 15 kg recipient. And HLA match status. Though if it is availability of kidney is very difficult, you can do mismatches also. But as far as possible, better to avoid HLA mismatch cases. It is very difficult to do post-operatively with immunosuppression drugs. It is a nightmare for a nephrologist. We can remember rule of 35. When we do cadaveric transplantation, it is what most important to preserve the kidney with proper perfusion fluids. We can use University of Wisconsin solution or HTK. But in live cases, we can do ringer lactate with heparin and lidocaine. Simple solutions we can use. On-table dissection of a kidney is very much important, whether it is a live or cadaver. Delicate handling of the tissues is at most important, especially in pediatric renal transplantation. You cannot afford to have an intimal injury or flaps or injuries in the child, because it is the anastomosis, they are more prone for thrombosis, and technically it is very much demanding. Preserve the golden triangle to prevent ureter complications. Avoid direct touch of the eyes. When you transport a kidney properly, you should have proper idea how to transport it. Don't push all the eyes on the kidney. It will cause direct thigh injury. Use proper perfusion cannula. It is very much important. Don't use Venflon. It will injure the intima. You should have a proper cannulas of different sizes and different angles. Though it costs, it is worth putting cost on that. These are the different cannulas should be available before perfusion. So it at most affects the results post-operatively. This is the one case. First deal with the vein. Once kidney comes, ligate all the small venules which will cause lot of bleeding later on. Take control of vein. Adequate length of the vein should be taken. Then adequate length of the vein is very much important. If you have a short vein, it is very difficult to anastomose. If you have very large, long vein, it is easy to anastomose, but most of the times post-operatively after closing abdomen, it may cause kinking of the kidney vein and may cause thrombosis. So adequate size of the vein is at most important. This is a cadaver kidney where you have a good patch of aorta, and it is very difficult to anastomose this patch to a small vessels. So cut it more proximal to that. If needed only, you use that patch. What are the equipment? As I told you, anesthetist should have all the equipments ready before taking a child. Surgeon should be ready with all the instruments. Don't struggle for the instruments after intubation of the patient. Keep everything ready, then only give an anesthesia. Adequate retractor should be there. Magnification is must. Vascular tapes should use. Try to avoid umbilical tapes. Vascular forceps and ring forceps should be must. Proper perfusion cannulas, proper needle holders, all should be there before itself. There are some instruments which should be there. Whether you do one transplant, whether you do 100 transplants, you should have all the instruments there itself. Don't think that we are doing very less cases, whether it is needed all these instruments. Don't think like that. We are not compromising on our cars. We should not compromise on our instruments also. Keep everything ready before itself. What is the skin incision for a child? Routinely we use right iliac fossa for an adult, but if it is a child is very small, if it is less than 15 kg, we may have to do midline incision because we may have to anastomose to aorta and IVC. But if the child is well good enough, more than 15 kg or 30 kg, according to your experience, you can use right iliac fossa, Gibson incision and extraoperative approach. What is the implantation site? Where do you anastomose usually? So surgeon most of the times will be comfortable with right iliac fossa, most common site we regularly use. But other sites we may have many times we may have to do like dual transplantation, pancreas and kidney transplantation, pediatric renal transplantation. Many times we have to change the position of the surgeon to opposite side, which may cause many times technical difficulties during anastomosis. So we should be acquainted with that knowledge also. When we do lymph node dissection, very much comfortable when we are doing from the right side. But when we are doing transplant, we are very much comfortable when we are doing from right side. So we should have idea of these anatomical factors before taking a transplant. And to which artery we should be anastomose? Many people will do internal iliac artery, some will prefer external iliac artery. It is up to depending upon the surgeon's experience. But in children, most of the times we may have to anastomose to higher level of, because the vessels, the donor most of the times will be a bigger size kidney with big vessels. We may have to anastomose very higher up like common iliac artery or common iliac vein. If it is very small child, we may have to use aorta and IVC. If the vessels are multiple, as we have option, if the same size, we can reconstruct as a pantaloon anastomosis, or otherwise we can, if it is small artery and big artery, we can join them together, or otherwise if the same size of arteries are there, we can anastomose to internal iliac artery, external iliac artery, or both to the external iliac artery. And if it is a small upper pole branch, we can ligate it, most of the days won't be a problem, but a small branch in the lower pole, to prevent ureteric complications, we may have to anastomose to inferior epigastric artery. So at that time comes the technical points. Sorry for poor video. This is a case where we have anastomosed inferior epigastric artery to the lower pole branch. The first one we are seeing the internal iliac artery anastomosis. This is the inferior epigastric artery anastomosis to small lower pole branch. So what are the basic principles of vascular anastomosis? As we remember rule of 35, you can remember rule of 3. So you have to take all the 3 layers for the anastomosis, and you should take at least 3 mm bites apart, and you got to clear adventitia at least 3 mm apart, and use of heparin, especially when you are using external iliac artery and atherosclerotic vessels at least 3 minutes before anastomosis. What are the different techniques? Suture material, what we use? Routinely for adult, we can use 5-0 for vein, 6-0 for artery. But if in children, when you want to do anastomosis, we may have to do 7-0, 8-0, especially for microanastomosis. If the atherosclerotic arteries, special needles will be available like VC black, taper cut needle with firm, which are crash resistant. Because many times when you take bite from atherosclerotic artery, the needle will become blunt and it won't take second bite. So these type of needles we can exchange for routine needles. And as we mentioned, all the instruments like Bulla, Satinska, every should be available to apply to vessels. And proper spatulation is utmost important. Direct anastomosis, small artery to small artery, the flow may not be good. For doing a vascular anastomosis to a limb, adequate flow is enough. For a kidney, if you just adequate flow is not enough. You should have a good flow so that the urine output will come. Even a small 1 to 2 mm extra spatulation will definitely have an impact on the outflow of the transplant. And when you do anastomosis to external iliac artery, initially we used to cut directly with blade, but the results are very poor with that. You must use aortic punch so that you should have a wide anastomosis so that the immediately kidney will become hard and turgid so that urine will come on table itself. And we should well versed with microanastomosis, especially when you are well versed with microanastomosis, as we use routinely loop for hypospadiasis, for varicocele surgery, for vasoepididymal anastomosis, vasovasal anastomosis. We can use the same principles for pediatric renal transplantation also, especially when you want to do inferior epigastric anastomosis or where a small anastomosis vessels are there, especially child is very young. These principles of microanastomosis will help a lot. What are different 3 ways of anastomosis? Using a single suture, using 2 sutures, and using 3 sutures. These are the different 3 techniques. As I mentioned, rule of 3 you can remember in vascular anastomosis. Single suture parachute anastomosis. Most of the times when you do external iliac artery anastomosis, you cannot directly go on continuing anastomosis like that. You should acquire knowledge of how to do parachute anastomosis. Similarly, vein anastomosis. It is usually easy. You can use 6 o'clock, 12 o'clock sutures. You can tie 2 sutures, then complete the posterior and anterior anastomosis. But in artery, most of the times, though internal iliac artery anastomosis will be easy, external iliac artery you should do parachute anastomosis. This is one video where we are anastomosing renal artery to the internal iliac artery. Taking bite at 6 o'clock or otherwise 12 o'clock. Corners should be shaken, then followed by posterior anastomosis, followed by anterior anastomosis. Many people will do artery first, followed by vein, but we routinely do vein first. But sometimes when you anastomose already vein, it is sometimes very difficult to bring both ends of the artery together. In this case, when we had difficulty, we have removed the bulldog over the vein, then we could bring the close ends together. After taking posterior bite, 6 or 12 o'clock, then continue the posterior anastomosis, which is a difficult one. If you suddenly complete anterior anastomosis, it becomes more difficult to anastomose posterior side. We have to flip the kidney again. So try to do the difficult one first, so that the easy one can be done later on. This is the completion of posterior anastomosis. This is a vein anastomosis. Apply Satinski first. Then handle kidney very nicely with a wrap in the gauze piece. Cold continuous cold saline over it. Need not to wrap in ice bags because the anastomosis most of the times will be finished in 20 minutes. Need not worry about the putting ice over it and handling very difficult. Then complete the posterior anastomosis from posterior or otherwise from anterior also. You can finish up the one side anastomosis of the vein. Then complete the anterior anastomosis. Check the integrity of the anastomosis before releasing the clamps. Then comes once artery and vein is everything is good. Once we release the clamps, everything is fine, urine is coming very good, we can go for the ureteric anastomosis by different modes depending upon the situation. Most commonly, modified Ledger technique is used. Regarding child, bladder augmentation, teaching catheterization, self-catheterization, use of mitrofenab before going for transplantation when the child is difficulty in doing CIC, all this should be properly dealt. Post-op care, already Sridhar sir has mentioned everything. The main complications in post-operatively in child is cardiovascular complications and lymphoproliferative diseases are more common compared with the adults. And at most important thing is follow-up is in children is very much important because of adverse effects with the glucocorticoids, glucose intolerance and cosmetic problems, growth retardation. With all these factors, the child may not be willing to take drugs. So follow-up and adequate dosage continuation is at most important for a good result. Doing a technical good job is not at all enough. The follow-up is very much important in this group of patients. This is one patient. He is my wife Seshikiran, nephrologist, and he is my child. Transplant what we have done. Last but not least, I just want to mention about Dr. Surya Prakash sir. We have two Surya Prakash, one is V Surya Prakash, one is B Surya Prakash. Both are very good in urology and we are very much happy to have these Surya Prakash in urology in APSOGAS, Telangana and Andhra Pradesh Urology Association. Both are doing good work. Sir is my guru and mentor. With him help only we have done this many transplants over a period of last 10 to 15 years. Thank you.
Thank you, Kasi, for your exhaustive coverage of entire transplant. Okay, I would like to add two more points. See, whenever a child comes for transplant, the only worry for surgeon is, most of the time it is the adult kidney to the child because the parents come forward for the donation. So where to put this kidney, whether it will accommodate in the pelvis or you have to go to the abdomen, aorta. These are the two issues. Of course, he said more than 30 kg is almost akin to adult. But if you look at the Peter Morris textbook, if a child is more than 23 kgs, it is almost akin to adult. You can either anastomose to the artery to the external iliac or common iliac. You need not go to the aorta. That is the principle. That is what we observed also many times. The other important thing is in a pediatric transplant, how it is different from adult. During surgery, when you are going to release the clamps, see the child tolerates hypotension very badly. So the graft, if there is hypotension, it is going to be persistent and the graft goes for ATN. And then very difficult to manage the child post-operatively with renal failure and dialysis. So when you release the clamps, don't release the distal half, that means distal clamp on the external iliac artery. So we release the proximal, then the graft is perfused. We will wait, ask the anesthesiologist how is the pressures are maintained or not. Once the pressures are stabilized, then only release the distal clamp. That is very important observation which everybody should remember. Thank you. We will go to the next session. Thank you, Gopi. We will conclude the session.
Thank you very much, sir. Now I would request our founder and MD of KIMS Group of Hospitals, Dr. Bhaskar Rao, sir. He has taken time out to attend our conference. Thank you very much, sir. I would request him to please inaugurate this session. Dr. Mohan will also be joining after some time. And speak a few words as encouragement to all of us.
Good evening to all of you. It's a great pleasure for me to be here. The purpose what we build this auditorium in a private sector to do more and more conferences. Today, the wife and husband of the urology department is not only urology and nephrology, it's everywhere. Cardiology, cardiac surgery, or oncology, it matter everywhere. But the good husband is one who should listen to everything, nod and do what he wants. So that way you don't want to keep anybody, unhappy. The day when you learn the tricks, I think both in life and as well as profession, you will be very, very happy. And once again, I thank all the people, especially all the senior faculty who has come here and to do. This is one of the important thing. A lot of well experienced people come on a single platform and keep talking about the juniors do get some experience. It has to be a continuous process. It's not just do one. I don't think anybody will learn in one aspect or one lecture or maybe one conference. He has given so much of detail. In spite of that, you could be able to add 2 more points on this pediatric cardiac transplant. I, being a cardiovascular surgeon, I know how difficult is this vascular anastomosis. The entire trick is only the vascular anastomosis in the transplant. I don't know, in beginning, when I was in Apollo, the vascular component is the cardiac surgeon is to go and help the urologist. In Dr. Girinath used to go and a few cases, then they start learning. The fact is that it is not the anastomosis that itself, it is the positioning of the kidney with the lye, where, as he rightly mentioned, if there is any slightest kink, that will be able to propagate to the thrombosis and then kidney failure. And even I have also seen few here. And the important task here is the how alignment with the vasculature, whether it may be internal iliac or the aorta, or with the new kidney that is coming, the length and depth, and it may be in an open place, it looks very nice. You have to see and close when all the organs and everything comes. The kink portion is the most important success for a transplant is concerned. And that's all out of my curiosity. I'm just saying you people are the most experienced and experts in that. And I must congratulate my wife and husband of KIMS of urology and nephrology. They are working together without any fight. And I don't think any family, wife and husband, they are happy. It's a wrong notion. They are always has to fight. Then only will get a good outcomes. So I must congratulate my entire urology team, Dr. Gopishan, Arvind Panda and all, Francis, and the nephrology, even Satyareddy and all. They're all, Sridhar and Ravi, everybody. They all work as a team. That is the most important aspect. And when Mallikarjuna Reddy was associated with me since Nellore, he wants to be here, wants to build a good pediatric one. That's what I keep telling. It is not when we keep on expanding our knowledge and when we want to really give a good care, quality care to our patients, we need to go for a subspecialization where we can always keep on inventing ourselves in one area rather than there are few people who can do entire thing, but ultimately institutions like this, if we can able to go for a subspecialization, there are plenty of patients are there and we will be expertise in that. And one day we need to all of us has to do, always we quote the Western literature and the case studies and all. We have plenty of cases that we are doing and we are not able to produce, and somebody should be able to quote us, our Indian literature. That's the way once we do, then we will be the expertise. That will come when we are going to a subspecialization, concentrating on one particular area. So that there only it will come. So that way it will be helpful. Maybe in a few more years, I think this subspecialization will come in a big way in this country also. And we need to, right now we are doing a lot of research and as well as paper publications and writing books also. We need to do that. This is the country where we are doing maximum in healthcare is concerned, in all aspects. But our documentation, the presenting of papers are very, very less. Once we do that, in the medical community, we will have to evolve as a number one. People are all going overseas before. Now people trying to come here and learn something. So these are the type of interactive sessions will help. And again, I congratulate my entire KIMS team of both nephrology and urology to do this and to invite me for this also. Thank you very much.
Thank you very much. We'll have the next session. I would request Dr. Mallikarjun to please come onto the stage. He is head of the department, Usmania Hospital. Dr. Ravichandar, head of the department, Gandhi Hospital, to please come and chair the next session. Thank you very much, sir. Dr. Chandramohan, he will be talking on stone surgeries in children. So he will be showing us how to tackle the stones in children at 20 minutes. Yeah. Dr. Chandramohan does not need any introduction to the urologist here. He is like the rock star of urology, especially when it comes to stones. Thank you very much, Dr. Chandramohan. In spite of your busy schedule, you're here. He is owner of 3 hospitals in the city, and in spite of that, he is with us. And I think he is an apt person to talk about stone surgeries, been international faculty in treatment of stones in children. Thank you.
Respected seniors, my dear colleagues, I am happy to see Dr. Bhaskar Rao sir talking. After a long time, I am listening to you, sir. Nice, you being a cardiac surgeon, establishing this big institute and institutes, magnanimous institutes. Great. First of all, I congratulate for your both professionalism and entrepreneurship. I also thank Gopi for giving me this opportunity. My talk is management of pediatric stone disease. Actually, I was doing RIRS in the beginning part of my career 10 years back. As the number of RIRS cases has increased, the pediatric cases started coming. That's the way pediatric stone disease I am dealing. So with this, I'll quickly go through it. Most probably I'll finish before 15 minutes. Common surgeries are RIRS, PCNL, URSL, cystolithotripsy, laser usage. Only thing that's happened in last 30 years is open surgery role has come down because of the advancement in the endoscopic equipment. That is the major, even though certain indications are there. So no conflicts of interest. The incidence of disease is increasing because ultrasound is used before the baby is born. So imagine 4 months baby from Nilofer was referred to me with bilateral ureteric stones and anuria. Baby has not taken the food. That means metabolic abnormalities are common. So they are detected early worldwide because ultrasound is commonly seen. In the same way, large stones are decreasing worldwide because you will never allow them to grow. Ultrasound will pick it up because it's commonly used for abdominal pain. For all practical purposes, ESWL is the treatment of choice even today in small stone volume and also the less dense stones. That we should not forget. Only problem is the mission is separate, the heads are separate, not many missions are so effective. That's why other treatments have come. Regarding the guidelines, if you see slowly from ESWL, people are moving to PCNL and RIRS for large stones. We have to understand. In adults, for example, if you see in child with a small bladder stone, previously we used to do simple cystotomy. A lot of people say it is a simple surgery, no morbidity. But the cut in the rectus sheath, cut in the bladder is always there. Whereas here, the technology has advanced. This is a bladder stone in a small child. Small scopes are available. 6 French, 7 French divided by 3 is equal to 2.2 mm. Excellent vision. And laser fiber is 100 to 200 microns, very, very small. You go inside, put the laser, keep on moving over that. It's easy operation also. So it becomes powder. How to remove this powder? If the powder accumulates, again the stone may come. So suprapubic aspiration with intracath can be done. So no pressure in the bladder raises. Sepsis chances will be less. Similarly, at the end also, when you make completely powder, if you want to remove, nephroscope of 12 French is available with the outer sheath, 7.5 French nephroscope, and you go inside like this and remove all the stone. At the end of 10 minutes, you will see normal bladder. Then why not the patient go home in the same day? Sepsis can occur, urethral injury can occur, but you should not do it. You should get expertise not to damage. Similarly, the adults, lot of PCNL is there and still, but in children, slowly RIR is coming into the way because it is less invasive. So how different pediatric is, anatomical aspect is, urethra is small. In males, 1 year baby, 2 year baby are different from 10 years babies. 1 year baby penis cannot be compared, urethra cannot be compared with 10 year baby. Urethra is very, very small. You have to be gentle, otherwise you will put your signature lifelong on his urethra. They will be carrying the file this doctor has done and stricture has formed. So you should be careful. Coming to the bladder volume, in no time when you are doing surgery, bladder will fill, 30-40 ml bladder will fill. Small children develop ascites also, so you should not drape the suprapubic region, feel it, empty it. Now coming to the caliber of the ureter, almost like adult, if you put a stent, if you don't put it, it is small, snugly fitting, 5 French, 6 French, 7 French. So don't be judiciously directly using the large scopes in the ureter and damage it. Put a stent and do the surgery in small children. So evaluation, I don't want to go into the detail. CT scan is used less, no doubt about it. Even X-ray KUB should be used less because ultrasound is very good. And metabolic analysis you should keep on your table whenever you have the patient, read it, write it on the paper, you may miss it or else you have to mug it up. So these are all the metabolic. For technical aspects are good ventilator should be there, good anesthetist should be there, low tidal volume, low pressure machine should be available. Otherwise we should not do these cases, especially RIRS where tidal volume should be very low, but you cannot decrease the respiratory rate. These are the values. Stent removal, see the position of the child should be gentle, it's not like stirrups will be there. You have to use the pads only and you have to keep at the edge of the table. Prepuce should be retracted properly. Do not damage the meatus. Calibrate. What calibration? Simple dilator, male dilator, you put 8, 12. If it is accommodating, then you put ureteroscope under vision. If it is accommodating, then only you do the RIRS or ULSL or go for PCNL. So like that, every child is different, especially male children are difficult to manage. See here, I am showing meatal dilatation. Retract completely the prepuce, use adequate gelatin jelly and be gentle, very, very gentle. You are not over dilating here, just adequate for the ureteroscope. In female it is okay, but only problem is meatus is not seen so easily. Put light properly, put jelly, it will show central lumen like black, then only you calibrate. And a certain angle will be there. If you force, blood will come and you cannot do the surgery. Ureteroscopy 6 by 7.5 inch is a crux for any stone disease. Adequate caliber, this is the average small size of the scope, which is also applicable for the pediatric. Otherwise you can use 4 by 6.5 scope. See the stone seen like this. If you feel that it is adequate, go ahead. Parking 2 guide wires is important. This is basic principle that one guide wire outside will always help to put the stent. One guide wire inside will help in the going inside. Access sheath passing also over the guide wire is like that, gently. Urethra is most important than ureter because ureter stented will behave like adult ureter, but urethra you cannot. If you have problem, we put 10 French Foley's catheter 1 day before, then it gives some suppleness and dilatation so that injury will not happen. The access sheath insertion is not recommended in less than 5 years, better to avoid it. If you use it, the ureter should be adequate and urethra should be good. And when you sheathless RIRS, you can do always suprapubic aspiration with simple intracath is sufficient in male children because you cannot put feeding tube by the side of your scope. Whereas in female children, you see this is the aspiration. That also you should not do fast aspiration. As much it is filling, that much only you have to aspirate, otherwise bladder will collapse and then intracath will come out. Now coming to the female feeding tube can be inserted because usually 7 French ureteroscope or 8 French plus 5 French, total it becomes 13. You can easily dilate female baby urethra even in a newborn baby. But over dilatation may cause incontinence temporarily. Upper ureteric kink is very common, diatal fold will be there. It is for the growth of the child God has given. So if you meddle with it, it will perforate a valve. So pass a gentle guide wire, wait for the peristalsis to disappear, give diuresis and then pass 2 guide wires, straighten it, then things will be much better. Now coming to the merge maneuver, very useful. Every time when the kink is there, you push the kidney up, ureter becomes straight and then pass the ureteroscope. These are the tricks. Initial RGP is always a good roadmap. Nobody says that it is wrong. So let us see where it is going, how it is going, mal rotation, everything. Basket, every time at the end of the surgery, you have to take one stone out and then send for the analysis. RGP at the end, whether you have done intravasation, extravasation, any damage to the ureter, document it, put the stent for more time if you have done damage. Then initial RGPC, this is the smallest child published by us, supine PCNL, 9 months baby. When we started RIRS in a post-stented baby, immediately within 2 ml contrast as extravasated perforation happened in the upper pole. You can never do RIRS in such case. Already stented patient came, anesthesia is a concern, do supine PCNL, and this is the smallest child supine PCNL published in the world. Then scopes, flexible scopes, no scope is available for pediatrics separately in the world. That is the unfortunate part. Only adult scope is there, but less length is there, so that you will not stand kilometer away from the small penis. Length is not at all useful. Breadth and diameter is very important. No scope is available for pediatric as of now. Stent placement is important. 3.5 French is very good, and it passes to the ureteroscope, then pass it. Smaller the stent, better for the children. Even in adults, peri-stent drainage only happens, so putting large stent has no use. Armamentarium, I am not going into the details, scope, the laser, everything will be there. The flexible scope, see how the lasing with chromium laser powder is better. You can't do popcorn because it produces heat. You spend some time, usually they are small volume stones, not stagons. Spend time, let the water be coming out from the access sheath or the bladder. It is both same. If you have not put the access sheath, water will be aspirated from the bladder. Let pressure not rise in any part of the body, ureter, bladder or the kidney. Now coming to the RIRS with thulium fiber laser, this is a new laser which is used for 2 years, which generates more heat. But if you have bench cars, go only at 90 kilometers per hour, chances of accidents are less. If you have bench car, means you are more prone for accident is not correct. Use low energy, low frequency as much as possible to make the stone powder. Otherwise, no definitive literature saying that it is bad. RIRS with chromium and TFL, you can use in both the cases. This is a case where we can use both lasers. Nothing great, but if you have a large burden, you see this is a hard stone. Sometimes you have to make powder initially, but when small fragments are formed, you can't chase them, you can't take out with basket. Use high frequency laser like thulium fiber laser at the end and make powder. Aim is powder. If you can make face powder, it is good. If you can make face powder and aspirate it, is very good. If you clean the kidney on spot without any fragment, very good. This is about RIRS. Post-operative care, I am not going to details. Every department needs ancillary support. That's where corporates matter. Even medium setups can have one pediatrician, pediatric anesthetist. And my friend Nandakishore is here, who is there for 10 years. He is my MBBS classmate. He has established first ICMO in KIMS. It may be the only center who is doing in Hyderabad. He was studious and he came after 4 years from UK and established. Even we take some suggestions from him whenever patient has post-operative fever like that. So any person, nephrologist or pediatrician who can, an anesthetist who can give good care is very, very useful in such cases. Diagnostic criteria are all different in children. Total leukocyte count is less considered than CRP. CRP is more important for pediatricians as far as my experience concerned. But nowadays I am not looking at it. Being the hospital owner, I will also realize that it's not your cup of tea. You do the surgery well and give the other part to them so that your stress will be less. Now our experience, we have published in Journal of Urology, approximately 64 cases. I'm not going into the details of that. Review of literature ample is available. This is about bladder stone is over. This is a 4 months baby child, which is the smallest baby RIRS we have done in the literature available in the world. So obstructive anuria. Technique is same, but only how as Kashi said, in fact he came yesterday only to help me kidney transplant with 3 vessels. His hands were very soft, and a successful kidney transplant we could do in our hospital with 3 vessels. So you have to be soft, and you have to be soft with these organs, and you should not try anything force. Disaster can happen, especially avulsion and perforation. So this is a child, 1 year male RIRS. All the surgeries are same. You calibrate, you go inside with ureter, whatever I said, you go with flexible scope, go inside, take basket and keep it in the upper calyx and do in a comfortable position. That is horseshoe kidney. So these are the about RIRS. Briefly about the PCNL, supine PCNL we started doing more last 3 years. I have already shown PCNL is making a puncture in the kidney. The problem is the kidney will be just below the skin. Over enthusiastic deep punctures are dangerous, may hit any vessel, so that you should be superficial. Ultrasound is very useful, should know depth, how much depth you should go and properly puncture. Take help of the radiologist also, no problem, but proper puncture, after that everything is same. So we have done a lot of pediatric PCNL. This is 9 months baby supine PCNL. This is the ultrasound picture. Ultrasound always give the picture, and these are the 2 stones. This is what I told that this is a supine position. In children, putting prone is difficult, so this position it is done. See, puncture is most important. This is a perforation. This is the position. Posterior axillary line, everything is same. For the urologists, they can understand better. See, you are almost horizontal to the surface. Needle won't be more than 20 degree, 30 degree in any case. So once pass the guide wire, rest of the thing is the same. But only thing is that here we are using very small scope, ultra mini perc, like 7.5 French with laser. The same again, you will make powder. You cannot make pieces and take it out. Last piece you can send for the analysis, so that child can be followed, what medicines can be given. This is a picture. This is a small hole. So 1 year baby supine PCNL, same. Like a number of cases we can show there is same. We are collecting the cases and supine pieces. See, this is the kinks which are there. Multiple stones are there. So once you puncture normally like this, 1 or 2 attempts it may fail, but don't try to do dilatation without confidence. Once it is properly punctured, see here, second puncture after leaking is done. After that, the guide wire has gone inside. You should have patience, and you should not be in a hurry. Ultrasound should be there always. So ultimately, these are the cases which gives confidence over a period of time when you can combine both RIRS and supine PCNL. This is our team of urologists presently dealing with the 3 hospitals. One is at KPHB and another is BHL and Gachibowli. Thank you once again for patient listening. I thank the organizing team of this conference of KIMS for giving me this opportunity.
I wish to congratulate Chandramohan for his extensive experience which he has shared here. He is very good at the pediatric, managing pediatric stone disease, and he has showed all his techniques and all his tricks. But in a small baby, we also have seen we do little PCNL for small babies. We see a lot of extravasation of fluid into the peritoneal cavity. Have you any time experienced that sort of situation, and how could you manage that? And
Sir, yes, the reason not known. If you do long time RIRS or PCNL, instead of perinephric, ascites is also seen because of the very loose tissue between the kidney and peritoneum, and transudate can go. Abdominal distension is very common. I feel abdomen should be exposed during surgery, and just before surgery, see the abdomen with your mind, feel how much is the size, and at the end you will easily realize how distended. By the time anesthetists realize, it is too late. By the time we release better, one trans-abdominal drainage I have kept in RIRS, so immediately patient settled well. RGP, MCUG also I have done, no leak seen. So intrarenal reflux, then some leak in the around the kidney. Any case of RIRS, if you do like donor nephrectomy, if you see, lot of fluid will be there outside, around the ureter, around the kidney. That means it is invasive procedure. It causes transudation of fluid. That fluid in children immediately goes into the peritoneum, so it can cause respiratory difficulty for the anesthetist also. Yes, that's a valid point.
At what size of the stone do you limit RIRS?
1.5 centimeters, not more. PCNL is better.
Okay. So any questions from the audience? Thank you, Chandra.
Thank you, sir. Thank you very much. Thank you, sir.
Thank you, Dr. Ravichandran and Dr. Mallikarjun. And congratulations, Dr. Ravichandar, for doing transplants in, continuous transplants in Gandhi Hospital. I would request Dr. Bhagwan, sir, please come and chair the session. Dr. D.S.R.K. Prasad, sir, and Dr. Taif, sir, please chair the session. I have Dr. G. Srinivas, who is consultant at Star Hospital, our very dynamic secretary for our state association. Thank you, sir, for taking time out for us. He'll be talking on renal scan, its significance, how do we do it in children. You can start, sir.
Dr. Gopichand and the organizing team for giving me an opportunity to be here in this evening for this pediatric update. So, Dr. Gopichand has given me a difficult topic, which we normally as a urologist don't deal with that. It is a radiological topic, and somehow he has forced on me to do this. So I don't know what I'm going to do, but the thing is, if I go wrong somewhere, I request the senior colleagues to help me out and clarify certain things. So before going into the proper thing, I just want to briefly tell that the renal blood flow is about 20% of the cardiac output. The cardiac output is about really nearly 5 liters per minute, of which 1 liter goes to the kidney. And of the 1 liter, only 60% is the plasma. So essentially 600 ml of plasma goes to the kidney, of which 20% is the GFR. And so by that calculation, it will be 120 ml is the GFR. Per minute to the kidney. And after ascertaining all the knowledge about a particular disease and the thing, finally, this is the investigations which tells us which way to go, whether it is a vesicular reflux, whether it is a PUJ obstruction, or if you are going ahead with the transplant, before transplant, choosing the kidney. For everything, this is a guiding light. So here, essentially, these investigations tell us how much is the renal blood flow, and it also tells us what is the difference in the renal function between the kidneys, and also tells us what is the amount of obstruction that is there to the kidney, whether there is obstruction at all to the kidney or not before we proceed with any surgery. And also, most importantly, in vesicular reflux or any other disease where the kidney is scarred, so this will tell us what is the extent of scarring in these kidneys. Now, what are these radiopharmaceutical agents that are available? Nowadays, everything can be tagged. So animals in the jungle can be tagged, and you can make out where all these animals are going. So every possible thing, your car can be tagged, yourself can be tagged, and your Ubers are all tagged. Everything is tagged. You know the movement of these. So long before in the medical field, we had this particular chemicals which are tagged. Each chemical has its own property. We should be able to decide which agent is useful for which particular purpose. So in my ensuing lecture, I'll be able to tell briefly about the characteristics of each molecule and how it is going to benefit us. So essentially, we have a DTPA, MAC3, DMSA, and ethylene dicysteine as markers. So coming to the DTPA, it is a heavy metal chelator. It extracted entirely through the GFR. This is the word which you have to remember about the DTPA, and it is excreted without being reabsorbed. And hence, it is used to calculate accurately the GFR of a person. But if the renal function is poor, the glomerular filtrate will definitely come down. In those cases, the quality of image what you get is very poor because there is a lot of background activity in those cases. So essentially, if a person has got a normal GFR, the assessment of obstruction can be very well done with this, and also you can very well assess the GFR of a patient. Now coming to MAC3, so MAC3 is protein bound, so it is purely by tubular secretion. So this is the characteristic property of the MAC3. So it is not impacted by the abnormal GFR. So even if the GFR is low, even if the renal parameters are elevated, if you use MAC3, you will arrive at the diagnosis. There is a higher extraction efficacy of this molecule when compared to the DTPA, and the image quality is definitely improved in this. The radiation to the non-target organs is very less when this. It's quite cheap. So it is automatically becomes the agent of choice for measuring the differential renal function and functional obstruction. And ethylene dicysteine exactly almost has the same properties as MAC3. That is what is very much used in our Hyderabad city. DMSA, so it is cleared by GFR like DTPA. It is, however, receptor-mediated endocytosis occurs in the proximal tubule through the receptors megalin and cubilin. So it is ideal for imaging of the cortex. So it is useful in the assessment of acute pyelonephritis or in assessing the renal scarring. Now, there are certain essential elements whenever you are sending a patient for any of these investigations. A patient has to be hydrated well so that the drug has to reach the kidney. In unhydrated state, the circulation to the kidney definitely is poor and it won't extract the drug as much as it is supposed to do. Drug history is very, very important. For example, if the patient is a diuretic, the drug goes and gets out, washed out pretty fast, so that your study will not be proper in those cases. So one should know about what drugs the patient is on. Anything which affects the quality of the image or the process of this particular molecule in the kidney, you should stop the drug and then only you go for the study. And everybody should know about the anatomical abnormalities. Whenever you are sending a patient for DTPA, please mention in detail about the case and also provide them with all the investigations that you have. Somebody has scoliosis, somebody has got horseshoe kidney, a pelvic kidney, duplex kidney, or a pelvic kidney, or a post-renal transplant you are sending, and the person there does a DTPA of the kidneys which are not functioning, and they miss out on the kidney view, what you are looking for, it is of no use. That is the reason every detail has to be mentioned, so that for a proper positioning of the patient and also for proper positioning of the gamma camera to record the activity that is happening in that particular end organ. So if a patient is having a neurogenic bladder or a bladder outlet obstruction where the bladder pressures are pretty high and there is a lot of pressure retrograde on the kidneys, it is better to catheterize the patient before you do the study. And if a patient has got a PCN, block the PCN and then do the study if required. So essentially, once you do the study, the information that you are looking for is what is the peak cortical uptake that is happening. A normal individual, normal functioning kidneys, it has to be 3 to 5 minutes. What is the half clearance? That is 50% of the clearance of the drug that you have given is happening from the time it has achieved a peak cortical uptake, that is called as half clearance. Normally it should be less than 15 or maybe 15 to 20. These timing, if there is any variance in this timing, then that gives us an information that there is something is going wrong with this particular unit. Essentially, this particular study has got two things. One is a perfusion phase and the second thing is a functional phase. So now coming to this renogram, the top one is about the perfusion phase and the down one is the functional phase. If you look at the upper one, the one with the white line is the aorta. After you have given a patient the radionuclide, so it reaches the aorta much high before the kidneys. So the molecule is appearing in the aorta first, and it is peaking initially, and thereafter it is taking a plateau. Now here if you see, the peaking is happening equally in both the kidneys, the red line and the teal line. So essentially both the kidneys are taking up, the uptake is very good in both of them. So that is what tells us from the initial perfusion phase, if the uptake of the tracer is good, then the function of the kidney is good. The second graph lower down, which is the functional phase, much of the uptake takes place in the first 3 to 4 minutes, and half clearance takes place in less than 10 minutes in this particular case, shows that the functioning of the kidney is very good. Now, whenever there are certain systems where the tracer is still there, the clearance is not happening as expected, then you have a doubt whether it is an obstructed system or a non-obstructed system. That is when a diuretic renogram is going to help us. So in this, a diuretic furosemide is given, maximum dose 40 mg, but if the patient is having an abnormal renal function, maybe higher doses are required. There is various timings for this, 0, -15, that is 15 minutes before the procedure, or 15 minutes into the procedure. But so far there is no data that one is good over the other. And half clearance, as I said earlier, if it is less than 10 minutes, it is non-obstructed. If it is more than 20 minutes, definitely it is obstructed. If it is between 10 and 20, it is indeterminate. Now coming to this particular aspect, I was talking about the perfusion phase. White line is aorta, the teal line is the left kidney, the red line is the right kidney. So the aorta, the peaking is good, the left kidney, the peaking is good, but the right kidney, the peaking is not good. It says that the function in that kidney is not that good because the tracer uptake is not good in this particular thing. And coming down, when the clearance rate, if you're talking about the functional phase you're talking about, there is peaking happening even after 20 minutes. You want to rule out whether there is obstruction or not. Then if you give a diuretic, you can just see the washing out of all the material from the kidney immediately. So it is a non-obstructed dilated system. With the diuretic, it washout happens. So it says that it is a non-obstructed system. And coming to the renograph, again, the perfusion phase. So aorta is peaking very well, and both the kidneys, if you look at the left kidney is peaking very well, but the right kidney is not peaking so well. And down below graph, if you see the left kidney, it is peaking, and later the half clearance rate is very good. But the half clearance rate of the red kidney is not good. So here it is suggestive of an obstruction. Again, a diuretic renogram will tell us whether it is obstructed or not. Group 1, this is a normal kidney. You see the peaking and how the half clearance rate is happening. You give furosemide, there's hardly anything left over, so that small whatever is there in the kidney comes out. If you go to the second picture, it is an obstructed system. Peaking happened, clearance is not happening. You give furosemide, still the clearance is not happening, it is obstructed. Now, if you go to the group 3 picture, you have stasis there. So uptake is good, peaking is happening, no clearance, furosemide, immediately clearance is there. It is stasis, there is no obstruction. And the third picture, it is sort of indeterminate, so it is suggestive of a partial obstruction. Now in case of a vesicoureteral reflux, there are certain parameters which tell us when to go about with a surgery in a child. So at that point, we go in and do a DMSS scan to look for scarring. And also in our follow-up of your patient, you want to know over a period of time whether the reflux is coming down or not. After your surgery, whether the reflux is coming down or not. Every time you can't do a micturating cystoarthrogram, the first thing has to be MCUG. This cannot replace micturating cystoarthrogram. The follow-up has to be with this. The advantages being, it is highly sensitive, even a subtle VUR you can make out in this. You have a patient, recurrent UTI, you do MCUG, you are not able to make out any reflux, then go for this test. Even a subtle VR can be made out in this, and the radiation what the child gets is much less in this. Now, when you want to do a renal cortical imaging, so say it is in pyelonephritis or in the renal scarring, in both there are photopenic areas with low tracer uptake. But in pyelonephritis, if you repeat the test over a period of time, whatever was photopenic, it will come down. It becomes normal. It becomes dark again. But whereas in scarring, it persists. Scarred kidneys always are smaller in size, and also the scarred areas have got sharp margins. That's how you differentiate between an acute inflammation and a scarred kidney. Now, if you look here, score 0, 1, 2, 3, it all depends about how much of scarring that is happening there. 0, so this is perfectly normal kidney, upper pole is scarred, patches scarring here seen and there. Scarring is seen in the third part in most of the places, and the kidney has got contracted. In acute pyelonephritis, you see here patchy photopenic areas in both the kidneys, but if you repeat the same thing after 2 months or 3 months, the entire thing will disappear. Where are the other applications of these radionuclide studies? One is renovascular hypertension. So when you are in doubt whether there is any renovascular hypertension or not, you do the study. And renal transplantation to differentiate whether it is a rejection or it is with the kidney is in ATN, again you use this. Thank you very much for your patient hearing. Hope I'm able to clear a few aspects of this radionuclide study. If there are any doubts, please.
Any? Thank you, Srinivas. Even though you are a transplant surgeon, you really revealed the very nice thing to you, everybody.
Yeah. Thank you, sir.
I should be very grateful for your efforts you have made.
Thank you, sir. Thank you very much.
I ask the audience to have any questions, please.
Thank you, Srinivas. It's a very big topic, difficult to cover in 15 minutes. In pediatrics, which molecule is ideal? MAC3 or EC, DTPA?
So, MAC3.
And another thing is very difficult to estimate GFR in children. Why?
So, no, I have no idea, sir. No idea. Anything? You can tell us, sir.
I think the GFR in children is weekends. The whole issue is we need to realize that the kidney becomes an adult kidney at 2 years. The neonatal kidney has got no concentration ability. So the concentration ability comes at 2 months. So till such and such time, if we start doing a renogram or either of the tracer, so we will not be able to get the proper functional estimation. So the recommendation is to do anything beyond 2 months, so that we will be able to estimate the GFR of the individual kidneys. But then if you have to need the concentration ability, then we need to go for 2 years. So less than 2 months, then we will not be able to estimate the exact functional capacity of the kidney, because it doesn't concentrate urine. Then you'll have to change the person, sir. If someone is not giving that, you'll have to change the nuclear physicist if he's probably so.
So, small announcement I just want to make about our midterm conference which is coming up on June 12th. It is being hosted by Dr. Bhargavardhan Reddy and the Karnool Urological Association at Nandyal. So, the topic has been chosen for this is complications in minimally invasive surgery. I want every one of you to contribute with the problems that you have encountered, the lessons you have learned, and how you have overcome, so that it immensely benefits the future generation and other colleagues also about how to manage a difficult situation. My sincere request to everybody to make an effort to dig out your old cases and see where you have faced a problem and how you to overcome that. And apparently Bhargav has been sending a lot of details about Nandyal and the most interesting places in and around Nandyal. So I request every one of you to actively participate, and also you can have a good trip to Nandyal. Thank you very much.
Thank you, Srinivas, once again.
Thank you, sir.
So before the next talk, we'll have just a 5 minutes tea break. Tea, coffee, and some snacks are served outside. We'll have just a 5 minutes break.
Thank you.
Thank you, sir. Thank you. Sir, thank you.
Change happens when the brain undergoes the maturation, and what we know is the neurons in children are still quite plastic. So there's a gradual transition here. The maturation occurs by step one is as inhibition of the infantile reflexes, and second, the adult voiding type occurs which is mediated by the micturition center and this spinal bulb pathway. And the inhibitory controls, these are normal and they are usually overcome. So if you look at a simplified classification of bladder disorders, there may be an emptying abnormality or there may be a storage abnormality. When you talk about emptying abnormality, there can be detrusor over underactivity or acontractile detrusor, and there may be outlet obstruction, which may be either a detrusor external sphincter dyssynergia or a bladder neck dyssynergia, so-called smooth postal dyssynergia. There may also be a storage abnormality, the failure to store, which may be due to bladder dysfunction or an outlet obstruction causing, maybe there may be outlet dysfunction because of a weak sphincter. So, first of all, when we talk about bladder and we start treating the bladder in children, we have to define what is a safe bladder, because the whole object of your aerodynamics or doing any treatment on the bladder is to create a safe bladder. A safe bladder is a low pressure reservoir. A low pressure reservoir is less likely to have reflux or poor compliance. There should be no functional obstruction to the drainage of the ureters. There should be no upper tract dilatation. And so, because of the previous three, the renal failure or pyelonephritis should be unlikely. Now, this is classical, that a 40 centimeters of bladder pressure is taken as a safe level in bladders. This was after Magyar's study in 1970s, but now we do know that this is far too high. We accept now a bladder pressure of less than 20 centimeters of normal saline or water as a safe cutoff. 40 is no longer acceptable. Magyar took this as 40 because he did a logarithmic assay of this of his case series and said 40 appears to be a good cutoff. So lower the pressure, the better. And this is very important when we are starting treating particularly patients with myelomeningocele. So what are the principles of pediatric urodynamics? First of all, for all urodynamic cases, frame the urodynamic question, good history and physical examination, have a voiding diary, and have a review of the imaging studies. Second, you must adapt the investigation to the child. For that, it requires time and patience. Thirdly, you must have a friendly atmosphere and experienced staff. Because a child can be rational, you can't really reason with a child, and you try as much as possible to perform the procedure as in play. So what we need to do again, respect personal integrity, have cartoons and toys around the place, on the walls, and you may use sedation. We try to give a small oral sedative to the child. So what does this achieve? When you are doing UDS, why are you doing UDS? You should not do UDS if your management will not change based on the results of UDS. If any test that we are doing and it does not change management, it's best not to do that test. So our aim is to reproduce the patient's symptoms during the study, to provide a pathophysiological explanation by correlating those symptoms with the findings that we have, to assess for the presence of risk factors, that is poor compliance, sustained high pressure detrusor contraction or DSD, and to provide documentation of the disease of the lower urinary tract. So you need to take a good history. This is a mentation and a medical history. Nature of the urinary tract symptoms. What do they have? What are the current symptoms? If the patient can vocalize, sometimes they can't vocalize. And then you look at the overview of the related symptoms. Is there constipation? Because when you talk about neurogenic bladder, there's always neurogenic bowel associated. And we need to treat that as well. And that's something which we do not treat, and many physicians do not treat that as well. And physical examination, again, motor strength, sensation, reflexes. See if there is any, how good is the bulbocavernous reflex, anal reflex, or the other motor reflexes. Voiding diary, if possible. In small children, it is not possible. The child is a little more older, maybe around 8-10 years. Definitely you can, or 6 to 10 years, you can definitely do a voiding diary. Note the daytime frequency, note nocturia, and note something called the maximum voided volume, which is basically the functional bladder capacity. This is the largest volume of urine during a single micturition. At least observe for at least for 24 hours. What we do know is that 48 hours voiding diarrhea is better, but often not possible. Minimum is having 24 hours. And of course, note on total fluid intake, if it is possible, but try. You have to explain to the parents about the importance of this and why they should be exact in doing this. So this is the voiding diarrhea, this is the bladder diarrhea that we use in our institution. So coming to the armamentarium, there is Uroflow. If you look at urodynamics as a whole, you find Uroflow with PVR, cystometry, pelvic floor, external sphincter EMG, and video UDS. In a video UDS, the advantage is that anatomy and function both can be assessed simultaneously. So Uroflow with PVR is a very basic test which can be used in children. It's useful for screening. It's simple to perform, simple equipment, physiologic. The another problem is children need to be toilet trained. One, it is limited value in a neurogenic bladder, and we don't really have good nomograms for children. Like we have for adults, we don't have good nomograms for children. This is something which is something that can be done in children. You do Uroflow with a simultaneous EMG recording with sort of perineal patch electrodes. It's non-invasive, and if you have dysfunction, if the child has sort of dysfunctional voiding or sort of a neurogenic bladder, we can differentiate this. But then again, the perineal electrodes are not the best electrodes to use this, and we really can't use those needle electrodes because they're painful in children. That's one of the disadvantages. So it's sort of a middle ground between presumptive management and invasive CMG. It is good if you're having a lot of children in your practice, it's good to do this. So again, the shape of the curve that you can know, this is in a 12-year-old male, this sort of curve you can have. And if you look at this child, sort of a tower cave shaped curve, typical of voiding postponement. So there's relaxation of the pelvic floor, the beginning contraction resulting in explosive. So this is supervoider. Always keep your eyes open for a supervoider. You will find some children with a very high curve. And this is typically because the pelvic floor is tight, the sphincter is tight, and suddenly it opens up during the middle part when they are forcing down in the middle part of the micturition cycle. And then you have this huge curve which normally you would not have otherwise. So this is a part of a dysfunctional voiding spectrum. And even in young adults, a lot of people will come to you with sort of symptoms of CPPS, chronic prostatitis. When this happens, when this sort of supervoider happens, what happens? The urine tends to intravasate into the prostatic glands and can cause inflammation, aseptic inflammation of the prostate. So again, this is a Plato-shaped curve. This may require normal or intravesical obstruction anyway. These are just some of examples. I'll just go to the next one. So again, PVR increases in the first 2 years. Maybe this is because of physiologic dyssynergia. It's almost complete emptying is achieved by the 3rd year. So from this, we have to decide if you need urodynamics invasive UDS. And when you talk of invasive UDS, talk of cystometrogram, PFS, urethral pressure profilometry, synchronous video CMG, and ambulatory urodynamics. Ambulatory we do not do here, nor do I believe so much in UPP because it's very difficult to distinguish artifacts from the UPP's profile. So this is, we all know about this. I'll just go to the catheter right away. Now use the smallest caliber double lumen catheter. 6 French is preferable. Don't use 10 French catheters because if you put 10 French catheters in small children, you are going to diagnose bladder outlet obstruction. You may try two single lumen catheters, filling and pressure monitoring. The rectal balloon catheters must not be overfilled. This is very important. If you tend to overfill that may cause artifactual changes. Fill to about 20% to 25% of its unstretched volume. Some people have small hole is not always needed. So there are 3 types of catheters: water-filled, air charged, microtrip transducers. Microtrips are probably best, but they are not disposable and we don't have them. We use water-filled catheters. And access is usually perurethral, suprapubic, if possible, if you have access, but generally we don't have access. Smallest size possible because that is less discomfort and preserves flow. And if the patient has spina bifida or meningomyelocele, try not to use latex catheters, try to use latex-free catheters because many of these patients have allergic reactions to latex. So again, you have to set 0, calibrate, establish a pressure reference level. Now, the symphysis pubis is the pressure reference level, and you may do this study whether the patient is sitting, standing, or in a lying down position. That does not matter. But again, doing a proper 0 position is important, and it's not necessary that you just put 0. You have to open it to the atmosphere and then set the 0. Filling medium, we use saline. Again, for children, please use slow fill. That is, I don't think we should be doing anything like medium fill or fast fill in children. Please use slow fill at less than 10 ml per second. And again, if you look at the formula, less than 5% of the predicted bladder capacity. Ambulatory UDS, of course, you use natural fill, but we don't do that. I don't have much experience on that. So again, this is the ICS definition. Weight by 4 in kgs is equal to X, and physiological fill rates is less than X ml per minute. Non-physiological fill rate will be more than X ml per minute. This is the formula. Why we should do slow fill? Because the rate of bladder stretching should not exceed the rate of stretch relaxation. And if that happens, they'll get a poor compliance, which will be artifactorial. So this we already know. I think I'll just skip this. How we sort of measure pressures. There is of course rectal pressure transducers and there's bladder pressure transducers, and the detrusor pressure is a derived value. So PDAT is PVES minus PR. We all know this. I'll just go through. I'll just quickly skip. Now cystometry, that is the reflex hammer of the urologist, can be done at any age. And so you have a filling phase here where you measure the sensation, compliance capacity, and continence, and a voiding phase where you measure the contractility and the voiding. So when we are talking of cystometry, first in children, you need to measure the bladder capacity. There are two ways of doing this. One is, of course, from the voiding diary, the maximum voided volume. In children, before we do it, it's essential to have a bladder diary and have analyzed that beforehand. And the second way is to use formulas. There is, of course, the Koff formula or the KIMS formula. The Koff formula is a linear formula, so H plus 2 into 30. Basically, H plus 2 in ounces, each ounce is 30 ml, so H plus 2 into 30 in ml. The KIMS formula is non-linear, so age less than 2 and more than 2, that sort of, because again, the bladder capacity changes in a non-linear fashion in children. KIMS may be better for younger age group children. So age less than 2, 2 into age in years plus 2 into 30, which is almost similar. That is, and age more than 2 is age by 2 plus 6 into 30. So that's how these are the formulas. You can always use them to capacity. But again, most of your machines will also have, once you enter the age, if you're using MMS or a laboratory machine or a Dantec machine, if you enter the age, automatically the machine calculates the capacity. You can't fill beyond that. Again, bladder sensation, difficult to evaluate. The child must be able to vocalize. So in very young children, what we will be basically doing is a filling cystometry. You really cannot do a voiding phase in very young children because they'll be reflexly voiding. So you measure all these things. Maximum cystometric capacity, this is basically the volume at which the infant or child starts voiding, detrusor leak point pressure. Again, I have said less than 20 is what we should see, not 40. So I'll come to the safe period. Now this is something which everyone should understand, is the safe period. Now this is the point. If this is the point, if you just look at this diagram, this is the point where I have taken this as 40. You can take this as 20 as well. So this is the point at what point in bladder filling that the pressure rises above a safe point. So this is the safe capacity of the bladder. Say if you are doing 20, it will be somewhere here. In 40, for the explanation purpose I have taken, this is here. So this is a safe filling. Then filling may be less than 100 ml. This is the line diagram which I have done. And if you are talking of a safe period, this is the period from 0 to the point where you reach 100 ml is the safe period. So in a child, say the child is like 15 kilos and it might take 2 or 3 hours for the child to reach 100 ml if you take 1 ml per kg body weight. Again, this is relevant even for adults as well. So it is important to know what is the safe period and what is the safe volume of the bladder. And the time needed, that is the time needed for the bladder to distend to this particular volume is the safe period. Again, cystometry is invasive. The child must obey commands. The child will involuntarily void, and child needs to appreciate sensation. And of course, the change in compliance with age. What is more worrying is the lack of standardization of protocols and inconsistent infusion rate. The machine, of course, takes care to a large extent. And if there is VUR, we need to be, again, you are going to get a very false compliance value because part of it will go up. So you really cannot assess the bladder in the presence of grade 5 or grade 4 VUR. That has to wait until the VUR is corrected. This is of particular importance when you are trying to assess the bladder pre-transplant. Again, videos, UDS is very important. This is of course the Rolls-Royce of UDS, simultaneous evaluation of anatomy and the voiding cycle. We are introducing this very shortly here. So the advantage is more precise evaluation and detection of DSD, determination of bladder pressures at the moment the VOR occurs. So if you are having VOR and you are doing video CMG, you can just say before VOR what is the pressure and what pressure VOR is occurring. So false reduced compliance can be easily detected, and in high grade VOR, of course, decides the infused volume corresponding to the bladder capacity. So it also we can diagnose detrusor external sphincter dyssynergia with this. If you have done it well, then you will exactly know at what point it's happening. So there are 3 types of DSD, and early diagnosis is very important if you can treat it. So the disadvantage is, of course, it makes the examination more complex. It's much more expensive. There is radiation exposure to the child, and the child will be scared of the entire machinery and all that zing bang. Ambulatory, this is good, but you need a magnetic canceller. Uses the child's natural fill. Suprapubic placement is preferred, and it's quite expensive. It's good to have it if you can. Again, what are the potential sources of error? Calibration, the fill rate, don't use a very large size catheter, balance the pressure in the rectal line, avoid overinflated rectal balloon, obtain a proper EMG signal if you are using EMG, and always watch out for slippage of lines, electrodes, make sure there's no air in those lines. If you're using a water-filled catheter, it's very important to make sure there's no air in those catheters. Artifacts, just look at the artifacts, that's very important. That's entirely a separate session. I will not take much I'll not go into that because it's completely separate presentation. So the important thing in the child will cry and will strain, and these gross movements needs to be noted and subtracted. And remember, if you are not getting a proper UDS, please repeat. A second fill may be more representative. It's very important. And we need to know that the pressure lines are stable and movement free, and wait for return to baseline, and be there when you are doing UDS in a child. You just can't give it to a technician and walk away. So again, you need to do quality control before starting, after starting cough and all that, and you and keep coughing at regular intervals of 25 to 50 ml. So in the last 2 years, even though it was COVID affected, we did around 33 children below 16 years. Our majority were actually neurovesical dysfunction. We did some valve bladders, voiding dysfunction, and we had some pre-transplant analysis as well. This is in children. And this is important because we have a lot of spinal dysraphism here, and we tend to treat them. What we need to do is that you need to remember that these suprasacral, sacral, so-called UMN upper and LMN bladders are not so-called classical findings are not often seen. What we do see more commonly is mixed patterns of bladder. And the bladder dysfunction may have no correlation with the level of the bony defect. This is what I want to really stress, because what we do know is LMN bladders, we are going to have a highly compliant acontractile bladder. So you are not going to, upper tract is going to be safe, but in a suprasacral or upper UMN bladder, upper tract will be unsafe because the intravesical voiding pressures will be higher, and there may be DSD. But again, I want to re-emphasize that mixed patterns are more important. You really cannot categorize a child based simply on the anatomy and on the MRI findings. So if you look at how this thing divides, classical MMC with the inactive detrusor and a synergic sphincter is only 30% of cases, and you have detrusor overactivity with synergic sphincter in 38% of cases. So this is the dangerous bladder. This is the dangerous bladder which can cause renal failure in future. So we need to evaluate the upper tracts, evaluate renal function, and when do you do UDS? When they present to you. All children with hydronephrosis, early as possible to detect DSD and a poorly compliant bladder. And this is, I think we've already gone through this. This is Maguire study. Safe volume, we have already gone through this. And I'll just, we did a study here, and this got an award actually. So we did prospective analysis of the neurological and urological outcome in patients with spinal dysraphism. What we know as normally what we think if you look at our conventional knowledge is that once you have a spinal bifida, we don't expect any improvement in the bladder function. But so we did a study to evaluate the improvement post-surgical repair, both neurological and urological. So we assess sensory, motor, and neurologic deficit in patients with spinal dysraphism, and we assess the change in bladder function and UDS findings, both preoperatively and postoperatively. So this was done for a period of 1 year, and all patients underwent surgery for spinal dysraphism. The inclusion criteria were patients getting operated, open and closed, age more than 4 years, because we wanted them to vocalize and able to follow instructions for UDS studies. 4 out of these 10 patients had previous surgery. This was their second surgery. We compared 4 variables. Of course, there were also neurologic variables, but coming to our UDS variables, first desire, strong desire, mean detrusor filling pressure, capacity, and the strong desire, both of them underwent a significant change post-operative for the better. While the first desire improved, it was not statistically significant. And the mean detrusor filling pressure was also not statistically changed. But what we changed was the bladder capacity, which is important. And of course, the strong desire. So 7 patients who had urological complaints in the preoperative period, all 7 showed clinical improvement, and 6 have improvement in the UDS parameters. So I just like to conclude that preoperative UDS study will help assess the severity of dysfunction, and the functional outcomes actually improves post-surgery. This is not there in literature till now. This is what we have found in our study. And so we need to do long-term surveillance of the UDS in high-risk patients, particularly in patients with poor compliance and DSD and reflux. Low risk can be followed with regular screening of the upper tracts and renal functions. Compliance with CIC, bladder bowel management is very important. Thank you so much. I'll be happy to take questions if you have any.
Arvind.
Sir.
Here.
Yes, sir. Sorry.
Yeah. One of the major problems that we faced is making the child to sit on a commode, because most of the commodes are adult commodes, and the child tends to slip into the chair.
Sir, yes, sir. So I have actually brought one of those baby things. We should have shown them to you. Actually, we have 3 things. We have made 3 modifications. One is if you go to Amazon, you will get those baby seats, which can be fitted onto the commode. We have one. So we fit that baby seat onto that commode, so the baby can sit on that. That is padded, and it is much smaller, so the baby doesn't fall inside. One. Second thing which we have bought is we have bought a spirit level. And we have bought a metal rod, like a simple, what you get in a tailor shop, that sort of metal rod. So we put that metal rod, we put that spirit level, we make sure that the base is correctly done. And for the sitting, we put the patient on that thing which we fit onto that commode. And if that cannot be done, we do it with the patient lying down, supine.
Then you will not be getting a Euroflowmet.
Sir, this is anyway for very small children. And no, we have that thing. Even if they lie supine, they can void down. We have the chair, the specialized chair which we can move up and down. But anyway, for very small children who are going to lie down, we are not doing the voiding phase. We are only doing a filling cystometry.
And most of the time, the EMG doesn't work.
So the EMG, yes, sir. For the small children, if you are going to use surface electrode, this is just too big. It's not worth it. If you want to use EMG in small children and you want to be accurate, we have to use needle electrodes. No, I don't think that's painful. Generally doesn't work out.
And how are you tackling patients with colostomies and vesicostomies?
So colostomies, that is a very interesting. We just put it inside the colostomy to measure the abdominal pressure. So if you have a colostomy, it actually makes the study easier. The abdominal pressure, don't need to put a rectal, we don't have to put a rectal catheter, put it into the colostomy. So that works as a rectal catheter. So, and for a vesicostomy, I don't think we have done any vesicostomy, but we can directly measure through the vesicostomy which is not leaking.
I generally block the vesicostomy, yes. Put in a Foley and block the vesicostomy.
Yes. Sir, I do a CUV or a urine culture, one of those things. If the CUV is normal, I do not go for urine culture. But I generally do a urine culture for almost everybody. If possible, I do for everybody. Before.
And is there any finding is there, sir, so that you can have any change of plan of action for a pediatric surgeon when they are doing surgery? Is there any finding you will able to identify in a urodynamic study so that they can have any technical change in the plan?
So it depends on what they are planning. If they are planning to do, for example, most of the patients on which we have done are referred to us from from neurosurgery before they do meningomastoid surgery. They send it to us very early, not just these patients, but also even adult patients. So they feel that that bladder changes are one of the earlier changes that come, but it's not detected. So you can have the changes before they are actually clinically significant. So we have done a lot of these cases. We are in the process of actually compiling them. So early changes, we feel, and they also feel, that the bladder changes come earlier than what is gross motor changes. They tend to appear later. So if we tell them that, see this, we are having underactive detrusor, or there is a detrusor overactivity. For example, one patient, I can just share an example. She was a 19-year-old, so I haven't included in this, 19-year-old lady who came from Warangal. I think she came with recurrent UTI and she had right pyelonephritis. And when we did a uroflowmetry, it was perfectly normal, and she was having recurrent pyelonephritis. So I did a UDS to see, and I got detrusor overactivity. And then we did a MRI. There was actually there was a sacral defect, and that's why she was having. So these changes, then I referred it to neurosurgery. So these changes can, we can detect early. So that will make a difference. But if pediatric surgeons want to do augmentation, sir, should be late. I don't think augmentation should be, with the present armamentarium we have, we should not be jumping to augmentation. And one more thing I want to emphasize is, when we are planning drug therapy for them, we need to give a drug therapy that will work in urogenic bladder. So if you are giving tropan, you can give up to 0.6 to, you can go up to almost 1.5 kg body weight. So you can give 555, even to a 15 milligram of oxybutynin to a 5-6-year-old child. That doesn't matter if you are having poor compliance. So the normal dose which you give to adults or to normal patients, in the neurogenic bladder, it has to be much higher.
What is the age limit? Below which age it is urodynamic cannot be done? At the after what age? How do you assess the child? Sir, psychologically, physically, and technically?
Sir, these are referred patients. We look at it if it is possible to put a catheter. We give them a oral sedation if possible, and generally we try. We have not failed in doing a UDS. Sometimes the patient may cry so much, and we tend to defer it. Say, come back later and we'll do it.
I think when should we do a urodynamics in a child? I don't think there is an age limit. Yes. So I would agree. If you have a myelomeningocele, and then I think you should be looking at doing urodynamics straight at the time of birth.
The only thing is, you can't put the tubes in a crying child. You may need to take to the anesthesia, short GA and short sedation, put the tubes.
We all know that the myelomeningocele, there is a huge difference in bladders, which the way they behave. If the myelomeningocele has been corrected before 72 hours after birth, or after 72 hours after the birth. And these children who have had these myelomeningoceles corrected after 72 hours after the birth have a very high incidence of neurogenic bladder and the upper tract damage versus the ones who have been corrected in a tune of 30%. So it's an extremely important thing that it is done. And even if you don't do urodynamics in these particular children, it is very, very important that we initiate clean intermittent catheterization, irrespective of whatever it is, so that the parents are tuned, and you are also decreasing the bladder pressures. The second other issue which we need to look at is, when we give these anticholinergics, make sure that you give the bladder becomes defunct. You have to make it a reservoir, not a voiding organ. The voiding is not what it is doing. We don't want it to do. So we need to make it a reservoir organ. So we can go at very high doses of tolterodine, oxybutynin, and we can go till the child develops side effects, and then you can de-escalate. The only issue with a little tolterodine and sulfasalazine in a child who is going to school, if there are some cognitive issues which are coming in, then you need to look. I had a child who is now a radiologist at this point of time. During her MBBS, she had to have, because she was feeling sleepy with tolterodine, so we had to give her Botox to get her off these particular things.
Correct, sir. And generally children tolerate much better than older people. Yes.
Sir, if we don't understand the bladder of a child, you doing urodynamic study, you can have idea. But if already spinal problem is there, you are going for surgery, is it mandated to do urodynamic study, or we can go proceed with surgery? Whether this finding will change the plan of action?
Sir, two things, sir. One thing is, UDS is soft science. That's something we need to remember. We tend to think that UDS is hard science. It's soft science, not only in a child, but also in an adult. If you're able to replicate those symptoms and sort of replicate those findings, it makes sense. But if you're not able to, replicate, it really does not mean that it doesn't exist. So it's soft science. That's the first thing we need to understand. The second thing is which surgery we are talking about. If we are talking about what surgery are we talking about?
Spinal surgery I am talking about, not
Sir,
a
I feel
bladder surgery.
now I
If the
feel
bladder surgery, it is mandatory. Whether you are filling problem you are solving, whether it is voiding problem you are solving, it is okay. But a spinal surgery, anyway they are going for surgery.
Sir, if they are going for a surgery, a small child, you don't have facility, that's fine. But if it is a child which, we are doing it because we are following up these children before and after. If you can do it, is better, because you need to follow up these patients. You need to know whether the patient is, at least you need to do after surgery, if not before. But you need to follow up these patients, know what sort of bladder it is, and then sort of continue from there.
Kashi, I'd also tell you that the advantage of doing a urodynamics before surgery is you will at least have a baseline of what the bladder is. That is number one. Number two, if you don't do surgery, the child grows, the cord gets more tethered, and then the symptoms start becoming more, and then the bladders become bad, and then it will obviously have their effects on the upper tract. Now, if you have surgery, now there is a detethering of the cord done, but then that we cannot sleep comfortably that it is done. It is again when during puberty, when the child has a spurt of growth, again a retethering will happen most of the time, and this is extremely important that we look at the symptoms at that point of time. Whether they are subtle symptoms or not, we don't know. But if you have a baseline before surgery and after surgery what it is happening, then it is much easier for us to follow that particular child. But it is a puberty, the time of puberty which we are worried after a surgery. And once beyond puberty, if the bladders are stable, I think we can probably let them go off our thing. What do you say, Mohan?
We'll continue the discussion, sir. We'll go for the next session.
You have, when the child is small, the cord is much lower. As sir just said, cord is much lower. As the child grows, if there is anything connected, that tends to pull, and then it can cause de novo findings later, as sir is saying, in 12, 13, 14 year age group. So that is the important time we need to follow up. And when they do a detethering, they generally wrap sort of fat around it, so it doesn't get retethered. That's again very important. And we need to do it in specialized centers so we don't cause more damage when they are doing this.
Thank you. Thank you, Ravi Kumar sir, Dr. Francis, Dr. Arvind. Excellent talk, and Dr. Prasad. Now it is a great privilege for me to introduce our faculty, Dr. Mohan Gundeti, who has come all the way from US. A very tough journey today, since I think you're traveling since last 36 hours on the wheels, air and then wheels. So thank you very much for coming. Dr. Mohan Gundeti is Professor Pediatric Urology. He is at University of Chicago Medicine and Biological Sciences, Director of Pediatric Urology. He is an internationally recognized leader in the field of pediatric robotic laparoscopic surgery for treatment of congenital urological anomalies. He was with us during our state conference 2 years back, and again it's a great privilege for us to have you here again today, sir. This is KIMS Hospital, the hospital where I am working, and it is a kind of a dream come true to host you, sir, here. He is an internationally recognized leader in the field of pediatric robotic laparoscopic urology and acclaimed innovator. Gundeti was the first surgeon in the world to perform reconstructive bladder surgery in pediatric patients and the first to perform pediatric robotic urology procedures in the city of Chicago. He had pioneered a number of procedures, has a wealth of experience in complex surgical reconstruction. In addition to providing state-of-the-art clinical care, Dr. Mohan Gundeti's commitment to compassionate care is a strong component of his practice. He is the principal author of two very good textbooks, one entitled Pediatric Robotic and Reconstructive Urology, and other one, Surgical Techniques in Pediatric and Adolescent Urology, an excellent book. I think one must read it if we are doing pediatric surgeries. He currently serves as a consulting editor for British Journal of Urology International and reviewer for various high-impact journals in the field of pediatric urology. He is a member of Video Education Committee of American Urological Association. For his outstanding clinical work, Dr. Gundeti has received numerous awards from American Urological Association, European Society of Pediatric Urology, Indian Society of Pediatric Urology. He has been listed among the top best doctors in America, top doctors in US, and in Chicago Magazine as top doctors issues. He also received the prestigious European Association of Urology Hans Marburger Award for his pioneering work published in minimally invasive surgery. Thank you very much once again for coming here. I'd request our President, Hyderabad Urology Society, Dr. Murthy sir, our Secretary, to please welcome him, and Dr. Mallikarjun Reddy, President of South Zone, and Secretary-elect Dr. Surya Prakash, South Zone, to please welcome him. Okay. Dr. Ravi Kumar sir, our Secretary of HOS, please welcome. The next talk is on bladder surgery, and I would request Dr. Murthy sir to come as chairperson for this talk. Dr. Surya Prakash would be talking on vesicostomy, and Dr. Mallikarjun Reddy on all the complex bladder surgeries. Thank you, sir.
I can keep my pen right here. Vesicostomy. Good evening, everybody. At the outset, I'd like to thank Dr. Gopichand for giving me an opportunity to talk in among the august audience here. And I consider it as a privilege, great privilege to speak in front of international faculty like Dr. Mohan Gundeti, who is here, Dr. Mallikarjun Reddy, who is a stalwart in pediatric urology. So the topic Gopi has given me is vesicostomy. So I'm going to talk very briefly. It's about a 10 minutes talk. There are no videos in this, unfortunately. So we all know vesicostomy is a widely used and simplest form of temporary bladder drainage. It provides effective bladder decompression. We all know that it is commonly used in posterior urethral valves when we need to decompress the bladder, small child, where we don't have enough scopes, adequate scopes to fulgurate the valves, and even in neurogenic bladders. Sometimes we do this procedure even in prune belly syndromes, gross VUR with urosepsis. So to decompress the bladder, to treat the sepsis, we do vesicostomy. It is a procedure, simple procedure to create. It can be done even in acutely ill child. It is easy to reverse. Suppose when you want to reverse it, close the vesicostomy, it's easy to reverse it. And you can avoid all the complications of having catheter in the bladder. So coming to the most common indication for vesicostomy is PUV. What are the indications for vesicostomy in PUV? A very low birth weight infant whose urethra cannot accommodate even the most thinnest scope available. We have 4 French resector scopes. So but even you can't pass even the 4 French scope, then we need to do vesicostomy. Child with continued impaired renal function. You catheterize the child, still the creatinine goes up because of there is some sepsis, then you do vesicostomy. High bladder urine volumes. This is another indication. Upper tract deterioration even after valve ablation or urethral catheterization. This is another indication. So what are the advantages? Why we do vesicostomy? The advantages are it reduces the bladder storage pressure significantly because you are opening up the bladder pressures go down significantly, and when the bladder pressures are decreased, there is no retrograde transmission of bladder pressures to the kidney, and that optimizes the kidney function. That means GFR gets optimized. And it allows bladder filling. Though the bladder is opened, there is significant amount of the bladder in the base, so it allows normal bladder filling and preserves the contractile function. So when we do this procedure, we have to select the appropriate candidate. A child who has got a severe hydroerythronephrosis with grossly tortuous ureters is not an ideal candidate. So in such patients, we need to go for a higher form of diversion like a cutaneous loop ureterostomy or a cutaneous pylostomy. So what are the types of vesicostomy? In the literature, we have many types of vesicostomy, like the lapidus flap vesicostomy, commonly done procedure is the bloxam vesicostomy. And there are some other procedures like continent vesicostomy where the child doesn't leak. It's a continent vesicostomy and the button vesicostomy. So I'll be covering briefly about these types of vesicostomy. So you know Lapidus. Lapidus, we've heard him. He is a pioneer who has taught the world about CIC, self-clean intermittent catheterization. So Lapidus flap vesicostomy, it involves the creation of a skin flap and a bladder flap. The idea is to create a wide tension-free anastomosis of bladder to the skin. It is initially described as a semi-permanent type of vesicostomy in adults where bladder is situated deep in the pelvis. So this is the original article published by Lapidus way back in 1960. How he supports this procedure is the difficulty in approximating the bladder to the skin can be alleviated by forming a flap from the anterior wall of the bladder and swinging it upwards to the anterior abdominal wall. And the stricture formation is a very common problem in vesicostomy. So the stricture formation can be obviated by using a skin flap, which is turned downward through the stoma to be incorporated into the vesicocutaneous channel. So I have some textbook diagrams for this. See here, there's a horizontal incision is given suprapubically. The bladder is exposed, peritoneum is pushed forward, and a skin flap is created. Another incision is made about 4 to 5 centimeters above the bladder incision, a skin incision. You make an inverted U-shaped flap. So I raised a skin flap here, and you make a bladder flap. So we are making two flaps. One is a skin flap, the other is a bladder flap. So the bladder flap is rotated, swinged upwards, and it is sutured here. So this forms the vesicocutaneous channel. And the skin flap is rotated downwards, and it is sutured to the, so the skin lining forms and goes into the bladder lumen. So that's how we obviate the stricture. The vesicocutaneous stricture is obviated by forming a skin flap here. And the stricture here at the vesicostomy side is again obviated by suturing the bladder flap to the skin. This is the Lapidus flap. Though it's a little tedious to reconstruct, Lapidus says that this has got least amount of complications compared to the bloxam vesicostomy. Now coming to the commonly performed bloxam vesicostomy, it was described again way back in 1957. It was modified by Rinker, Caffery and Witherington. Of course, Duckett popularized it when he used it for posterior urethral valves. The key steps are, again, mobilize the bladder to expose the dome. Here, you have to identify the urachus. So you have to mobilize the bladder till you see the urachus, divide the urachus, and make a wide cystotomy at the base of the urachus by giving a circumscribing incision. And the other important step is you secure the detrusor to the rectus fascia, and the next step is stoma creation. This is how it goes. You give a horizontal incision here, identify the bladder, go to the dome of the bladder. Here we have divided the urachus. Then fix the bladder to the rectus. This is very important to prevent the retraction. Detrusor is fixed to the urachal rectus sheath, and then bladder is opened, and then a wide vesicostomy is made. The full thickness of the bladder is sutured to the skin. So these are again the same thing shown here. So the key operative step in bloxam vesicostomy is the posterior bladder wall should be taut. If it is like bag-like thing, then there is a chance of prolapse. So the key step is by bringing the dome of the bladder to the skin. So the dome of the bladder is brought to the skin to prevent prolapse of the back wall of the bladder to the incision. This is the key operative step. So coming to the bloxam vesicostomy is used not only in the children but also in adults, in neurogenic bladders or in adults with severe dementia, elderly patients, where it is a very good form of bladder drainage. By obviating, we can avoid a long-term catheter drainage, either SPC or a PUC. The only problem will be it's incontinent drainage, and the patients have to wear a diaper. What are the complications of bloxam vesicostomy? This is a literature percentage of the complications. Prolapse of the bladder is a common complication. Here you can see this is one of our patients, a child with a neurogenic anomaly. We did a vesicostomy and the bladder mucosa is prolapsing here. Then the stomal stenosis about seen in 3 to 12%. Peristomal dermatitis because of the urine irritation. Bladder calculi, even though you're diverting the urine, sometimes the bladder calculi can form. And parastomal hernia, like any other stoma, parastomal hernia is one of the complications. So this is one of the, whenever the vesicostomy, there is a lot of urine leakage and the child is always wet, the child can't see properly. So there are certain diapers available they cover the entire back and the buttocks region. So whenever there's urine leak in the nights, the diaper absorbs the urine, the child can sleep comfortably. So this is called a soaker stopper diaper extension used in vesicostomy children. The third type of vesicostomy is a button vesicostomy. It is again a simple procedure. It is used as a short-term, medium-term continent urinary stoma. It is a continent vesicostomy. Here the gastrostomy tube, where the gastroenterologist use for a long-term enteral nutrition, the gastrostomy tube is placed in the bladder. Indications again the same, can be used in neurogenic bladders, hypotonic bladders, obstructive bladders. This is the button vesicostomy. This is a gastrostomy balloon. It has got this is the tube which is placed into the bladder, and the balloon is inflated. And whenever the child bladder needs to be emptied, this catheter is connected here, so the urine is emptied, and again the button is closed. This is the opening. If it gets closed here, this is called the button vesicostomy. The other types of continent vesicostomy, there are so many variations are described in the literature. The most commonly performed one is a Mitrofanoff, where the appendix is used as a continent catheterizable stoma. The other types are vesicostomy, the bench crown stoma, where a segment of ileum is taken and it is intussuscepted, and the intussusception acts as a continent valve. We can also use take a small piece of segment of ileum, detubularize it, and use a Monti principle. And when appendix is not available, you can use a Monti configured a small bowel, and it can be used as a continent catheterizable stoma. And Nissen plication also can be done. Then another modification described in the literature, tube vesicostomy, continent vesicostomy, where a flap of the bladder is taken from the dome, a tube is created, and here you see the rectus muscles. There's on the both sides, right and left rectus muscle, you create a plane, and a bulk of muscle, a strip of muscle is taken, and this tube is turned, or you can make it inverted through the rectus. You bring the tube again, and when the tube is brought through both recti form as a continent mechanism for the vesicostomy. So this is another type of a continent catheterizable vesicostomy. Again, ileum can be used. A patch of ileum can be directly anastomosed to the bladder and can be brought outside as a ileal conduit. This is called ileovesicostomy. So what does the literature say about this vesicostomy? This is a paper where they have studied 50 consecutive patients over a 10-year period. And during this period, they found that there was improvement in the upper tracts. The upper tracts which were dilated, there was some improvement or stabilization. And the ureters which were dilated, the dilatation decreased, or in some patients it normalized. And they also decrease the degree of reflex. And when the reflex decreases, there's a decrease in the need for ureteral tapering when you do a reimplantation. This is another paper where they have studied about the temporary vesicostomy in pediatrics. What are the predictors for morphological or functional improvement? The paper says that age less than 1 year, abdominal swelling, hydroelectronephrosis, grade 5 VUR and recurrent UTI are independent morphological and functional predictors for the improvement of the child after vesicostomy. So can transient resting of the bladder with vesicostomy reduce the need for major surgery? Suppose you do a vesicostomy in a VUR, can you avoid a reflex surgery in these patients? They found that the cure rate was 95%. So the recurrent UTI incidence can be brought down to 95%. Secondary VUR can be brought down to 80%. And primary UR also, the resolution is about up to 40%. So the authors conclude that vesicostomy should be considered in children with neuropathic bladder outlet obstruction in case the first-line therapies fail. This simple and reversible procedure can reduce febrile UTIs, protect the upper urinary tracts, and reduce the need for major surgery without decreasing the bladder capacity. This is another paper about the use of vesicostomy in neurogenic bladder spina bifida. It can be done both in children and adults. Another thing, whenever the child voids, if your child has got a vesicostomy and the child voids pariurethra, it is a failure. It is an indication that your vesicostomy is not functioning. So voiding pariurethra is an indicator of vesicostomy malfunction, and a temporary stoma-free drainage. So you put a catheter into the vesicostomy, and then the voiding pariurethra stops. So it can be a diagnostic or a therapeutic option when the child is voiding pariurethra. So coming to the closure of the vesicostomy, you have created a vesicostomy and the child has improved, the upper tracts have normalized, the creatinine has improved, you have ablated the valve. Now you want the child to void pariurethra normally. In such instance, you close the vesicostomy. Closure again is a simple process. You again give a circumscribing incision around the vesicostomy with a skin collar of normal skin, divide the subcutaneous fascia, identify the place where the rectus sheath is attached to the bladder, divide those attachments, completely mobilize the bladder. Bladder should be completely free from the attachments to the rectus muscle, and excise the part of the bladder which is adherent, and then close the vesicostomy. You can put a catheter, you need not put a catheter like an SPC. Close the bladder in 2 layers and put a periurethral catheter till the bladder wall heals. So to conclude, vesicostomy is an effective form of urinary diversion. It is easy to create and reverse. It can protect the upper urinary tracts and reduce the need for major surgery. Thank you. Thank you, sir. Mic is.
Hello, hello. Yeah, there are two important complications which you all come across. One is the stenosis of the vesicostomy stoma, and another is prolapse of the bladder. If you are too wide stoma you did, there will be a prolapse.
Yeah.
So what are the technical points you observed during this?
So we can even teach the parents, like apply some jelly to the little finger.
I am telling, during
the
surgery, what are the technical points you have to observe?
So to prevent stomal stenosis, we have to create a wide vesicostomy, fix the rectal wall, rectus to the bladder, and full thickness of the bladder has to be anastomosed to the skin, a wide vesicostomy. That's most important to prevent the stenosis. Again, to prevent the prolapse, as I said, the dome of the bladder has to fix to the skin. So if it is too wide, again there is risk of prolapse. It happened to one of my patients. I showed the picture. So I think prolapse is easier to manage than stenosis, because stenosis, the purpose is lost. Purpose of creating a vesicostomy is lost. In literature, it is mentioned that the parents can be taught to prevent stenosis. You clean your finger, dip in betadine, and if the parents can then they put a finger into the vesicostomy to prevent stenosis. It is described in one of the Cincinnati's website. I was just going through it. The parents can see and assess whether it is stenosed or not. That is one of the ways.
So I would like to ask Dr. K. Ramaraju here. Ramaraju? Sir? Make some comments. Oh, sorry. Yeah.
Stenosis is a real problem, but ideally when you do the vesicostomy, your forefinger should easily fit into that. That should be around 50 French or so. And main problem why, despite that, if the stenosis occurs, is mostly because the mucosa gets denuded in contact with the garments. So probably you have to apply some antibiotic creams. Yeah. The other thing you mentioned was the ureum ammoniacal dermatitis. Yes, yes. I think it's important to tell them to apply this zinc cream. It comes as Siloderm liberally around the stoma. That is another problem. And the third thing is, of course, the prolapse of the dome, which you amply covered. It's very important to go tease the peritoneum of the dome, go up to the urachus, excise that little segment, and then bring it out. I think we have very clearly. It's a wonderful operation. But while we are here, I just wanted to talk about the role of vesicostomy to Dr. Gundeti about, if I'm not deviating, it's an extremely important subject, because if you look back in my days as post-graduation, the literature was full of the diversions, the ureterostomies and vesicostomies, especially the Boston group, and then the wall fulguration primarily, in all cases, was popularized by John Duckett. But then, sometimes what happens is when the concepts are promoted by very big-time people, the reality gets lost. One thing was, when a child was very sick and you don't know how lousy the bladder is going to be, you fulgurate the valve and then allow them to void. Just the kidney is about to recover from the high pressures. But if this child were to have a wall bladder, the progression of the improvement of the kidney will not happen.
Yes.
And that's when you go for
Diversion.
a bottom-up approach. But then there was one paper by Churchill and Kruger from Toronto children, which was an excellent paper written in Controversies in Urology, where they said, the child is sick, don't bother about valve fulguration primarily. Directly go for a vasectomy. The vasectomy would protect the kidneys to the maximum. The child would be optimized for a couple of years or so.
Yes.
Then kidneys would have recovered to the maximum without further onslaught from the bladder dysfunction. Then do an antegrade fulguration, which is the best way of fulgurating the valve. Then you undivert. They published a very huge series where they said the renal growth is better, the somatic growth of the child is better, but then Urological Society did not pick it up. So do you have any comments to make?
Yeah. So thank you. There is definitely a role. It's, as you mentioned, it's a wonderful operation, life-saving operation for a child. And there are two ways you can do. One as a primary operation, and second as a secondary operation. The primary operation is, especially if you look at the kid with a posturethral valve, bilateral hydronephrosis and thick wall bladder, and child is acidotic, his renal function is not that great. You put a catheter, he doesn't improve well. And you know that even if you fulgurate the valve, this kid is not going to do better. And primary vasectomy is a good option for the child to recuperate. Not only renal function, but physiologically. The acid imbalance, the electrolyte imbalance, so it sets up very well. In regards to the secondary, I think as you correctly mentioned that you could valve ablate and see how things go, but if the kidneys are decompensating, his creatinine is increasing, and he's getting infected repeatedly, I think then secondary role of vasectomy is there. So it's still around, it's not popularized or it's not under-popularized. And the one paper you mentioned, Toronto Sick, was right, but the second paper we looked at it, Guy's Hospital, that what happens, in 10 years afterwards. So what we saw is there is a marked difference up till about 2 years in regards to their growth, development, renal function. But after 2 years, it doesn't change much. So those 2 years which are critical, you really save their life in all the aspects. So there is a great role of it. I'm really fond of operation when it is needed.
I just want the students to remember that there are operations beyond endoscopes, and you should use your discretion to make sure that the patient gets better. Use all the options available.
Sir, I think you brought out a great and important issue today, because I see a lot of people, whenever they see a valve, start telling us that you fulgurate the valve or you do vasectomy, it doesn't matter, the whole overall outcomes are the same. They are not the same. Not all valves are same. There are people who have posturethral valves who lead a normal life. There are children who with posturethral valves go into renal failure at various stages of life. The most important thing we need to realize is when there is an obstruction in utero, the bladder develops in a different way in each child. Now, why it does, we don't know. That is the greatness of medicine. And that's the biggest thing in pediatric urology, that we still don't know what exactly happens. It can be that there can be only 10% to 15% collagen in the bladder, to there could be 85% collagen in the bladder. So these bladders are extremely plastic and they're non-compliant. So we just don't know what they are. So we need to look at carefully a palpable bladder in a neonate. Those are the sepsis. Those are issues which we need to look at doing vasectomies. I don't want anyone to argue and tell that one paper says, okay, both long term is fine, and so you just do a fulguration. I don't think that's right. We need to look at each child very carefully and decide what would be the best. But if at all you have to err on the side of vasectomy, not on the side of fulguration, because fulguration can always be done later. Nothing will stop you doing a fulguration later. The child is either way incontinent, whether it is through the urethra or through the abdomen. So if you have to err on the side of vasectomy. Sir, what would you?
Yeah, Dr. Mohan, just 1 second. This is what I would like to know. See, the primary now, the indication is endoscopic fulguration for all PUAs. If you see the recent series and all that. Primarily, if you got a miniature or neonatal scope, go and do this one. But there are, as you said, there are bladders which he mentioned, Dr. Ramaraju. They're terrible. They're thick-walled because the entire thing damage has happened in the utero, circulated, and the child will not resolve. I mean, will not settle down just by doing a fulguration. They continue to have problems. So how do you select, and how do you select your patient there, whether he is going for a vasaectomy or a primary fulguration?
Yeah. So I think, as I mentioned, the primary fulguration still is an option. But if you see a child who has a very thick bladder wall on ultrasound scan, huge hydrouretronephrosis, biochemistry, renal function is not that great. He's acidotic. He is decompressed with a catheter in place, but still is not improving. And this is a kid who is not going to do better in spite of you doing a valve ablation, because patient is decompressed with a catheter in place and is not getting better. That means even if a valve ablation and recycled and he's voiding, he's not going to do better. So I think it gives you an indication that, this is a patient, I think we should just go for vasaectomy and save the life, and then, think about later things.
So primarily we have to catheterize and see the reversible factors.
Correct.
But how long you see?
Usually I leave a catheter at least for 3 to 5 days.
3 to 5 days.
Minimum 3 to 5 days to see, what's the trend. Are you seeing a trend? Then, it's fine. But if you're not seeing a trend, or while he's on catheter, if he's getting an infection because the systems are not draining well, then I think, this is a place, I think, bigger drainage will help.
Yes, can I go to other topic? Dr. Mallikarjun Reddy, catheterizable stoma.
Thank you very much, Gopi, for this opportunity, and nice to connect back with Mohan after a long time, and Murthy sir, Raju sir, and seniors. Gopi has given me a huge area to talk, and if we really have to talk about this area, I think the pediatric urologists over all these ages have never gone, they still have words to describe and discuss about all these things. So I'll try to get an index case and then get a little discussion on, and then I feel that probably if we interact, there are some other issues which can go on, because there is no dogma, because whatever I show you is not the 100% thing which we need to look at that. So the index case is a 12-year-old smart girl who has a neuropathic bladder due to a myelomeningocele, which was corrected as a neonate. At the age of 5, she started developing febrile urinary infections. As usual, we don't get much referrals from till some problems happen, which required hospitalization, and she was incontinent in spite of intermittent catheterization. So I'm just stressing that she was incontinent in spite of intermittent catheterization done every 4th hourly on anticholinergics. So what happened subsequently? She looked smaller for age. Obviously, she wasn't growing because of recurrent UTIs and possibly some amount of renal dysfunction. She was in a wheelchair. She is plastic paraplegic, but hands are good. Okay. So all these things make a difference in how we go ahead and then treat this particular young girl. The basic chemistries are normal. Urine analysis, as usual, gross E. coli. Ultrasound, as expected, shows bilateral grade 4, grade 5 hydronephrosis, scarring, dilated ureters till the bladder, and a thick trabeculated bladder wall. So let's get to a summary of this particular child. Myelomeningocele, operated, recurrent UTIs, on clean intermittent catheterization, voids in between catheterization or leaks in between catheterization, and then growth is stunted. So with this particular scenario, this time, there are 2-3 things we need to look at treating this child. One is we are looking at treating recurrent UTIs so that the renal functions do not fail. We also look at treating the incontinence between the clean intermittent catheterization so that that particular child is dry and sociable. And then we need to make sure that this child becomes independent. Now, she can't be dependent on her mother for years together. She's on a wheelchair. Though her hands are good, I don't think she can actually catheterize herself because she is plastic paraplegic. Her legs are spastic, they're done, they're closed down. So these are the issues which confront this particular child at this point. So these are 2 different MCUs, what I'm showing. This is the one which the child has. These are different MCUs. The reason why I put up this little difference in the MCUs is, now you can see that this is a bladder which has got multiple diversaculations and then reflux on one side and obstruction on one side. But what I want to tell you is, if you want to look at an MCU, make sure that you look at the urethra. Now this girl, I would probably not look at doing anything or doing something just like that without knowing what the bladder neck is. If the bladder neck is incompetent, even if I do something, I will end up having incontinence in this particular child. So I need to look at, so the completeness of an MCU is important when we see these kind of children. So make sure that MCU always gives you the urethra. Get the catheter out and get it. And the differential functions were fairly okay, that both were functioning well. And as usual, as expected, the urodynamic study showed poor compliance with a 70-80 ml capacity with a detrusor leak point at 60 ml of water. Now, what are the options we have here? First is to try to escalate the dose of anticholinergics. Should we do that? And before that, what are the things which we need to look at? We need to see whether what has happened to the urodynamics, has it changed its patterns, has the bladder changed its patterns, or were the dose of anticholinergics adequate or not. But then how long would you probably give them before you make a basic decision? 6 months. The child is around 12 years, wants to become independent, mother is becoming old. The option which has come recently would be Botox. Now, why I'm discussing these options is, not all children are spastic paraplegics, not all children with neurogenic bladders are on the wheelchairs. There are a lot of children who are up and about and who do catheterize themselves, both males and females. So if someone is voiding in between 2 episodes of intermittent catheterization, let us realize and recognize that this bladder capacity is low, it is hyperreflexic, it is putting out the urine. Now, why is it doing? Is it just only hyperreflexia, or is it hyperreflexia associated with any abdominal pressure? All those things are secondary. But there is something which is not, that the bladder is not adequately, the pressures are not adequately controlled within that 4 hours. So, yeah, Botox, is it a possibility? Yes. Botox in children today, yes, we can give. We can very safely give 200 units of intradetrusor Botox. It does improve the capacity of the bladder, decreases the hyperreflexia, doesn't do much about the compliance. We need to realize when we talk about compliance, compliance is the pressure for that particular amount of bladder capacity, that if it is poor, that means it is plastic, that means that amount of detrusor is less, the amount of collagen is more. So as long as the collagen is more, all the options which work on the muscle will not work in that particular bladder. So in these children whose compliance is too low, maybe Botox would not be an option. The compliance is okay, but with hyperreflexia, Botox comes into play at this point of time. What next? Next would be an augmentation. Reasons why we should augment this particular child is the bladder capacity is low, 70 to 80 ml. So we need a capacity for a 12-year-old for about 200 to 50 ml so that she can stay dry for about 3 hours or so. Plus, we need to do a continent catheterizable channel. Whether it is Monty, whether it is Mitrofanov, whatever is an option, you can. For me, as a person, if I am doing an augment, I will choose a Monty. Why will I choose a Monty? I probably leave the appendix in case the Monty fails, so that only if I need a catheterizable channel, I can as well pick up the appendix later. But then these Monty channels are much larger, so you can have a larger capacity catheter going in. The bladder empties, you can have a 14 catheter going in through a Monty channel, and you can empty the 250 ml in a matter of 5 minutes. Otherwise, in a Mitrofanov, you will have a 10 French catheter going in. You will take 20 minutes, and people, if they don't empty the bladder fully, you end up again having UTIs. That's number one. Then you end up having stones. And all of us have looked at augmentations. You will not be able to empty the bladder initially with all the mucus if you have a smaller channel. So augmentation with Monty or a Mitrofanov or a catheterizable channel is a very important thing. The second thing, what this does is, because it brings it either into the umbilicus or into the iliac fossa, whichever is comfortable, this particular child becomes independent of a caregiver. She will be able to catheterize herself. Now, I am purely looking at this part of it, but most of the time these children are also constipated, and they also have fecal incontinence. And for these, if you have to add a mace, where you bring the appendix out and then put a antegrade enema here, that's where this child would probably be also fecally continent, because it empties the whole colon. But if you have to do a mace, you would not have the appendix to do the Mitrofanov. But then there was someone who could argue with me, saying that the long appendix, you can do a split appendix. For a general scenario, you do a mace, you do the Monty when you are augmenting. So this is one which we are looking at, ileum, which is the ideal segment for me to augment. And this is the split Monty, double Monty, which I am doing. I was doing a double Monty. I switched over to spiral Monty. I am happy with both of them. There is nothing wrong with doing either of Monty. I am thankful to Surya Prakash for bringing in and putting the diagrams before both the Monty and the Mitrofanov, so that people can understand what it is. So this is how you have anti-mesenteric cut on both the sides of a small segment of ileum, and then you create this Monty. This is how the tube gets created. You create a serosal trough which gives you continence through this, and then you implant it into the bladder. Now, if you have a good large bladder, you can do the Monty into the bladder. But if you don't have a bladder, if you have a very small bladder with a thick bladder, you probably tend to excise that little useless detrusor of the bladder and do the augment. And in that case, you do the serosal trough, and these are continent catheterizable stomas. And this child has got a capacity of 300 cc's on CIC. And these children are on lifelong follow-up. An augment is a lifelong disease for them, and they have lifelong. If we are not committed to do the augment, I don't think we should not be doing any augment in these particular children. So I leave this at this point before we go to the Mitrofanov. Sir, can we have a little discussion before we go ahead?
When you have seen in a child like such a horrible bladder and all that, and also the point is that child is leaking in between. So you still want to wait for some time with anticholinergics, because if they are put on anticholinergics with that sort of a bladder and that sort of a scenario, the whole lifelong anticholinergic scenario, and with such a horrible small capacity tuberculated and sacculated bladder, so would you want to pick up surgery first, or you want to still try out anticholinergic and then proceed? And also you spoke in between about
Botox.
Botox again, it is a recurrent expenditure, I mean, the results are not good in everybody, maybe 60% benefit, 40% don't benefit, and it lasts only for max of 6 months. So ideally, what would you pick up if you have a child like this?
Yeah. The reason why I put these three options is, this is just not that one case which we are going to see. We will be seeing a huge number of these neurogenic bladder children who are on CIC, who are well up and about in the society, they are going around, who do leak, who do CIC on their own, but still leak in between, and that's a huge social problem for them. So when we look at those kind of children, should we go ahead and then operate on them and just expand their bladder? I think the answer is at this point, no. Now, this case, I don't think there is a role for any looking at a long-term anticholinergics in this particular child. But the why I made that up is, let's not look at that surgery is the only option. Now, this where the urodynamics would decide for us. The compliance is one which decides that the poorly compliant bladders would not probably respond to these medications. So we need to look at straight away whether those kids who are up and about, those who are fine, are we really treating them fully? Do they get the full dose of anticholinergics? And then if we can do that, there is a very important issue which we all should realize is that we should postpone the augment to the last. If you can postpone the augment to eternity, it is great, because when we put in something which is foreign to the urological tract, we are bound to have some problems, and these children have to be on follow-up for lifelong. After 10 years, you have a very higher risk of malignancy and all that. So that is one segment to answer your first question, whether we should look at an anticholinergics or not. The second question of Botox again comes the same thing. She told you that there is a young girl who had a kyphoscoliosis, came with a neurogenic bladder, was on anticholinergics, then she was not improving. Now, these children, some of them would not improve in spite of a higher dose of anticholinergics, even though they are compliant. Now, she was offered Botox. The Botox worked wonderfully well. The good part of Botox is the first thing comes anywhere between 4 to 6 months, once it works. From then on, every dose of Botox generally comes for about a year. So we need to repeat that once in a year. And how long can you repeat it? Yes, we can repeat somewhere between 6 to 8 times, not beyond that. So this girl went on to do her MBBS. The final year of MBBS, she tells me that, sir, I am feeling sleepy, extremely sleepy because of tolterodine and solifenacin. I am not able to study. So again, she skipped the Botox doses in between. So we had to put her back on Botox. So there are cognitive issues which come with these anticholinergics, which we need to realize that in children too, they go to school, there are cognitive issues which will come up. So that's where the Botox comes. Again, if you look at this case, Botox would not work because the compliance is poor. Wherever the compliance is poor, I think the medications in the Botox are not the way to go forward. We'll have to look at different modalities to look at that.
Closing the urethra if the leak is troublesome, or leave it as a pop-off valve?
Sir, my option in these cases where the bladder neck is incompetent is to sling up the bladder neck and give it a little more tension and pressure to allow a little pop-off. But as you said, the standard is to transect the bladder neck and close it so that they are totally leak-proof. Now, what I do, because we sling up the bladder neck and then do it, yes, there is an issue sometimes that these particular kids can have incontinence in between. But then the good part of thing is if they have incontinence at level of 400 or 350 ml of bladder, they should know that they need to catheterize. Closing the bladder neck, if at some point of time, if you have to redo the bladder neck, it is difficult. By slinging up the bladder neck, it's much easier. Ultimately, we just want to see that the bladder neck pressures go up and then they don't leak at that particular pressure. And if it leaks, if this leaks, then I'm also have to be careful whether the bladder is it changing its morphology. That means we have left a large amount of detrusor in an augment. A bad detrusor should not be left on the augment. No, we just use a proline. We go around the bladder neck, sling it up to the rectus, The advantage of that is even the child coughs or something, the rectus will pull the bladder neck up, and then it tends to give you the whatever extra closure effect which it needs to give us.
Sir, apart from Mitrofanov and Montes, is there any procedure, as you are doing anyway augmentation, taking out this ileal, making a small valve-like thing, any procedure like that?
I'm not very sure about the whole thing, but I am happy these two work in my hands and I don't do anything beyond that. There are these nipple valves and all these things, but I don't do them. I'm extremely happy working with these, and I feel that these two will fit almost all the children.
Okay, thank you.
So I'll just take you off on a small segment for a Mitrofanov. This is a 15-year-old child, post-PUV fulguration, 1 year of age. As usual, lost to follow-up. Parents say the boy was absolutely fine. Comes with nocturnal enuresis. You do an ultrasound, shows bloated kidneys, you have a large bladder, significant post-void residue, and then you do a urodynamics and shows a poorly compliant large capacity bladder. You teach CIC, the child is non-compliant, parents are non-compliant. Now what? The only option we end up would be a continent catheterizable stoma. And these children, I would prefer the Mitrofanov as a first option because we don't really need to do any anastomosis. Again, I would thank Surya Prakash to giving up the line diagram so that people would realize what it is. There are different ways of looking at doing a Mitrofanov. There are people who would probably put the appendix back into the posterior part of the bladder, or they could put it to the anterior of the bladder. They bring the stoma to the appendix, the umbilicus, they can bring the stoma to the iliac fossa. I see wherever you get a straight stoma, whether the stoma is straight to the umbilicus, I bring it to the umbilicus. If the stoma is straight towards the iliac fossa, I bring it to the right iliac fossa. The other important thing which I would definitely do here or err on the side is to do a larger submucosal tunnel, because I would have an obstructed, sort of an obstruction on a submucosal tunnel rather than a leaking stoma, because if the stoma leaks, you have very few options to do anything. There are papers who have said you can put in deflux, you can do a lot of things, but if the stoma leaks, it's very difficult to treat. You'll have to redo the whole thing. And if ever you had a chance to redo a Mitrofanov, you won't have a Mitrofanov. You will end up doing a redo Monty. Very rarely you can get the appendix back. So this was one of the robotics which we had done. So, and the bigger problem in this is you have to really be extra careful in putting the submucosal tunnel. Even if you do a bladder, you fill the bladder and see and the appendix doesn't leak, but still it would leak later. So this was the thing which was coming, but you have anchored the bladder up and then you push it down, you have a straight stoma. There are many ways of doing it. That's what I was saying. Then this kind of appendix you can actually have split. We actually transected this part here when it came out, and then this was a straight appendix because there was a lot of redundant appendix here. And the most important thing I do is to catheterize this particular thing with a full bladder, full or overfull bladder, and that too by my scrub nurse. Because as urologists, we know how to manipulate these catheters across. But then these children have to be catheterized by their mothers or fathers or themselves. So if it has to be done by someone else who is not a urologist, it has to be my scrub nurse who has to do it. And not less than 10 to 15 times they have to do it with a filled bladder, empty bladder, so that the anastomosis is patent. The catheter is, the egress and ingress of the catheter is smooth and there is no obstruction. So I'll just take you to another small case of case with a child with constant, continuous incontinence. She had bladder neck incompetence, and then we did she had a duplicated ectopic ureters, and then we did a robotic bladder neck reconstruction, young D's. So this was a cystoscopy. So there was an issue when we did a cystoscopy, we couldn't really find the ureteric orifice. So we just did an ICG to find the ureteric orifice. And then we're creating the transverse flaps. You have a 12 French catheter here. Someone can probably say that you would have probably looked at a smaller catheter. That was fine. So we create this flaps, and I love this young Ds. But not always young Ds works for, these are bladders which are not neurogenic. So young Ds should be a good option for these. In a neurogenic bladder, we may probably need a crop or something which has much more longer length, and then which gets much into the submucosal tunnel, so that we have a continent child. There's a big issue here in terms of we have to err, where we should err, whether we should err towards total continence, or whether we should err towards a little incontinence and still go ahead doing it. So now this is always a discussion between the clinician and the parents. There are some parents who and the child. If the child is old enough, the child say that probably I may take a little incontinence, 1 or 2 pads in a day or 2 pads in a day, and then I still allow me to void. So maybe we can do a bigger urethra. There are people and children and parents who feel that irrespective of whatever it is, we don't want a leak. Then we probably have to do a very tight bladder neck. Nothing is guaranteed, but we have tight bladder neck. Then the Mitrofinov comes into play. So we have to do a reimplant and then a Mitrofinov so that they catheterize. Almost all these children, we would, for a few months at least, if they could void, we make sure that sometimes they cannot void, so they need a Mitrofinov for clean intermittent catheterization. So this is one thing which was done. I would leave you all with these things, and then I think we can have some discussion on these particular aspects as well too. Thank you very much for your patient hearing.
Malli, finish?
Yes, sir.
Yeah, I invite some questions or comments from the, yeah.
I'd like to ask about the bladder neck reconstruction. If we are planning a Mitrofinov along with the bladder neck reconstruction, should go for a Kenneth Krop, because that is much more, because anyway he's going to do a CIC through the Mitrofinov. If we are planning a young D, or if you do a reimplant like a Leadbetter procedure, then it is better to not do this, because you want normal voiding. My issues with after doing young Ds is you are never sure of the exact predictability. Sometimes it works well, sometimes it doesn't. We have to double breast. Would you consider in a slightly older child to put a artificial sphincter? Because that is much more reliable in the sense, occasionally you may have to revise it, but in an older child who was almost completed the growth potential, artificial sphincter offers a much more reliable method of bladder neck control than the reconstructions. Because reconstruction we cannot predict, always.
Agreed, Arvind. I know that you have been with Dr. Ganesh, so you would definitely speak on the Kenneth Krop. But for me, I fully agree with your comment saying that you will not be able to definitely give a specific answer on a young Ds. But these are bladders which are not neurogenic. These are bladders which are not neurogenic. So feel that you give a little more pressure, these children grow up, and more so in males, that you start developing the prostate, you tend to get a better continence. I have these children one of my child who had to do the same young D, had to repeat the young Ds. He is an epispadic child, had to repeat the young Ds. Then he was lost for follow-up. I thought this fellow is going somewhere, he is cursing me. And lo and behold, he appeared just 5 years later, 5 days back. I was just wondering, what is this fellow coming and telling me? He said, I am quite continent now. So these people tend to grow over a period of time. The girl childs are a problem. Now the issue with Kenneth Krop is, I fully agree that Kenneth Krop would give you it's a fair guarantee that the child would not leak. But you are bound to do CIC in this particular,
absolutely essential.
in this kid. Now, why we do the mitrofenov at this point is because in a young days also there could be some amount of edema and the urethra would not allow you to and we don't want to do a CIC in these particular children at that point of time, not before about 4 to 6 weeks. So we would like a mitrofenov to drain the bladder. I won't like an SPC to drain the bladder because it tends to start, the mitrofenov will start cycling the bladder. Now the issue comes when you talk about a artificial sphincter. We all know that the artificial sphincters can never be lifelong. There are a lot of issues with artificial sphincters because they tend to erode, do all sorts of things.
So at the bladder neck we have to put. This is not going to be at the urethra, at the bladder neck.
Wherever you put, there's something which is totally artificial which you are putting. And if your bladder neck works, which is natural tissues which you have, there's nothing like that. Once it works great, and then you have no worries about the whole thing. You just need to follow up. If you have done a Kenneth crop or something like that, you need to follow up the upper tracts to make sure that this guy is doing a CAC properly and the bladder is not becoming defunct.
So have you done a Tanago? I mean, what is your opinion on the Tanago, if you can?
No, I have done a Kenneth crop. I haven't done a Tanago.
No, Tanago.
I haven't done a Tanago. Let me be frank about that.
If I can comment on the sphincter, I totally agree with you. There is no role of sphincter for pediatric patients. Even in the adults, our adult reconstruction surgeon does it, and he explants so many artificial sphincters every 3 years, 4 years, 5 years, and malfunction. With our pediatric patient, the problem is even if you put at a bladder neck, the erosions will have very difficult to go back and do even bladder neck closure. So I think the sphincter is out for us. It's not really a good thing for us. One question about the bladder neck, I will prefer to be dry and catheterizing than little bit leaking, because it's a lot of psychological impact on children, especially when they smell around 13 and 14 years. So I will err on tightening and say, you have to pay some price. Nothing is free in this world. You have to pay something. And I will have them catheterized. And I think, they will pay the price for that. And I think laid better in those works, very well. And reimplant, you may or may not have to do it. It's not necessary all the time. Probably 90% of the time, I get away without doing reimplants.
No, I agree. But Leadbetter is not a reimplant which we do because we don't want to go out of the bladder. So Cohen is the one which we would do. But if we think we need the bladder neck coming a little further and then it is coming very near the orifice, then we would look at reimplant. There is nothing hard and fast that we should be doing it. I agree with Mohan that we would like a dry child. But all of the time when we look at, we speak to the parents and then see. I have had 1 or 2 parents who said, sir, a slight leak or a little leak is okay, but don't err on closing it. But it is easier erring on going much tighter than being a little less tighter. It's easy on us also, because if you have to tighten it much.
What would you put? Would you put a 12 French? Normally when you do someone less than 10 years.
10 years I would probably do a 8 French feeding tube.
Yeah. I will do 6 French or 8 French feeding tube, and I really tighten it.
I do a 10 almost, because
yeah.
I'm afraid that if that sort of closes off, and
no,
then you'll
it doesn't.
No, it
I
doesn't.
really want to close, but it doesn't close.
It doesn't close. It will
doesn't
still
close,
have.
and it doesn't scar even on 6 French. I really want to scar, but it still doesn't scar. I don't know what happens. I think these muscles are much different than the real good muscles. And I think that's why when adult surgeons do the radical prostatectomy, they have so much high stricture rate when they, in spite of doing wide anastomosis. And I say, we tighten it on 6 French, and we really want tight, but it doesn't happen tight. So I think there is something dynamics different of these muscles.
And what sutures would you use?
I use actually PDS, 3O
PDS, right?
PDS
Yeah,
suture,
PDS,
3O, and 2 layers, and it doesn't close.
And even double breasting, all that, it doesn't close.
It doesn't close.
I think closure of the bladder neck is the most failed operation.
Yeah, right.
Most failed operation.
Yeah, I agreed.
So I know one person told me they actually multiple sclerosis, the leak was so much. They actually divided the urethra, closed both ends, and still she leaked.
Yeah. Somehow they reunite. We don't know. Even if you put a omental fat transposition, they still it's tough thing.
That's exactly the closure of the bladder neck to make it 0.
Most difficult.
And the worst
that
part
is
is you
true.
want it to fail, you don't want it to fail. This is one place you think you do whatever and it closes, it doesn't close. For some reason it doesn't close, as Mohan said. We haven't had a stenosed bladder neck, exposed bladder neck. The biggest problem with the bladder neck closures is a leaking bladder neck.
Malli, of
Sir.
course, this is not your point of talk. What about the slings in urogenic bladder for incontinence?
Sir, I would probably prefer not doing slings in urogenic bladder because I think there was
I have
one.
done a couple of slings and
There are people who do
dry,
slings.
completely dry.
Correct, there are people who
With
do.
anticholinergics.
But
they do the CIC.
Sir, I think one statement I would like to make, but not mine, let me not own that particular statement. It is that when we make an incontinent child continent, that is where we are putting their upper tracts in jeopardy. No, it's not for you, sir. It's not for you. So slings, if you are doing slings in this thing, I personally don't do. I have read about these slings where you can increase the urethral pressures. If there is, the bladder is fine and there is a bladder neck which is open, there are people who have done that. But if closed bladder necks, I don't think there is a role on slings.
Dr. Mohan?
Yeah, I agree. I think, children are growing. It may work for a year or two, but everything changes, isn't it? The physical tension, the stress, the muscle growth, again, it's temporary. So that's why we don't do it. The biggest paper is from Tom DeJong, and he has just about 25-30% success rate.
Netherlands.
And again, just 2 years, 3 years. So there is no role compared to how you do in adult, the slings, they work beautifully.
But I think basically it alters the outlet resistance to certain extent. For a very short period of time, the dynamics of the bladder changes as it passes out. With the outlet resistance, the high pressures will start happening. With the growth, there is a change in the bladder dynamics. Both result in a change in the whole dynamics. So sling is only temporary.
No, the pressures are already there. What the outlet has done is it has safeguarded the upper tracts.
No, that's
now
exactly.
you increase the upper.
No, we increase it and it will become more pressure and it will leak again.
All this will again, the pop-off goes out to the kidneys instead of what it was supposed to go out. So I think a leaking child is much safer than a continent child in this, in most of the situations.
Till he leaks, he is there with you. Once he stops leaking, he goes to the nephrologist.
Then they'll come back again with a bigger problem on our head.
Any more questions or comments? Thank you. Thank you, Tony.
Thank you very much, everyone. Thank you for your patient hearing.
So next we'll have your talk. And next we'll have Dr. Mohan Gundedi's talk on pyeloplasty. And I request Dr. C. Mallikarjun sir, Dr. C. Mallikarjun sir to take be as chairperson, and also he will also have a talk. It will be a discussion between Dr. Mohan and Dr. C. Mallikarjun regarding pyeloplasty.
Thanks.
Thank you, sir.
Thank you, Gopi. You have this? No, you have to put it to the laptop. Thank you.
Your talk?
Yeah. Okay. Oh, yeah, there you go.
Oh, there you go, beautiful. Wait a minute. Okay, okay, beautiful, that's great. So that's Chicago Spring, and it's really beautiful but cold, and I'm really glad here. There were a lot of issues with the travel and something on the road, but thank you Gopi and thank you all the team, and I'm here now. I want to share some of the talks. I put in 3 talks together. We have reflux, we have a duplex kidney and pyeloplasty. So we could start with the pyeloplasty. So it's going to be a little bit of more interactive, and we have a lot of postgraduate students. Okay, perfect, okay. So Mallikarjun and Gopi have been very near and dear to me, and again, all of you, I get to know you from 2 years ago when I was here for a workshop and a conference, and Gopi and Mallikarjun have been formed of, for last years of our association. So this is University of Chicago. It is a small oasis on the south side, a beautiful campus, about 15,000 students, 5,000 postgraduate students, and the medical center employs 15,000 people. Out of those, 5,000 are doctors. So this is like a small village, and we are probably about total 100,000 people. That means 1 lakh people in this campus working every day. I'm really proud because, as all of you know, Dr. Charles Huggins was the only urologist to win the Nobel Prize in entire history for his prostate cancer research. So before we start with the pyeloplasty, I want to take you through, because the problem starts prenatally, okay? So this prenatal consult I saw a couple years ago. She's a 32-year-old, coming with a left hydronephrosis, fetal side. And the question comes in, when the baby is born, when to get the ultrasound scan, when to get a VCUG, and why we need to get a VCUG, and how to counsel this family. So this is a prenatal scan, and if you see prenatal scan here, this is a hydronephrosis on the left side, that's a fetus here inside, and you can look for other kidney, how it is, you can look for the bladder, and then also look for other parameters about echogenicity, amniotic fluid, and make a decision that is it safe, how the kid needs to be counseled, what needs to be done. Now the biggest mistake is done is once the baby is delivered, you ask for an ultrasound scan. And my urge is you don't have to rush to do ultrasound scan unless it's bilateral, unless there is a bladder anomalies, unless there is an anhydramnios, oligohydramnios. You can wait because there is underrepresentation of hydronephrosis in the first week of life because of the neonatal dehydration, and as we all know. So this is what you see here on the first day. But if you look at in about a week or 2, then you can get a real representation. So urge is get the ultrasound scan in about 4 weeks after once the baby is born, as long as there are no other indications where the baby is unstable. Now the question comes in, when should we get a VCUG? Does everybody needs a VCUG? And I will say no. Usually if there is a duplex kidney, if there is a hydroureteronephrosis, if it is a bilateral, or if there are any bladder anomalies, then I think it's better to get a VCUG to look for infravesical obstruction, to look for uretrovesical pathologies, or so those are the things you're looking for. So what do you want to do at this point? This is a 4 weeks baby, has a hydronephrosis, grade 2, VCUG is normal, and the question comes in is about, shall we do nothing? Just monitor with the ultrasound scan. Shall we do antibiotic prophylaxis? What should we tell about the renal scan? Do we need to do renal scans? So what is the evidence we have now for the antibiotic prophylaxis? All the evidence shows that there is a role for antibiotic prophylaxis only in severe grades. That means SFU grade 3 and grade 4, which will correlate with anything about anterior-posterior diameter of pelvis more than 20 millimeters. The second population is uncircumcised male with the high-grade hydronephrosis, because the foreskin will harbor the bacteria and will be the cause for urinary tract infection, and then female gender, which are also risk of the urinary tract infection.
So this is a case 1 follow-up we saw after about a month and 3 months, and this is a grade 2 hydronephrosis. At this stage, I will continue antibiotic prophylaxis, and I will have them see in about 3 to 6 months. There is no roll-up renal scan, and because this is an isolated hydronephrosis, there is no need for VCUG. Now what about this case? This is completely different. As leading on to, we just talked about posturietal valve, we talked about bladder anomalies, we talked about neurogenic bladder. This is a kid with a bilateral hydrohydronephrosis and oligohydramnios. Now you need to change the gears and look at his bladder. The bladder is distended. How do you know that the bladder is dilated on a fetal scan? First of all, you know the bladder is by umbilical arteries on both the sides. And then if it does not empty for a while, you know that there is some problem intravasically. So this kid, when postnatally we looked at it, this is a bilateral hydronephrosis and thick wall bladder, and this is the VCUG. And you all know the diagnosis is the infravesical obstruction, and then that changes what you will do. This is following the posterior valve resection. How does it look like? Then the next question, another thing, 37 weeks, we came with the concern for possible pelvectasis, and on a day 2 revealed grade 3 to grade 4 hydronephrosis, and the other side had a grade 1 hydronephrosis. This is right side is normal, and that's the left side, which is about grade 3, grade 4 SFU. Now, if you look at it, you have to be very careful about differentiating from MCDK and the severely dilated hydronephrotic kidney. There has been a case I have dealt with about 15 years ago, and this patient was diagnosed as a bilateral multicystic dysplastic kidney and hasn't done anything. He came back after 10 years with a hypertension and bilateral big abdominal lump. And I said, this is very unusual, why this kid is hypertensive and, big abdominal lump. So we got ultrasound scan, hugely dilated kidneys. I said, let's do nephrostomy. So we put a nephrostomy and drained about 3 liters of urine from one kidney and 1.6 liter of urine from other kidney. And then, got the antegrade study and showed bilateral uretropelvic junction obstruction. So the diagnosis was missed in the earlier period, saying that this was a dysplastic kidney and nothing was done. So be careful about, if somebody is interpreting for you, you try to look at this ultrasound scan by yourself, and it is very simple, it's very useful to have some interpretation of your own. So this patient got a VCUG just because of some abnormality of the ureter. Now what you would like to do? This is a grade 3, grade 4 hydronephrosis. You can start antibiotic prophylaxis, and this is the case where you want to think about the functional renal scan. And usually we do functional renal scan is a MAC3 scan. I'm sure, DTPA scan is also available, but MAC3 handles much better. And this is a MAC3 scan, and you can think about it, how it is looking like, what the split renal function is, what the drainage is. And here you see, it's not draining well, and the split renal function is probably reasonable, about less than 40%. So this is the case now. Question comes, you want to wait or you want to do pyeloplasty? And my urge is, this is obstruction. This is not going to get better. All right. There are a lot of studies showing, you can sit tight, you can follow up, but you are turning this normal child into a patient with a number of times the visit to the hospital and, number of radiations and everything. This is grade 3, grade 4 hydronephrosis, less than 40% split renal function. I think he deserves pyeloplasty. So switching back, this is a very common problem we deal with as a urologist, as a pediatric urologist. 1 in 100 pregnancies will have a prenatal dilatation. And of those 1 in 100, 1 in 1,000 will have a uretropelvic junction obstruction. So the spectrum of this is a huge, and that's why I think we need to know much better of prenatal hydronephrosis. Now, when do you say it's very significant? And I say simple is 4, 6, and 8 millimeter. Mild, moderate, severe in the first trimester, second trimester, and third trimester. There are different nomenclature used in different literature, but 4, 6, and 8 millimeter, first, second, and third trimester, anything above is significant and which needs to be monitored and to be seen carefully. The other problem comes in is whenever these babies are born in, children's hospital where there may not be a pediatric urologist, there may be a pediatricians or other colleagues. They get excited and do the labs. And they say, oh, creatinine is normal. But when you ask them, when was it done? Oh, he was born yesterday and we did it this morning. And you say, no, it may not reflect it. It's mother's creatinine. So you do need to wait at least for 3 to 7 days. So be aware about these things. Also be aware about the prematurity. You say creatinine is normal, his bilateral grade 4 hydronephrosis, and what's the weight of the baby? 2 kilograms. When was he born? 32 weeks. So these are all important things to take into consideration whenever you talk with the pediatricians, because the pediatricians are the real source of people who are taking care of the children or infants or fetuses, and I think your discussion with them will really help. So what should we use for the grading? Now, grading has been very difficult. There's a lot of inter-observer and intra-observer differences. If you look at this SFU grading, grade 1, grade 2, grade 3, grade 4, and this is where the problem comes, grade 3 and grade 4. Because when the cortex is reasonable, that's fine, but when the cortex is thin, is grade 4. Now, if the ultrasonographer is not looking at this very well, you could miss. And then, you can have a misinterpretation and the problem of just watching or doing surgery. The Society of Fetal Urology, the pediatric urologists now are thinking about just doing 3 grades, and urinary tract dilatation, P1, P2, P3, P3 just severe, so that rule out the cortical thinness, which we talked about. While North America uses SFU, rest of the world use anterior-posterior diameter of the pelvis. And the fallacy of anterior-posterior diameter of the pelvis is they are measuring the pelvis here in a maximum dimension. And they say, all right, 20 millimeter epipelvis. And you say, okay, it's less than 30, it's less than 40, we can sit tight. But what we are missing is the calyceal dilatation. The calyces are not measured. Now, if they say 20 millimeter epipelvis with all calyceal dilatation, then your eyes are going to up, oh my God, this is intrarenal hydronephrosis. I can't sit tight. This patient needs some intervention. So that's why the fallacy of anterior-posterior diameter of the pelvis comes in. So you are a key, real stakeholder of taking care of the children. So we talked about VCUG. If you look at all the guidelines, all the literature, there is a lot of VCUGs done for unilateral isolated hydronephrosis, and I think it's not needed. And over a period of about 20 to 30 years at Great Ormond Street Hospital, when Gita Dillon and Philip Ransley looked at 5,000 prenatal patients, they came up with this. And they said, if you have prenatal ureteral dilatation, bilateral hydronephrosis, oligohydramnios, bladder anomalies, and postnatal similar pathologies, I think, then you need to do VCUG. You're not missing much. And if somebody is presenting with a urinary tract infection, again, you have to think about doing a VCUG. So this is a very select population. This is after about 5,000 children being learned about, when to do VCUG. Now, again, the question comes in about the MAC3 renal scan, how it is done, when the radioisotope is injected, how the Foley catheter is placed. Did they look at the drainage pictures before the bladder was empty, after the bladder was empty? So you have to have a good discussion with your nuclear physicist, whoever is doing it, because it makes a lot of difference. Shall I operate or not operate? And that's why what I say is put everything together. Like, when you're going to buy a house, you're not just looking at the front door. You're going to go to the back door, you're going to look at the bathroom, you're going to look at the ceilings, you're going to look at the floor. So I think, look at the ultrasound scan, look at the cortical thickness, look at what type of hydronephrosis is it, then look at the renal scan, put it together, and just don't put on value on one thing, either split renal function, either T-half, put everything together and then, make a plan. Now, when to give furosemide? And this debate continues on. Some say 0, some say F minus 20, some say F plus 10. And at our institution, what we do is, first the radioisotope injected, and then the Lasix is injected in about 0 to 5 minutes, and that has been consistent. So follow whatever the plan is at your institution so you have consistency. This is another issue. And this is where you caught up with the parents, and parents are not happy with you, because you look at this renal scan, and this is the right kidney is really good, and then the left on the side, you look at the big area of interest, and if you see it's a huge photopenic area, and the nuclear physicists will draw the line or area of interest around this, and they will say, oh, this kidney has a 55% function. But actually, if you look at the radioisotope uptake, there is nothing. It's actually radio retention later on, which is not excreted. So this is not the uptake phase. And this is where the problem comes in, and they say, after surgery, first of all, you shouldn't do surgery because there is no function. And even if you do surgery, you have to be very careful about them saying that this kidney may be 10% function, this may be 15% function. Whatever report you see, don't come back and tell, you did a surgery and you did something wrong to my child. But that's why I think we need to set up the expectations of the parents and the family and write in the consent. I think we are heading to a legal practice very much around the world, and nobody is going to be spared without any legal justification. So this was a patient, the renal scan, you looked at it. This was the ultrasound scan before surgery. You can see there is some renal cortex. And when I said, when you buy a house putting together, now look at this. When you looked at this renal scan, there is no radioisotope uptake. But when you look at ultrasound scan, there is some renal cortex. I said, all right, let's give him a chance. This is like a 8 weeks or 6 weeks baby. Let's do pyeloplasty and see what happens. So this is what I did a pyeloplasty, and this is after about 2 years. You can see some renal cortex gain, and when we did a renal scan, it was about 20% function. So in infants is much, much different than the adults. There's a lot of recuperation. There is a lot of still ongoing nephrogenesis. So be aware very carefully about nephrectomy versus pyeloplasty. That was just a simple scar, how it looks like. Now, where does the obstruction exactly exist? Is it because of the muscular orientation at uretropelvic junction, which is not transmitting the peristalsis very well? Or is there a possibility of extrinsic obstruction from the crossing vessel? Is it because of the non-dependent insertion of UPJ? Is it a urethral polyp? So those are all the causes of uretropelvic junction obstruction. Now, as we talked about the indication, the most important indication is grade 4 hydronephrosis, or AP diameter more than 20 with calyceal dilatation, and the split renal function less than 40. But there are children with a 50% split renal function, and you have grade 4 hydronephrosis, or you have grade 3 intrarenal hydronephrosis. They also qualify for the pyeloplasty just because of the anatomy what they have. And the other things are, presenting with urinary tract infection and the secondary problems like a kidney stones formation because the urine is not draining well. Now we talked about, shall we sit tight or shall we not do pyeloplasty? And Steve Kopp stirred up the pot, saying that we should sit tight, and we don't know in last 20, 25, 30 years how many were, not needing surgery. But I know from Philip Ransley's series, which is the only natural history series which was done in 1980s. And if you look at all the patients who have been observed for grade 4, they came to surgery later on. It's not that they didn't need surgery. So that's why this paper will really make some contribution. Dr. Ramesh Babu, pediatric surgeon, he said, pro-pyeloplasty in this patient really helped having recuperating the function if you do in these children rather than not doing it. So what type of pyeloplasty? I think Dr. Mallikarjun Chari is going to talk about it, but dismembered Anderson-Heinz pyeloplasty works best. And it's a gold standard, it works really well. If there is an intrarenal pelvis, you can do follioviviplasty. If it is a long segment, you can do spiral flaps. But 99% of the time, Anderson-Heinz pyeloplasty works really well. And if you look at this, it's such a standard procedure, and it's time tested for almost more than 6 to 7 decades. And it tells us that this procedure, these two plastic surgeons have done such a great job contributing to the urology. And we haven't done much in regards to the contribution to the science in pyeloplasty. I think, we just changed the approaches. We've been doing laparoscopic, we did endopylotomy, didn't work, and we've been doing robotic, and which becomes more standard of care nowadays. I don't want to go much in the details of the robotic pyeloplasty, but if there is, I can show just a 2 minutes clip. This is a 6-week-old infant who is undergoing pyeloplasty for uretropelvic junction obstruction. Let me forward that and renal scan here. So we are very careful when we position the patient, just pad everything and make sure that pressure points are very well taken care. Place a port with the open Hassan technique approach. Usually 8 millimeter, now the 8 millimeter camera port has come in, and then put 2 additional 8 millimeters because the 5 millimeter ports, the instrument don't work in well as 8 millimeter works, and there is an assistant port. And you may say, what are you doing? You're putting all these 8 millimeter ports in a 6 weeks baby. I don't want to, but I don't have 5 millimeter nice instruments and nice ports. I don't have 3 millimeter instruments and 3 millimeter ports. I think if we keep on doing, the market drives, and hopefully, all the people who are working on this will get smaller instrument for sake of our children's. So once we get these ports in, again, these cannulas are very long. You have to be very careful about how you bring it in. The biggest mishap you can do is a bowel or vascular injury, and you will feel terrible. What I did to this child when I could have just done a simple open pyeloplasty. So be careful about it. You don't have to do it. You can do open pyeloplasty, give a good results, let him go home next day or something. But if you want to learn, this could be a good investment to learn for the future. So I'm going to still fast forward. I just want to show the anastomosis. I don't want to take too much time here. And here. So the access in the infants is a little bit difficult because there's a lot of dilated loops of intestine because children cry, and then there's a lot of air in the intestine. But once you get to the renal pelvis, things make much easier. You put a hitch suture, fire your PDS, and lift the pelvis up, and then transect the uretropelvic junction, and then do a nice dismembered Anderson-Heinz pyeloplasty. The spatulation becomes very easy with the part scissor. This scissor is used by our cardiac surgeon who does open heart bypass with the robotic approach, and he uses this scissor to cut the coronary arteries. And this is a suture which in laparoscopic, I know Dr. Mallikarjun Reddy is expert at it. I couldn't do laparoscopically, and robotically it works well for me. I know the suturing gets great. I can use 6O PDS, 7O PDS, put in a cutaneous stent or indwelling stent depending on the anatomy, and finish the pyeloplasty. Whole probably skin to skin will take about 75 to 90 minutes, including my resident participation. That includes port placement, closure, and everything, to console time and everything. So I will stop that there. You saw the glimpse of it, and some of you may be doing it. Now I just want to share a point on a vascular hitch. We published this when I was in Great Ormond State back in 2005. And why we did this is when we were doing laparoscopic pyeloplasty, it was very painful. And whenever we saw crossing vessel, Patrick Duffy said, why can't we do Hellstrom operation? We lift the vessels up and see what happens. I said, okay, we'll do. It could have been a little cut short for us not to do laparoscopic pyeloplasty. And it did work in some children, and it didn't work in some children. So the question was why it is working in some and why is it not working in some? And then there were a lot of papers from around the world saying that hitch doesn't work. So we went back and looked at it, and it's a very select population you can do this. These are symptomatic children who are above age of 10 to 11 years with the intermittent pain, and when you do ultrasound scan, they only have grade 2, maybe grade 1 hydronephrosis. And when they come with the pain, at that time it could be grade 3. But when they are not in pain, then it's only grade 2. And when you do renal scan, their T half is never more than 20. is probably 10, 12, 13, 14, 15. That is also at the time of obstruction. So it's a very select group of population where it works. And if you do it for the burnt out UPJ, if you do it for T-hub more than 20 minutes, if you do it for grade 4 hydro, it's not going to work. And I think that's I just wanted to share. So what are the type of complication? Anything you put it together doesn't heal, or it heals so well that it forms scar. So these are the two complications. Any anastomosis you do is nothing different from what you do. So what should be the accepted complication rates? I think as long as you have grade 3 complication, less than 5 to 10%, I think, it is better. But especially if you look at the outcomes of the patency of UPJ, it has to be more than 95%. If you have a stent, if you have a leak, 5 to 10% is acceptable. But if it is not, I think we need to think about what you can do better. I just want to share some of the outcomes about when we looked at it, robotic and open. There is a good learning curve for robotic cases, about 20 to 30 cases, and then it gets down to similar like a open surgery after about 30 to 40 cases. And look at the operating time, it could be under 100 minutes. So there is a learning curve. These are some of the literature. You can look at it and look at the outcomes. These are the robotic surgery pyeloplasty, and over a period of last 15 years, it did got better. Probably earlier was about 85, 90, and now it's about 95 to 96% outcomes. So I think that's reasonable. Infants also, once you have a good learning curve, you can do better. This is our multi-institutional study. This is our own when we compared infant and non-infant. After learning experience, you can do better. This is a recent literature of our own publication. You can look at the outcomes, grade 3 complications, and again 95% success and less than 5% complication. This is a Cleven-Dindo grade 3, 4.5% complication. Now what type of diversion? First of all, shall we do diversion? Shall we put a stent or not? And every time I see Philip Ransley, he says, are you still putting a stent? I said, yes. He said, then why are you doing, when we did an open, we didn't do it. I said, yes, I took care of your patients. We left a Foley catheter. We left a drain. They stayed in the hospital for a couple days. And now they go home next day. And we don't, leave a Foley catheter. We just leave overnight. We don't put a drain. And I think my gut feel is there's some bleeding and clots. And when the clots stuck at uretropelvic junction, and even though you do anastomosis, it's not that tight. And I think it finds a leak. And that's where, they get peritoneal irritation. The child doesn't feed well. He starts throwing up. He comes to hospital again for readmission. And we work in a teaching hospital. You have to give something to the residents. The resident can't just sit tight. They are future surgeons. So for that reason, I think, still we have to put a stent. I know, there will be one day without stent. Now, what type of stent? Internal stent is great, but the problem is internal stent needs anesthesia to take it out. So probably an external stent, which is like a cutaneous piloureteral stent we talked about here. So what we do is, previously when we did open, it traversed the stent from pelvis through the renal cortex and came out through the skin. But when we were starting doing robotic, the problem was when it came through renal cortex, it was oozing. And the anastomosis was very difficult. You couldn't see better. So now actually I bring the stent through the renal pelvis and then come out through the skin. And you can pull this stent out after a week. And it does work. Sometimes there very rarely stent extrusion happen because the stent material is not that soft. So this is some of the financial outcome when you compare the robotic versus open. It's a little bit expensive because of the capital cost. This is our own, again, cost difference, about $500 more expensive. Now, this is a very interesting paper we just recently published. When we were at European Society of Pediatric Urology, there was a question came, what are you doing better by doing infant robotic pyeloplasty? And I said, I don't know. I'm just exploring and seeing what happens. They said, did you compare with the open? I said, sure, but I'm not doing much open now. So one of a surgeon who, Duncan Wilcox in Colorado, does an open. One of the surgeon in Chile, he does a laparoscopy. And we all three were in London at the same time. So we looked at our own series, mine robotic, another surgeon laparoscopic, another open. And if you look at this hair outcome, it's almost similar, except that the open needed a little bit more pain medication and the laparoscopic needed a little bit more time. But the important thing is learning curve. The residents learn the robotic much quicker than a laparoscopic, because laparoscopy is not for everyone. And also the volumes we are doing is much, much less than 20 years ago, because there are so many surgeons now, and the birth rates have gone down. So that was an advantage we put forward in this paper, that is very useful to bring in some additional technology for transfer of the skills. What's a follow-up? If it is a cutaneous pilourethral stent, we knot it out next day, remove it in 7 to 10 days. If it is an internal stent, remove in 4 weeks, do ultrasound scan in a month, then 6 months and 1 year. And renal scan follow-up, I'm letting go of as many as possible. If ultrasound scan shows improvement in hydronephrosis, I talk to family, say, ultrasound scan look better. If you want renal scan, we can do it to see the renal function, to see the drainage. And sometimes they say, no, I will let go of it. These are some of the picture. Now, be careful when you do grade 4 hydronephrosis dilated system. And post-operatively, the ultrasound scan is looking better, but the parents say, or you wanted to do renal scan, you do it. The T-half will take a long time to go down. It may be still about 12 minutes, 15 minutes, because the system is dilated and capacious. And this is, again, why I'm talking these small points is you have to talk to family and mention them before surgery about all these points. So after surgery, it doesn't feel that, you did something wrong. Because parents are always looking, after surgery, anything happens. Surgery is the incident. Anything happens after surgery, is surgeon is wrong and surgery is wrong. Okay? So that's why making expectations, making discussion, and these all things very helpful. So that's ultrasound scan in a year. Now, a last word about the redo pyeloplasties. Redo pyeloplasties have been much, much less now compared to 20 years ago. Probably everybody is doing very well. Everybody is expert. Everybody is learned very well. But whenever case here and there happens, I think you still have to do redo pyeloplasty. That's a better option. Endopilotomy is not a choice for us, because pediatric patients, it doesn't work well. The instrumentation is not that great. So the second option about redo pyeloplasty is ureterocalicostomy. So I'm going to show you a video clip here. Ureterocalicostomy some or other way works very well in those children with a kidney with the poor thin renal cortex. Okay, be careful if you have to do ureterocalicostomy, that make sure that the lower pole renal cortex is very thin, so that you can do a nice anastomosis. The problem happens is those children who have a renal cortex very thick, and you don't see better and how to cut it. So what I do is I put a flexible cystoscope after I cut that ureter through the pelvis and cut on the light, like how we used to do the end-to-end ureteroplasties. You put a light from above, and then you cut from below, or put a light from above, and that's how it helps. So cut for the light and then do the anastomosis. So this is a flexible pyeloscopy, and then I put in an angiocath. I rupture that lower pole calyx, and then I'm going to use a harmonic scalpel, because I don't want to do a vascular control here. And I can just use a harmonic scalpel, just take a centimeter of that renal cortex out, and then do a anastomosis of that ureter to the urothelium and the renal cortex. It's very friable. Probably we don't know why it is so much friable. It's very friable. And I say, put 3 sutures first and then tie one after other. If you put one suture and tie it, then the other 2 sutures are very difficult. And these are some of the hitch sutures you are putting it, so that the kidney can get oriented. That's the stent going through the, after the posterior wall anastomosis. And then you can do the quickly anterior wall anastomosis. All right, so yeah, I will just, that's a completed anastomosis. We talked about this laparoscopic. So
I think what can I say, prenatal hydronephrosis is very common. There's a lot of insight into the management of counseling, of follow-up, when to do VCUG, when to do renal scans, and when the patient comes for pyeloplasty, how to counsel the family, what the expectations you have to do it, and the complication, explain to them what the percentage of complications are, and be frank on it. And if you have a 95% outcome, that's great. If you're not, I think, probably there is still scope to improve ourselves. So thank you very much. I hope that was very helpful discussion on a pyeloplasty.
It was wonderful, Mohan, and I think I'll have some questions before my talk is started off. Can I have somebody to plug my laptop, please? Okay. It was a fantastic compilation. I think you have taken those specific points which are very essential to be looked into when you look at doing a pyeloplasty, right from timing and evaluation. I'll have, in a simpler way of putting the questions, will you do an RGP? If at all, if you do, when do you want to do it?
Very good question. Thank you. I didn't put it in here presentation. So, again, we grew up with RGP. And, we wanted to see, where is the uretropelvic junction inserted, high, low, where should I make an incision, how should I plan for it. And a lot of thought process went in it. And we really learned it, enjoyed it. And even when we did open, we used to think about, shall I do incision here, there? And it really helped. But then I said, everything we learn, do we need to do it or do we need to not to do it? So I started practice 2007 in the United States, and they said, I don't want to do it. I don't want to do RGP. And said, okay, how about you, Mr.
You have more information available in other sorts of imaging, like rest of the things,
Yes.
better ability to
Yes.
visualize it than
Yes.
what was happening previously?
Correct. So this is, no, actually, previously also, Great Ormond Street and Chicago, both have pediatric radiologists, both have pediatric units, board certified, same facility available. So I said, Dr. Feinstein, radiologist, you do ultrasound scan, you always tell me that ureter is not dilated, you excludes uretrovesical junction pathology, and I will do it. I said, okay. So we stopped doing it, and I was doing pyeloplasty without retrograde pyelogram, and I ended up in trouble 2 times, both infants. Big ureter dilated, and I couldn't put anything from above. I put a nephroureteral stent, came out, and there was uretrovesical junction obstruction.
How far you believe, coming to that point, that there is a dual obstruction in patients?
Yes.
Is it your inability to pass a guide wire across? Do you consider it as an obstruction? Or our inability to evaluate a functional obstruction there is the reason why we are thinking it is a dual obstruction?
So I went back, both the ultrasound scans, couldn't pick up. I went back, looked at renal scan, and then I could see the opacification of the radioisotope in the kidney, the opacification of radioisotope in the ureter, and it was much different. And I said, okay, there's a UPJ, but also you could see the dilated ureter until uretrovesical junction, and I missed it 2 times. So that was one learning point. So now what I say is, if you have a good radiologist, if you have good nuclear physicist, you can interpret well, I think you can let go, but not in all cases. Horseshoe kidneys, ectopic kidneys, redo cases, I think it's better you do retrograde so you can have much more foundation before you get into it.
I think that's mandatory in those cases, what all cases you said. I think it's, if you don't do it, sometimes you mess it up. Is it a possibility that you do an ultrasound and see that there is no dilatation of the ureter and it's only dilatation of the PCS, and you go ahead with lap pyeloplasty or robotic pyeloplasty?
Yes. Now, I haven't done it, and so far I haven't had trouble after those 2 cases.
Fine. I have got one more before.
Please.
Many questions. Yeah, Malik, there's one more question. What is it? Yeah. How do you define success?
Everybody takes, every paper you read, we define success as a decrease in the hydronephrosis on ultrasound scan. Some say, success is defined as a pain-free after pyeloplasty. Third is renal scan showing a good drainage. I say is, you have to put all things together. And all things together, you have to have improved hydronephrosis. If the patient is symptomatic, he has to have symptoms go. Renal scan, those patients
whose system is not capacious and dilated and tortuous, they are not going to be good renal scan after surgery, even in spite of you do a good job, because there is no renal cortex. The hydrostatic pressure generated is not that much to drain well. So these systems are going to be dilated and capacious. So those patients, renal scan you have to take with a pinch of salt. But the other two things are very important.
Malik, you said something.
Mohan.
You're audible, man. You're not a pediatric one.
Wonderful listening to you again and again. You always see that never your talk is the same. So we always listen to you. One thing I just wanted to put a comment on the lighter side is, as you hail the plastic surgeons, I think cardiologists today owe their existence to urologists. Werner Frostman, the urologist, he was the guy who put a guide wire across his basilic vein and then got himself x-rayed to show what a cardiac catheterization is. If he would, and unfortunately he gave up his life because of endocarditis. Without him, cardiology would have been defunct now. But leaving that, getting into hardcore pediatric urology, I think the science of obstruction yet has not evolved in pediatric urology. We have no way that we can describe a particular kidney, whether this is obstructed or not, unless we prove that there is loss of function. So whatever we are doing has got a little fallacy at the end of the day. So many markers have been tried, so many things have been looked at. So we really don't know which is an obstructed kidney or which kidney is going to go into obstruction unless we, over a follow-up, we see that there is a loss of function. That is one problem pediatric urologists look at. The second thing is, I think, we'll have to look at the pyeloplasty prior Ransley and pre-Ransley and post-Ransley. Pre-Ransley, every hydronephrosis was operated. Post-Ransley, now there has been data what to do and all that. Leave the West aside. Looking at India, there are a lot of these children whom we look at in hydronephrosis and tell them, why you need to come back at so and so time to look at redo investigation. After working in a little smaller town in a medical college, looked at a lot of these children because they are asymptomatic, they don't come back. They end up either losing the kidney or becoming better. So for those people who lose the kidney, we know that the literature tells us on a follow-up of these kidneys, we lose about 3 to 4% of these kidneys over follow-up. Take Onen's paper into consideration, saying that the present generation pyeloplasty, the minimal invasive pyeloplasty, which is now ubiquitous, that number 2 with the better anesthetic techniques and much lesser failure rate than losing the kidney, aren't we justified actually going to the pre-Ransley era?
Yeah. So good question. As you mentioned, every UPJ is not the same UPJ. Every hydronephrosis on ultrasound scan is not same hydronephrosis. As you mentioned, if it is an intrarenal hydronephrosis, no extrarenal pelvis at all, and calyces are dilated, I'm worried about that child. Even, those children in the United States where they have an insurance system, I said, I'm afraid if you miss the appointment and, his kidney is going to blow out and lose the function. So even if it is grade 3, because they say the renal cortex is not damaged, and if it is intrarenal hydronephrosis with a calyceal dilatation, and renal scan, supporting what I say, I will do pyeloplasty. But there's an extrarenal pelvis, and it's a grade 3, big capacious pelvis, extrarenal outside the renal cortex. Those ones, I think, you are right, can you come back for a follow-up? But putting all this together, what happens is, when you say, why we waiting, do surgery, then what happens is, there could be some children who will get unnecessary surgery. And that's why we need to be very careful about, select children based on the ultrasound scan findings, on the renal scan findings, put everything together and make a case. And we are much better, as you correctly said, we have minimal invasive, we have good outcomes, we have good anesthesia, But again, surgery is surgery. If you say everybody's surgery, then everybody will get onto the band, and then you miss the boat. Then what's the scientific discussion?
Arvind?
So I just wanted to first, it was a very nice presentation. Thank you so much. I agree with you about, I think it's very important not to do harm, and just to go in just because there may be obstruction, you're never sure. It's that we should avoid. Now, coming to it is that when we look at PUGO, it's a spectrum. It's not one all or none. And there is a definitely, when you talk about hydrodynamics, there is non-obstructive hydronephrosis is a well-defined clinical entity which we should recognize. As you said, intrarenal hydronephrosis is a different story. And the renogram is not the best test. We need to realize that has inherent limitations. We always used to talk about the well-tempered renogram. And there are that's not the curve. The curve, in fact, can be quite fallacious because if it's the slightly extrarenal pelvis, it will be fallacious. Have you used cortical transit time more than 3 or 4 minutes? And with intrarenal pelvis may be more likely to indicate obstruction. That's one. Yeah. Second point is this obstruction, which we say when we at various levels, which there could be a compression even at different levels. And as you said, I too have faced more than one occasion having a hypoplastic ureter below. And that is when, but that again doesn't mean that we do RGP for all patients, because these are small pediatric patients, and RGP actually can do some harm because you may not be able to have that fine catheter, you may create a flap, and if you are sure there is no ureteric dilatation, it may be better to just go ahead and do a pyeloplasty. What would you say about the cortical transit time? What has been your experience?
So it's a good point. Thank you again, and we actually looking at it. So our nuclear physicist is looking at all the renal scans we've done it so far, and looking at and then comparing that ultrasound findings and the surgery. Was there really helpful renal cortical transit time? And if you saw the paper from Texas, I think they do comment that this will be much more helpful, and especially if you want to do a MR urogram and look at the cortical transit time, it will be much better just doing on a renal scan. So I think we will let you know probably in a year or two once we have more evidence.
We did a systematic review about a year back on this, and we found that if you look at the data, there is some benefit in actually looking at it, and we can look at it even with the renograms that we see.
Correct.
The other point I want to emphasize is in India, we have nuclear medicine departments in very few institutions. So when you have different nuclear medicine protocols, when you have different renogram protocols, you really can't depend on them. And I have seen some of the reports that come from outside, you really can't depend on the way it has been done. And they don't follow the correct protocol or don't follow your protocol, so you can't really follow them. You will be comparing apples to oranges. And I think we have to be careful, particularly because we are dealing with pediatric patients, and any mistake would have a long-term repercussions.
No, I think that, Arvind, that's a real point wherein improvement in cortical transit time, I define it as a good, satisfactory result. Rest all the things are mostly misinterpreted or possibly interpreted in their own ways and calculated in their own ways. Ramraj sir.
Dr. Guneti, as a part of diagnostic workup at a practical level, do you just depend on ultrasound and isotope renogram before you operate, or do you do an IVP or a CT or MRI?
So most of the time, ultrasound and renal scans are complementary and more than helpful. I must say, I haven't done MR urogram until unless it's a horseshoe kidney, basically MR angiogram, look for the aberrant vessels. And IVU, I haven't done it since, India we used to do, back in 90s. And you remember every time we did it, there was so much of gas shadow, isn't it? And when the kidney was obstructed, we used to sit there for 6 hours, 8 hours, and we used to take ourselves films. So no IVU, no retrograde, ultrasound and renal scan. But again, it's very helpful that we have people who we can talk to all the time. We learn from each other compared to, if you send somewhere you don't know who they are.
But in defense of IVP, if you're not accusing me of coming from
No,
ICH,
not at all. Not at all. Learning from you.
If somebody is doing an open operation where do you place your incision if you don't have some bearings?
Yeah, that's what I said, when we are doing retrograde, that was one of the option. Laparoscopic, when we were doing, that was one of the option, am I able to do this or not? But what happened is, robot changed the face. We go intraperitoneal, and you look at this renal hilum to almost pelvic brim, and you can go up and down everywhere, and it changed the face, and that's why, you are much more comfortable to do now without anything.
But one thing, sir, in absence of any radiological investigation like a CT, it's always advisable to do an operative ultrasound, not intraoperative, on the table when the child is completely sedated and quiet. You will be able to see and see the ureteric dilatation. If you have not done that, a CT or anything like this before, please do an ultrasound on the table.
But I don't know about your opinion. I hate to do a CT scan in children. Too much of radiation.
True.
So at a practical level, again, our youngsters are doing too many CTs in children. It is 2 passes, one before contrast, another contrast, and then throughout their lives they are going to require CT scans for any number of reasons. There's going to be a lot of cumulative radiation. I would suggest to all the youngsters not to do CT scans in children to assess PUG obstruction.
Yes.
Totally agree. If at all you want to do MR urogram, and that's more than helpful. Even same with the IVU, we take 4 or 5 pictures, so much of radiation. So you need to be careful of our children. Do you want to use this?
I don't think I've already changed. I think it's my laptop.
Oh, good. Okay, all right. Thank you.
I think they've changed it. Oh, yeah. Oh, yeah, they've changed it. Oh, it's there. I think it was a fantastic. I think possibly I will not be able to add much to whatever you said, Mohan. I think it's one of the oldest procedures which we learnt, and possibly we are practicing, as you said, in a different style rather than the open style what we learnt at that point of time. But one thing in Indian scenario, robotic pyeloplasty is far-fetched yet. But let me tell you, with the disclosures that I do robotic also, but I stopped doing robotic pyeloplasties. I switched back onto my laparoscopic pyeloplasties for whatever may be the reasons, but I feel I switched back onto laparoscopic pyeloplasties, especially in children. Adults, it was being done before, but even that has been stopped. Pyeloplasty is only by laparoscopy. That's one thing is true, which is it's a continuous process of learning. No 2 pyeloplasties are same. You find some problem or other every day. The principles, as was being said, they have not changed in the last 60 years. I don't think in the last century. It will not change for the next few years to come also. The same way, MIS is no difference. Well, the diversion is, at present, possibly 99% of the people are still using internal double J stent. Few have been using a transrenal or a transpylo stent, what is being placed across the PUJ, but it becomes quite unstable and comes out of the pelvis in my experience. That's the reason why we stopped it. Unless otherwise we are not able to put across a stent across, then only we think about it. I don't think there is any contraindication at present, but I still believe what extends below the pelvic brim is not a good case for any of these minimally invasive procedures. I still believe it's going to be a better procedure for an open surgery. And I was about to ask a question which possibly after my talk you can answer. What is the timing of surgery? When do you see? I see 3 months, 2 months kids being operated for pyeloplasty. Possibly, are there any specific indications to do before this time? Or finding an obstruction is an indication to operate? This is one question possibly yet to be answered, because there are too many pediatric surgeons, too many urologists covering this own field in their own perspective. So every obstruction is being operated at every point of time. So I think we need a little amount of discussion on this point after my talk is over, Mohan. Well, to get good results in laparoscopic pyeloplasty, I would say one thing. Everything is known to you. I don't think I'm adding anything on. The only one thing which I add here is gesture imprecision. Correct trocar and a correct needle holder. Don't have a 10 mm trocar with a 5 mm needle holder. Have a correct trocar and a correct needle holder. When it comes to the principles, it is always true. One thing which I want to specify. Irrespective of the size of the anastomosis you make it, ultimately it may be 2 centimeters, 1 centimeters, 3 centimeters. What ultimately drains is this narrow point. That is the point where you have done a spatulation, and that ring of the ureter, just few micromillimeters below that spatulated cut, is the thing which drains. If there is a scar there, if there is an injury there, if there is more fibrosis there, the drainage is affected. So it is not the question of how spatulated you become, how much is the spatulation done, how much care you have taken to that corner of the funnel. Based on that, I have some things which I tell during my procedure. I've taken one case, which a 15 or a 14-minute video, which will tell majority of the points which are going to be covered in this patient. It's a child with PUJ obstruction and renal stones. It's a very deadly combination, because I tell you in my results what happens. So when we talk about this sort of a thing, I'll just fast forward it. Is it coming? Yeah. Yes. This is the style of port positioning which I prefer in children. I do have a 5 mm port for a trocar and a 3 mm ports for my hand instruments, and one 5 mm trocar on the flank, because to put a drain, that's number one in case necessary, and to put my sutures and all into it. Passing sutures through this and trying to find out through this is going to be a cumbersome thing. Majority of the times, majority of the patients I do, this is the method of trocar placement for all pediatric pyeloplasties in my hands. Oh, sorry. I think I did a mistake. Okay. It is there on. Okay. So it's continuous. Okay. This is how it's a right-sided pyeloplasty with a PUJ obstruction and stones inside. So it's a definite mobilization of the colon to a certain extent which is happening. Most of the children, I think you agree on, these curettage fascia and are all very thick. They give a little amount of resistance to your incision. There is no doubt about it. But to try to make it your anatomy very clear, understand the anatomy very well, see the relationship of all the structures there, and try to minimize the mobilization or a window in the serratus fascia. I never want the kidney to be mobilized or the kidney surface to be seen. It is never necessary in a pyeloplasty. You never need to lift any structure in a pyeloplasty. So this is a small window in the ureter which is being made, a small window, and that is the only window what we have. It is going to be onto the lateral aspect of the gonadal vessel, and that is the window what is going to be seen. There are 3 layers onto the pelvis or ureter. Ureter has got an outer muscular layer onto which there is a small areolar tissue with vessels there and a Waldeyer sheath coming up. When it comes, the same Waldeyer sheath comes onto the pelvis, you have a peripelvic fascia which comes, and some fat, and then the gyrotous fascia. So you should be able to understand the importance of this peripelvic or a periureteric fascias very, very correctly. If you injure or denude that fascia, you are trying to injure or devascularize the ureter. So I'll never touch the ureter. At the same time, I keep that facial layer over the ureter very well. So you will be able to see that facial layer in front of you happening, and that facial layer onto the ureter as well, and that is a vessel which is supplying the ureter. You can see that's a vessel from the upper ureter which is supplying the ureter. So that is a small window of a small pelvis, not a very big pelvis, and a normal unlooped ureter. Try to understand, if there is multiple loops into the ureter, that pyeloplasty is easy because the ureteric length is available. But when there is unlooped ureter with a smaller pelvis, anastomosis between the two is going to be difficult. That vessel need to be sacrificed to make a proper anastomosis. Sometimes you can do it without sacrificing it, but there is no point troubling yourself too much onto that. Again, I am telling you, you are leaving those peripelvic facial layers intact and then mobilizing the rest of the fat away from it and exposing the pelvic completely. So once upon a time, it was long ago when we used to have large pelvises, people used to ask for not to take out these facial layers around the pelvis, because that denudes or possibly denervates the pelvic muscles, it seems. So failed pyeloplasties was attributed for that, and that principle continued till that time. In my hands, I thought that was giving me a good result. That's the reason why I continued. Whenever you have a small pelvis which is not coming out towards you, you try to push it outside in some way or other. So sometimes you take a help of a sling which comes through the abdominal wall. You saw Dr. Gunde showing that slings coming up and fixing up the kidney and ureter also. So that's a completely mobilized structure with a perivertebral fascia. You have a mind idea where you are going to incise the pelvis, and that is the needle which coming. You can take a 3-0 monocryle, which is straight-end needle, or there is a large needle which comes as is actually used for skin, and the same needle can be brought in. Be careful, because it can injure any of the structures, because it's a cutting needle. Take care of it. Should be a monocryle suture, because you need to pull the thing. You can't have a braided suture to pull it. It's going to have a rubbing of the tissues very much. So it's a monocryle which comes out again from the abdominal wall, most of the time in the subcostal area, and that pulls it up. That keeps the pelvis outside into your field, and very well. So that is the area. And after that, you start dividing the pelvis. You see, whenever you have unlooped ureter, you have a tightened ureter, you better do something called post-anastomotic dismemberment. That means the ureter and the pelvis will not divide away. There is an attachment between one part of the ureter and to the pelvic wall, and that will keep both them together. And that will the advantage of it is that's a pelvic wall which is being opened up anteriorly, and you can see those stones which are existing inside and which are being grabbed. So I just selected this case because everything is covered into it. A small pelvis, unlooped ureter, stones inside, requirement of a loop, and bagging of the stones completely. Try to understand, in majority of the cases, the multiplicity of the stones are there. The chance of residual stones, irrespective of your attempts, is nearing 20 to 25%. So if you have multiple faceted stones, though we presume that we have taken out everything, we still land up in having one or two, or sometimes a small one, irrespective of whatever flexible ureteroscopy or flexible nephroscopy we do on the table, you end up in having small specks or small stones inside the pelvis. So that is the anterior wall of the pelvis which is divided. Now we need to into the local posterior wall. This is another mistake what you need. You never go from below upwards very easily. You need to have a better mobilization. See this, I am creating more and more dog ears there. The way we held the pelvis is not correct, and we have not mobilized the ureter away from the pelvis, so we are creating those. So don't do that. But anyway, you have a posterior wall of the pelvis which is being there, and that part of the pelvis is attached to the ureter for some time till a part of the anastomosis is completed. So that's a spatulation of the ureter. If you see the spatula of the ureter, it may not be easy for the scissors to enter. Once it enters, never close the scissor. Keep it open and move the scissor through into the ureter. That gives you a neat cut onto the ureter without dog ears. That is one thing which we need to do. Otherwise, multiple scissor cuts will end up in having multiple dog ears into the ureter. As I've been insisting upon, that it is preserving that end of the apex, which is more important. So all my sutures are para-apical. I first start off a posterior layer of the suture. I don't lift the ureter at all from that place. The ureter stays there. It is like opening the book and closing the book. So there is no devascularization or probably vascularity compromise of the ureter. So all the things stay there only. So I start suturing the posterior wall. Hold that part of the ureter or pelvic wall which is going to be excised. Don't hold the ureter as much as possible. Even if you hold it, don't take a serrated Maryland. You have a buttonhole, a cobblestone-like appearance Maryland. That will be less traumatic. This is the first only occasion where I held the ureter, and rest of the times you use that thread for pulling or having a retraction. That is one step, and the posterior layer is being completed. Use that thread to push and pull the ureter also. So that is the advantage of having it. See that you take a bite and use that thread for getting the needle into the ureter, getting through the ureter and pushing the ureter too. So that's a posterior wall being complete. So once having done a majority of the posterior wall, now you disconnect the pelvis from the ureter. So that is the time when you disconnect the pelvis. That's a posterior wall. I think I can just for sure do little. That's a posterior wall which is almost about to complete. Yes. And then, yes, now you disconnect it out. You see a small Surgery cell there. Never pass it's always better to have, because these people have children and we have gauze pieces cannot be brought in for suction. Don't suck onto the tissue. Keep a Surgery cell piece there and suck onto the Surgery cell. That's a better way to suck in any children, because this areolar tissue or fat comes out into this suctions very easily. So don't do that. Put a Surgery cell there and start sucking onto that Surgery cell so that there's no injury. That's a completion of the posterior wall which is complete, and and the knot which is being placed. After the posterior wall is complete, now it is the time of taking care of apex. So you have an apex where you have made a cut, and you have two para-apical sutures which are going to come. So one, that is the first para-apical suture on the other, one side posterior, on the other side of the apex. That's being done, and the similar thing is done on this side. So the actual funnel part will never have a suture material coming through. That will prevent a fibrosis or scarring in that funnel. So that is the principle of this para-apical sutures. So whenever you do it, both the sutures are going to be placed on either side of the apex. Try to understand, once upon a time when we had no magnification, that was different. But with this sort of a magnification, we can easily do this job without any problem. That's a posterior wall which is complete. And now we are going to place a stent antegradely through a suction catheter, a preloaded stent on a guide wire with a floppy tip, with a flexible rigid tip only. But withdrawing the rigid tip will make it floppy, and then you pass a stent antegradely into the ureter. The best way to check whether you have reached the bladder or not is, after passing the stent completely, you move the stent up and down and check whether it moves in very easily or not. That's the best way. If it is coiled in the ureter, it never moves like that. So you can check it any number of times, and then once you are satisfied, keep the stent inside and start taking the anterior layer now. I don't think there is anything big here. You see, basically preventing too much of mobilization is avoided. Small window into the ureter's fascia. Leave the ureter there. Don't lift the ureter up, and keep a book open, and the book is being closed now. So that is the completion of the anastomosis. What is happening now? I don't think there is anything much now, and that's a completion of the anastomosis, and you stitch it up. So in this part, the moral of the story is, the lesser you mobilize, the lesser you hold, the finer the suture, the better is going to be the result. And that is the end of the pyeloplasty. So coming to the lower polar vessel, it's always no. If you are doing an open surgery, you are pushing it anteriorly. If you do a transperitoneal laparoscopic surgery, you would end up in doing it, pushing it posteriorly. So whether they really matter, or they are the reason for the obstruction, we are not yet clear. So it's the same thing. I don't think the principles of pyeloplasty never changed, whether it's a lower pyle or vessel is there or not, and the anastomosis is going to be the same in a laparoscopic way. Let us come to a small pelvis with a low insertion. Sometimes you get these pelvises which are very small. I don't think you can disconnect them, and there is hardly any loop. Here is the time for a VY-plasty. Either you place it anteriorly or laterally. It may make a Y incision and close it as a V. That is the only way to correct this pyeloplasties. These are all non-dismembered pyeloplasties. But the best results, as I said, as and when it is possible to do an Anderson-Hines, you do. But the same principles of anastomosis continues to be the same in any of these cases. That's a stent, and that's a completion of anastomosis. That's a completion of the anastomosis. Flap pyeloplasty, in those cases where there is a long length ureteric stricture, long length ureteric narrowing, you can't bridge it, you can't get them down. You create a, well, we used to have culp flaps or those flaps, but anyway, you design a flap whatever is possible, get the ureter spatulated as less as possible, and use this flap to anastomose to the ureter. So this is a flap raised out of the pelvic wall, and you anastomose it, and the similar way of anastomosis as it's been described. And this flap will enlarge the whole area, and complete the lumen is going to be completely better. Renal distances. In some cases, you may not be able to get these two things together. See that long length of ureter. long length of narrowing. And that's it. That's the thing what I am trying to do that whether I can get the anastomosis together. It is not possible. So what you do is a renal descensus. Don't disconnect the lower pole of the thing with the peritoneal attachment. Only do the upper 2/3 of the peritoneal attachment and move the kidney downwards. And then make a spatulation now. At the same time, post-anastomotic dismemberment. You will never be able to disconnect it beforehand. It has to be disconnected at the end. Post-anastomotic dismemberment is the way to go forward. That's a renal descensus. There's nothing much into a post-operative care. Check the degestant position. If you are a beginner, in every case, on a C-arm at the end of the procedure, drain removal on the second day and a catheter removal on the third day, and stent removal after 4 weeks, and a follow-up DTP scan in our center is 3 to 4 things. Perio problems, there are 3 main perioperative problems which you have seen in general. Number 1 is hematuria. Most of the time it's on the 6th or a 7th day. And number 2, increased drain. Putting a large, this thicker plastic drains will compress the ureter and they may not drain even through the stent. So select the drain very regularly, not very stiff, especially in children. Restenting. You take out the stent on the 4th week and the patient comes back with fever and a flank pain and vomitings, and you may end up in stenting. And majority of the cases, there may be some cases you feel a lot of filling defect like thing at the anastomotic area. There's a lot of granulation tissue. At that moment you stent and see it, reassess it possibly after 3 weeks. As I said, in majority of the cases, if there is multiple faceted stone, the chance of you retaining a stone inside at the end of the day is very high. Losing the needle is the most common reason for laparotomy. You should be very careful when you get into the needle and get the needle out. It is not able to do palloplasty. It is not able to find the needle, which is the reason for conversion in many cases. Thank you very much.
That was incredible. Thank you. Any questions?
I just have a question.
Yes, please. Yes.
So the very nice presentation, sir. I noticed 2 things. You are doing the posterior layer as a continuous fashion. The anterior one you do interrupted. Both you do continuous. I thought the 3 and 4 sutures you do.
Both sutures are continuous, but at the apex there are 2 paraapical sutures, following which there is a continuous suture. Posteriorly, 1 paraapical sutures, following which there is a continuous.
So you take
suture.
3 interrupted ones.
2 interrupted, 2 continuous.
Continuous, correct. The other thing is you are using 50 vicryl.
50 vicryl or 40 vicryl, depending upon the situation. I do some in very small infants. It is easy to do with PDS. Because if you do take a braided suture, when you pull it, it becomes very difficult.
There's one more thing about when you do renal descensus, that's easily possible on the left side. Right side don't really get much length.
No, anywhere. You see, whenever you have a problem,
a little bit because the vein is short.
Well, you don't have an option. You have to try that and see. No other way.
Sir, would you consider using a C-arm to see if you have complete stone clearance?
It never matures because majority of the time the position is odd and nothing works out. So, see, the question is, even if you find some...
So if you put another extra port, I try to put extra port and put a nephroscope inside, rigid one. So I can look inside sometimes.
There are two aspects I tell you, because you raise the point, I tell you 2 issues. Number 1, irrespective of your search, ultimately your search will end up in having lot of fluid inside the abdomen.
Yes, that is true.
And that will produce the bowel to come up, and it becomes difficult for your anastomosis later.
If you use air inside without using much water.
That's one way, not air. It will take us a carbon dioxide. What you need to do is shift the carbon dioxide from the laparoscopic pore to your this thing.
Yes.
Even that, it's not so easy to see. It's not so easy. We have been trying. But that's the reason why I say, majority of the times we may end up in having 1 or 2 stones left behind, because those are the inaccessible areas. Yesterday only, we counted on an X-ray 72 stones. And we saw that 72 stones have been identified. And we thought we had done a complete clearance. At the end of the day, we have another 6 stones inside. Count is wrong.
So would you consider in such cases, in such cases we have multiple faceted stone, to do a PCNL, remove all the stones and then do a palloplasty?
You do it either before or after. What difference it makes? It doesn't make any much difference if you do it after that also. That's one thing which I somehow get scared. I never tried it because even a
Lot of
simple,
edema will be
I
there,
tell
no?
you, simple RGP, a little pressure, you see a lot of
edema.
fluid around the ureter. I don't want a separation between the wall layers and the ureteric wall. Very simple. I don't want that wall layers. No, it will happen.
Not only that, sir, it gets very inflamed.
Inflamed, that's true.
Sir, we'll go for the, sir, you fall down.
No problem. Thank you, dear. Thank you.
We'll go for the next talk. I request Dr. Vyasnarayan Rao sir and Dr. K. Ramaraj sir to be chairperson for this session. Thank you, sir, for coming all the way.
Good evening, everybody. Good evening, everybody. You must have had a feast of pediatric urology this evening. Wonderful to have you here. We are thankful for your presence here and enlightening everybody about your vast experience in pediatric urology.
Thank you.
The keynote address is the topic is duplex kidney. It's a very important area. Complete duplication of the renal collecting system poses a lot of problems like infection, obstruction, vesico-ureteric reflux. Over to Dr. Mohan to enlighten us on this topic.
Thank you very much. Gopi was very clever. He chose the topic so he can start a lot of discussion in the room. So this is another topic, you could go either way. And you say, shall I do ureterocele incision? Shall I do heminephrectomy? Shall I do ureterostomy? What to do? If there is a reflux, it's a primary reflux, it's a secondary reflux. And anytime you do ureterocele incision and you start doing some bladder-based surgeries, the problem is what's the long-term bladder function? There are some children who still have neurogenic bladder. They are not able to void it. And these are very important things. And as you get into practice, 10 years, 20 years, you look at it and, my God, this is little bit thought process. So I think, what are we doing here? Why are we spending so much time here is because, we are all the surgeons, we are all physicians, we take care of children, we take care of patients. And the main aim is, can we reduce the morbidity? That, can we give one surgery and get the children out of the door and not make the patients? And that has been the aim, not only us, but, for all last 200 years, since, surgery has been so much vast practice around the world. Now, this is a simple case scenario here, ultrasound scan on an infant, and you all know what it looks like here. There's a bladder, and there's a ureterocele here, there's a big ureter dilated. That's the left kidney. You can see the lower pole. That's the upper pole here. And then you go and get a VCUG. And what I would want to pick up here is not only the ureterocele, not only the reflux, but my interest is how much of that ureterocele is affecting the detrusor muscle. Because this is very important for me. If I puncture the ureterocele, how much support is there, how the reflux will be generated. But at the same time, if I'm not puncturing, if I'm going to do excision or reimplant, how much close to is the bladder base? Am I going to disturb the neurovascular plexus, which is at the bladder base trigone? So that's why my eyes are looking at this rather than, just looking at the reflux and ureterocele. Now, as we talked about, every surgeon is right. Some may say, if there is no function, let's take the upper moiety out. Some say, if there is no function, just puncture it so that the system is draining. So what is our thought process here? The thought process here, as we talked about, we want to reduce the number of surgeries. We want to reduce the complications. And we want to think about the long term to preserve whatever the renal function these growing children have. And in turn, we helping not only the children, but also the family, because, both parents work nowadays. It's very hard. You can spend money, but taking time off is very difficult. Now, is DMSA scan required in all these children? I think there is a role because you can quantify function,
there is a fallacy because when system is dilated, but at least DMSA scan will help because the radioisotope binds to the cortical tubules, and that will give the good representation. So this patient we just saw, and you can see the upper moiety. I don't know how much function is there. The right side looks great, and we went ahead and did a puncture. Now when it comes to puncture, you have different ways. Some people use holmium laser, some people use cold knife, some do a big incision, while some do like a sieve, like multiple small incision. And this is all so that we can decrease the consequences of vesicular reflux, we can decrease the consequences of needing additional surgeries, but definitely they all need the prophylaxis. So what we did here is we took that upper moiety out, because when I looked at this DMSA scan, there was not much of a function, and took the upper moiety out. And when took the upper moiety out, we did a puncture, and then we did a puncture. This is what it looked like, and then this is a post-puncture scan. Again, there is not much of a function, but this is the reflux. Now the question comes, is this reflux is huge, and this is at the age of 2 years, is into lower moiety, is grade 4 and grade 5 reflux. This is another patient having a reflux into both the moieties, and when you look at the DMSA scan of this, there is some function here. So in this patient now, when you have a reflux into upper and lower moiety, and the upper moiety has some function, I think you're bound to do a common sheath reimplant, because you have to preserve both of these. Now when you do common sheath reimplant, you can absolutely do the open transvesical Cohen's reimplantation. It works beautifully. But we do know that there is a downside of that, of bladder spasms, possible temporary urinary retention, and hospitalization and stuff. So we've been doing this extravesical technique. Now we have done extravesical myself as well 25 years ago, and every patient we did open surgery went into urinary retention, especially the bilateral, and unilateral maybe 30-40%, and we didn't knew what was happening. But I think with the laparoscopic, not much report available, but robotic approach, I think what's happening is we're dissecting the ureter very close. And Dr. Chari just mentioned how to dissect the ureter, keep the vascularity, keep the adventitia. We're doing that. But also, when we coming to the uretrovesical junction, I think we're not going outside the area, especially the dorsomedial area where the neurovascular bundle is presumed to be, based on one study from out of Germany from Owen Fellner, who looked at it in cadavers. I think probably we're preserving that, and that's why I think this technique I gave an acronym of L, that is the length of detrusor tunnel is about 4 centimeter. We do a U-stitch after a wide dissection that advances the ureter, and then incorporate some of the adventitia into the ureter, and then put an apical alignment suture. And this has been used not only for unilateral reimplants, but also bilateral, for the common sheath reimplant, for the children with post-deflux failure, post-ureterocele incision. And I just want to show you the clip. So here, this is a patient summary here, and this is a duplex ureter. Let me go here. Okay. So if you see here, these ureters are really, and that's how these duplex ureters are. And you can mobilize those common sheath, as just below the pelvic brim, they are very together. So you can breathe, nicely mobilize, put an umbilical tape around. And as you go down, this is the area here, that's a vas deferens, and we're creating another window below the vas deferens and getting that umbilical tape below the vas deferens, and then we're trying to go and dissect the uretrovesical junction. So this is a bilateral reimplant. You can see the huge dilated tortuous ureters. The bladder is filled in, and then you do a detrusor muscle. This is just to lift up the bladder. So it's like an open book, so you can work on the posterior wall very well. So that's a detrusor tunnel, that's a U dissection. And we're trying to see how the ureter can align into the bladder so that you don't create an angulation or you don't create obstruction. Now, can we use this for open? I think it is very possible to use it open. Only thing is you have to dissect the ureter very close. You don't have to go too much lateral or medial. And we could try this now and see what happens. Means that could be one of the options because we learned it with our anatomy and what to do. So that's why I'm sharing this video, even if you don't want to do robotically. So this is the advancement suture or a U suture. Now when you do Cohen's reimplant, if you remember, you make the first suture through the whole detrusor muscle and put it through the ureter and you advance it. I think probably it's the same principle here. When you put that U suture, the ureteral orifice get advanced and probably that change the dynamics of ureteral orifice. And that's how the success is much better than previously when I did without this technique, the success was very poor. So that's how it looks like after reimplant. Okay, so then, you know, as we talked about, when there is no function, as this inpatient you see here, there's not much of a function, and you know, you're taking this upper portion out. Now, what about ureterostomy? North American have been very strong emphasis that, you know, the non-functioning upper moiety removal takes, you know, little bit of a risk, you know, taking those vessels, you know, dissecting those vessels. And the suggestion is, why can't you just, you know, join the upper ureter to the lower ureter? And that may be the option. And you could do open, you could do laparoscopically, you know, robotic is too much because, you know, it's such a simple operation. But then my question is, if it is a non-functioning, why you want to keep that non-functioning portion there? Because it does have some dysplastic element, and we don't know the long-term what happens with the renal hypertension, you know, all these things. So this study does show that if you leave the dysplastic element behind, when you follow them into adult life, there is a risk of renal hypertension. So if you look at our goals of management, then we need to think about, revisit it, you know, what we are doing, is it right, and what we should do. So my take is, you know, ureterostomy, even though it looks simple operation, the consequences are to the good moiety. You know, you are sacrificing a good ureter, good kidney for, you know, somebody being very, you know, cavalier. All right, and I think, you know, it's not really good. And then, you know, there are complications. As we talked about, any two tubes you join, there's a stricture, there's a stenosis, there's a leak, and you're still leaving the, you know, disease portion up there. So that's my take on it. Now, heminephrectomy is also without any problem. When we looked at open surgery from 1997 to 2003 and published it, we had about 10% of patients having decreased renal function of the remaining moiety and 5% of patients losing the remaining moiety. I think probably when you do open surgery, there's a lot of traction on the vessels you don't need, realize, and there may be renal vein thrombosis, and that may sets up, you know, damage to the lower moiety. What happens with the laparoscopic? Same thing. We looked at multi-center, 65 patients of pediatric heminephrectomy, and 5% had a similar problem. But again, you know, I'm not saying which is better, which is not better. And as I evolved into, when we started doing robotic, I think probably we're handling the vessels a little bit better, though you are used to having a lot of force, is inadvertent force. But probably that's the case, but, you know, maybe we got better. Now, I just want to show you the laparoscopic. When we were doing laparoscopic, this is from in early 2000, it was a posterior prone retroperitoneoscopic. It was great. You know, you get onto the vessels, you know, once you inside the gyrotous fascia, you know, you can get the vessels down, you know, you can get the ureter, you can do the upper pole heminephrectomy. It works really beautifully. And often we just did it with one laparoscopic instrument. So one camera and one instrument. And we named as a single instrument port laparoscopic nephrectomy. But the problem was, even I realized it myself when I did it, we were giving a lot of traction with the left hand to the normal renal hilum when we were trying to take the upper renal, upper moiety vessels. And I think that's where we may have caused some renal vein thrombosis or intimal tear, and we didn't realize it and lost some of the children, the remaining moiety. So that's why I wanted to share. If you are doing laparoscopically, most of you guys are expert. Just be cognizant, and if you are doing, that's great. But I just want to share so nobody gets this complication. So now, are we doing better? And why should we change? Especially in infants. Those who are, really dilated moieties, getting recurrent infection, they already have a problem, undergoing anesthesia, physiological consideration. And even technical, it gets very difficult. These infants doing a surgery, limited space, putting the ports is difficult. Now, one question we just talked about is retrograde. And retrograde doesn't help, because you put a stent into the lower moiety to identify the ureter, but when you put a 3 French stent, it's so difficult to see and to feel it, and that's why I think the retrograde or a stent doesn't help in those patients where you are thinking about doing heminephrectomy. It's additional procedure, instrumentation. I don't want to go through this position. You all know renal procedures, how to do it. But one instrument I want to talk about whenever you want to do is a harmonic scalpel. You can use bipolar forceps, you can use whatever heart current you have, but a harmonic scalpel really helps for removing the non-diseased portion. And often you can take the vessels very well in a small space, because putting a staplers, the problem is the tip of the staplers is too large and the vessels doesn't get caught up. Sometimes they slip up, and that's why harmonic really helps. I want to go, you don't have to show port in port technique. Now, what is a retrograde technique? When you want to do the heminephrectomy, you may be doing this, but what I want to say retrograde technique is, this is a lower moiety, this is upper moiety, and you are trying to remove the upper moiety. And the ways you can do this is you directly go to the vessels, take the upper moiety vessels, and then get the ureter and then do removal that portion. But what I tend to do is I cut the upper moiety ureter at lower pole of the kidney after identifying the lower pole ureter, and then pass that stump underneath the vessels and hold it as a retraction. Once you hold it as a retraction, then you can see the upper moiety vessels very well. And in that way, you could take those small vessels with a bipolar forceps, or you could take with a harmonic scalpel. So that's why I say retrograde technique, so that the ureter stump you passing behind the vessels, because there's a transperitoneal approach, and you hold the ureter, give a traction, and then you can remove the diseased portion out. So let's see the video clip here. This is the heminephrectomy. I think it was on the right side. These are the 2 ureters. You can see the distinct ureters, upper moiety and lower moiety, the caliber, the size. You are slowly separating them. So that's the lower moiety. This is upper moiety. This is the segment. And don't make a mistake of cutting this stump too low. Just cut it at lower pole so it's not too high, and then pass carefully underneath. Before I pass that, actually I make a space without the ureter, so I know in my mind how to go, where to go, how much space is there, and then pass the ureter carefully, so that you laid your path, and then you are walking on a path so that you know which path you are walking. So that's the ureter, and now with my assistant is holding the ureter, and then I'm taking the vessels down with the bipolar forceps, and in that way, usually, it's much better and easier. Now, don't get fooled that, usually there's one more set of vessel by default. So make sure that, whole moiety is purple, and then only use the harmonic scalpel. Now, when you put a harmonic scalpel, the upper moiety and lower moiety, they're usually like this, okay? So what you want to air is go into the upper moiety, so cut it here, renal cortex, as you see here, and then get into the pelvic calyceal system of the upper moiety. So in that way, you're not damaging the lower moiety, you're not entering the lower moiety pelvic calyceal system, and the problem of any inadvertent injury to the remaining moiety or the pelvis is much, much less. See, that's the upper moiety pelvis, and that will guide you that where to cut. So you always err on the upper moiety than the lower moiety. Leave that upper moiety calyx invading into the lower moiety, because it's not going to do anything. If you go too low, then you're going to enter into the normal lower moiety. So just, small tips, nuances, just to make you comfortable so you don't land into complications or troubles in the future. So that's how you do it. Now, another thing I want to share here is usually, we are dominant right-hand person. Let me stop this here. Right-hand dominant person, so always we use scissor on the right and, usually bipolar on the left. But when you're doing the right side renal surgery, transperitoneal, sometimes you may have to change the hands so that, you're holding the scissor on the left hand and bipolar on the right. And be careful if you are doing that, let your brain know that this is what you are doing. And why I did this here is, see, my scissor is on the right hand. I'm trying to dissect it. No, I think this is next video, sorry. Okay, so I'm trying to dissect it, and then as I'm dissecting it, I wanted to go and get those vessels down. And if you see now, my left hand is bipolar and my right hand is scissor. So I changed my hand so that I could do vessel identification better. So think about it ergonomically. Don't struggle too much. Don't put a traction on the blood vessels too much. And bipolar is much more adequate. Yeah, battery charge. Sorry. So I think, those small nuances will really help, thinking about the ergonomics, thinking about the handling. Why can't we take questions? I think the charger ran out. We're charging it. Give me a minute. We can take some questions while I'm doing this. Let's get this. So far, any questions about handling of the ureter, handling of the moiety, or puncture, how to puncture it, which are the methods to puncture? Any questions? Floor on the discussion. Yes, good question. So the upper moiety ureter, once I cut it at the lower pole, I go a little bit lower, track it down slowly until the pelvic brim. And beyond the pelvic brim, when you see that the common sheath is, really closely attached, I think at that stage you should stop dissecting further. Now, if it was a uretrosil, which is not punctured, I'll cut the stump and leave it open, all right? If it is cut and if it is refluxing, then I'll put a stainless steel clip and leave it. That's it. But I'm usually not much heroic to go below the pelvic brim because I know that I'm going to land into trouble of the lower moiety. Now, what is the possibility that they may come back with the recurrent urinary tract infection of that stump? And when we looked at it, it was about 8 to 10% of children will need it, secondary uretrectomy for secondary infection. Stump syndrome, you're absolutely right, yep. Dr. Reddy is here, Mallikarjun Reddy, I can use his laptop? No. Anybody has a Mac laptop, I can use it? Reddy is here, Dr. Reddy? Yeah, Mac laptop, okay. I think it's going to take us some time for charging, that's fine. Thanks.
It doesn't have that pin.
That pin, huh?
Doesn't
Okay.
have a C-pin.
Okay, then I have.
C-pin guard. C-pin guard.
Pen drive, sir.
Plans
hand if it is needed. And so I talked about, transaction of the moiety. Most of the time, there's not much of a clear demarcation. What happens is the upper moiety calyx is here, often it invades into the lower moiety, and the upper moiety is sitting like a cap, and the lower moiety comes in. So you cannot go like this. And the best thing is air on taking the renal cortex here, upper moiety, get into the pelvic-calyceal system, and then come out here. And if you leave that C-shape, whatever the calyceal system behind, is not a big problem. You can coagulate that epithelial surface and leave it open, and most of the time it's not issues. Look at some other, how difficult it is, the demarcation. Look at the DMSA scans. And when you ask the nuclear physicists, often they do this because they don't know where exactly the demarcation is. Now, we just talked about the ureter, and that was my next slide, when you have these dilated ureters.
Sorry to interrupt.
Yes.
I'll put up the charge also here.
Yes, please.
So that you can continue the thing
yes.
in this laptop without
yes.
interruption.
Yes, thank you. So that's about the ureter, and we talked about secondary ureterectomy. Now, are we doing better? That's always my question, about the complications, about success and morbidity. And this was a paper published a couple of years ago, and we had a grade 3 Clavian complication in one patient. And all the moieties have remained well. They were seen on the scan. This is a comparison of open versus robotic, the pediatric population, and you can look at the outcomes and perioperative outcomes, and they look really reasonable. Now, we talked about, upper tract versus lower tract approach, ureterostomy. Asim Shukla, one of my friend, some other people know here as well. And we looked at his series of ureterostomy and mine, upper polyheminephrectomy, and these are the perioperative outcomes. And the surgical time for heminephrectomy was much, much less. Don't know how come it was. But otherwise, it looked very reasonable, except the surgical time, and the complications in the heminephrectomy were also not different. Now, what about this cyst formation? You may see after heminephrectomy, the patients coming ultrasound scan showing some collection. And this is because that epithelial surface of the calyceal surface is left behind, is going to secrete some fluid, and then the edges also secrete some fluid, and that's what you see it. Most of the time these are asymptomatic, and till today I don't have to drain. They don't cause urine infection because it's not communicating with any pelvic calyceal system. Can you prevent it? Some people put a fat, omentum, they do like when you do partial nephrectomy, you put a bolsters and tie. I don't know, it's too much, and it's asymptomatic, so you can think about to do or not do. One of the complications I had about 3-4 years ago, I did a heminephrectomy, very difficult. I was actually doing for a workshop, and this patient's ultrasound scan here, she had a reflux, ectopic ureter, and that's the DMSA scan. And it was very difficult, and I haven't seen those number of vessels. It was very difficult, went well. It was a workshop case, no problem. But then she came back with this appearance. It was not like a simple cyst, it was echogenic material. And I said, maybe there is some blood collection, let's wait and see what happened. She came back again, 4 weeks repeat ultrasound scan, and it was increased a little bit, but when I did hemoglobin, her hemoglobin dropped. And I said, there's a bleeding into this cavity, and slowly she's accumulating, and actually I could feel it. She went to IR, they got the drain in that cavity, but there was no bleeding vessel, and subsequently she got better. So this was one complication I wanted to mention. That was one thing happened a couple years ago. Now, if you look at the Mark Lickler, our friend in Europe, when he has the biggest series of laparoscopic heminephrectomy,
there's a lot of conversion rate, not only his but other case series as well, just because it gets very difficult in these small patients, the vascular anatomy and everything. So that thing to think about if you are doing laparoscopically, be aware and be prepared about it. But if you are expert, that's not a big issue. So I think it's up to you what you want to make, upper tract or lower tract. My suggestion is if there is no function, I think, we should just remove it. Be careful when you take it out, not damage lower moiety. And if there is a function, then, depending on either it's refluxing or non-refluxing, work on the lower end. Try to stay away from the much of the bladder-based surgeries because there are 2 patients I still remember back in the days, early 2000, this have to catheterize to empty the bladder because, they developed a neurogenic bladder. So be careful and cognizant about that complication. So with that note, I want to just, take a minute, say thank you to all our collaborators, but a lot of our residents, fellows, team, they work really hard day in and day out. And I'm also grateful, a lot of teaching I could do because of the University of Chicago Delhi Center, who has a grants for, some teaching activities, but also for you guys, if you want to do some research, some collaborative work, that is a great boon. Now, last 1 minute I want to take before conclude is we as a surgeons are really powerful people in the community, and people don't understand how much you bring it to the nation's economy. And I hear a lot of the time, a lot of the complaints and stuff. But actually, all the World Health Organizations and the national economic bodies are taking that surgery should be made a priority as a global health. Because if you do surgery on children or young adults, they are productive member of the society, and it adds to trillions and trillions of dollars to the health economy. This is some of the work, through the UChicago grant we did in India and some of the Southeast Asia. And I'm really grateful for all the people, who work and help us this together. Small organization like us, we also contribute, most of you may be doing charitable work as well. And this is a way to go through, to help the communities who are in the need. So there's a lot of, we can do as a surgeon, not only our daily practice, but, we are an important member of the society, and we can help all our community building in. So I want to say thank you. I know it was, little bit, maybe I got delayed, but finally I made it here and I was able to share some of the thoughts. Thank you, Gopi, and thank you all. It was great seeing you all, and we'll keep working together.
Thank you, Mohan. It was such a wonderful talk on a very complex subject. But I would have been more happy if you just didn't give them a choice saying it's up to you. A non-functioning moiety should be removed.
It's very polite of me, nowadays you cannot, it's like my child, isn't it? I cannot say my child, go and do engineering, go and do doctorate. You can't do nowadays. Everybody is very thoughtful nowadays. You have to deal very thoughtful way, because what happens is there's a resentment if you say you have to do this, and you put it out there and say, this has worked better, this is what my results are, and I think probably it may be worth pursuing. I think that's the way I want to live it, but also I want to keep the option open, because what we have done now, what you have done, our predecessors have done, we are evolving, and I want to give all of them scope to evolve and maybe say, we were doing wrong, and that's why I want to keep it open. I don't want to close the chapter.
The thing is, you're putting a very large ureter onto a very small ureter, and then if this were to have some yo-yo reflux, and that gets infected, and you need to take it out subsequently, that ureter, where are you going to divide?
Correct.
I mean, you can't repair the ureterotomy that you made for the anastomosis.
Yes.
So you're actually inviting a lot of trouble by.
Yes.
Yeah.
I totally agree. That's why I'm saying you are jeopardizing or punishing a good person for bad behavior.
Too
that's
much diplomacy also is not good in life.
True. Yes. Yes. Jack.
I think this is a good point, but basically it entirely depends upon how do you see the transition between upper pole and the lower pole. and the transition between the two. Is it grossly dilated system? We jump on and doing it partial nephrectomy. And you've got a system which is Thibain-like and a thick parenchyma, not able to differentiate without a margin. You end up in doing a ureteric anastomosis. Because doing that job at that point of time is going to be more difficult.
Yeah.
In fact, I've retrospected around 10 patients of mine. I realized that my decision was oriented around how the kidney appeared rather than how the anatomy was.
Yeah.
Because the anatomy is same. The dilated ureter, one undilated ureter. It doesn't change.
Yeah.
That's exactly the point.
No. I think, that's what I'm saying, everything we do has a select group of population. And we evolve slowly that, now you evolve and, say, if it is not dilated, do UU. But again, when you do UU, you may be using 6-OPDS. Now, pyeloplasty, we have a good outcome because pelvis is large, ureter is large. But two ureters, putting together, looking at, there is a risk of anastomosis. So I think, if you are doing good work, you are a good surgeon, of course, I will leave it to you. But options keep open and select according to what's the best for the patient.
Thank you.
Thank you very much.
Thank you very much, sir. Thank you, Dr. Vyasnarayan Rao, sir, and Dr. K. Ramaraju. I think last 10-minute session, I would request Dr. Adil, Dr. Bhavtej, and Dr. Vishnuvardhan Reddy to please chair the session. I will start this. This is on the last session. This is a simple Cohen's reimplantation. It's an open surgery. I'll not go to indications and nothing. I'll straight away go to how do we do it. Lights off, yes, sir. Lights off. So, small fenestrial incision. I think with less and less of pediatric surgery, less and less of pediatric surgery, the lights off. Yeah, less and less of pediatric surgery. The exposure to these surgeries are decreasing. So I was just showing this surgery. So it's a small incision, fenestrial incision, and we have to mobilize this sheath properly, and then take a midline, take a midline incision on the muscles. This is not incision, just separation of this recti muscle here. And once we separate this recti, the bladder has to be made full so that it can be easily identified. Once the bladder is identified, the incision should not be so big that we have to use our hands inside. And bladder is opened vertically, and to get a good retraction, placement of these gauze pieces, most of the time we need to use 4 to 5 gauze pieces. We always feel that the ureteric orifice is very low down and we won't be able to reach it. It is not the it is not like that. The orifice you will always see is quite accessible, and a figure of 8 suture at the distal part so that the incision does not get increased, and then we place an infant feeding tube. Take a suture onto the infant feeding tube with the mucosa so that you can have a good retraction, and then we have to then mobilize the ureter. Till what level? In males, we have to mobilize the ureter till the level of the vas deferens, and in females, till we see some amount of fat there. And this mobilization, if you go to the correct plane, there will not be much of the bleeding and you would not be requiring much of coagulation. There will be small vessels which you will have to just coagulate. And how much is to be mobilized? We follow the Penguin's law here, depending on the diameter of the ureter, 1:5. So if the diameter of the ureter is around, say, 1 centimeter, then we mobilize around 5 centimeters or so. It's very easily mobilizable. We think that it is very difficult. No, it's not like that. So we'll just pull the ureter and mobilize it properly. And once this is properly mobilized, the bladder there has to be sutured back. Otherwise, it will cause divertical formation of divertical later on. So the bladder has to be properly, this hiatus has to be properly sutured. Most of the time we use a PDS to suture it. The mucosa also has to be sutured. So first the muscles there have to be sutured. The mucosa will be there. We can form a good tunnel through it. So this is where the suturing of the muscle is very important, so that later on the diverticuli formation does not happen. So if it's a bilateral reimplantation, both the sides, the ureter is mobilized, the muscles sutured there properly, and then see both the sides we have. You can appreciate that both the sides have been sutured. And then the formation of the mucosal tunnel. The tunnel formation is, this has to be done in a way that you don't come again and again, you don't perforate the mucosa again and again. The scissors should not be very sharp. A measurement scissors is the correct scissors, and around 5 times the diameter of the this thing has to be mobilized here, and the position of the new hiatus, the new orifice is to be planned here. Most of the time the planning is like this: one goes superficial, the other inferior to the other, the original orifice, and then the anastomosis is done. The anastomosis, again, you can use a 5-0 PDS or a Vicryl or a 4-0 PDS. It depends upon the age and the of the patient and how thick is the bladder, and a proper anastomosis is done. And then depending upon your choice, infant feeding tube can be passed through. Once we see the alignment and all, an infant feeding tube can be passed through to be kept as a DJ stent and can be brought out of the bladder like this here. Now you can stent just one of the ureters. Both the ureter stenting is not needed because some amount of edema will be there. So when you are doing a bilateral, one of the ureter needs to be stented with the infant feeding tube. We can avoid a DJ stent because again it would require removal. So like this you can just stent it and then remove it once the patient is settled, around 3 to 4 days. And bladder properly closed, drain is preferably kept. So this is a very simple surgery which can be done whenever indicated. A very small incision. My Cohen's this thing, and the results are also very good. Only thing is that later on when we require a uretenoscopy or there is some pathology in the ureter, a rigid scope would be difficult, but then nowadays the availability of the flexible scopes and all, I think this still remains one of the gold standard in dealing with reflux, especially grade 4 and grade 5 reflux. I'll not go into much detail. I think we have dinner also served now. We can have dinner. And then thank you very much. On a working day, so many of you have come. And again, I would like to thank all the seniors, Dr. Mohan, who has also taken time out in spite of his very busy schedule. I think since morning he is he's dead tired, I feel. Morning he has got down from flight and still not yet taken a bit of rest. So thank you very much, sir. Thank you, Dr. Mallikarjun, Dr. Vyas Narayan Rao, sir, Dr. Ramaraju, Dr. Pivulan Murthy, Dr. Ravi Kumar, Dr. Gopi Kishore, Dr. Surya Prakash, Dr. Srinivas, everyone, and all the students, DNB students, my colleagues who have come all the way. Thank you very much. And we'll close the session. Yeah, one photograph. Yeah, sir, we'll just have one group photograph and then we can disperse. I think he wants outside.